Hi everyone, I hope you are here and we can take a rapid revision. First of all, good afternoon, all of you. Good afternoon. I'm really happy to see you all. And let's start our rapid revision. What we'll do is we'll follow a sequence of the previous year questions that have come in pathology and then the explanations of that chapter wise. Is that okay with you guys? Is that okay with you guys? Good afternoon everyone. So shall we start? I hope you're doing well and I am happy to see you all as well. And really, today's December 5th and we are almost like 1 month and a few days away from the exam. So I hope that you are motivated. I know the stress is there, but let's take it one day at a time. And yes, like if you follow the questions, the notes, I think this gives you a very concise summary of pathology. And PDF, I'll send it after I annotate it. Is that all right? So look at the first question. Let's not take any more time. I know you all are busy. So look at the first question that was asked recently in your exam. Okay? Okay. Look at this. A 54-year-old man, you have long history of chronic GERD. Over-the-counter antacids were taken. There is abnormal mucosal changes in the distal esophagus consisted with Barrett's esophagus. So can anybody tell me what is this? When we talk about Barrett's esophagus, what is it? It is an adaptive change, that is metaplasia due to chronic irritation, and chronic irritation over here is acid. Now where is the metaplasia happening? In the esophagus. Now if you remember, in the esophagus, what kind of epithelium do you have? What kind of epithelium? We will cover whole of pathology. I don't want you to ask any questions. Just go with the flow. We'll cover whole of pathology. Try to cover it as concisely as possible, 6 to 7 hours. Okay, is that clear? So we have stratified squamous that changes to, very good, stratified squamous, which changes to intestinal columnar, because remember, your epithelium that can produce goblet cells is columnar epithelium, right? So it changes to intestinal columnar. So what is the answer? Is it intestinal type columnar epithelium containing goblet cells? Yes, it is A. What about B? You need goblet cell. Goblet cell is the hallmark of Barrett's esophagus. Hallmark cell of Barrett's esophagus, right? Can you tell me how do we stain goblet cell? We stain it with the help of Alcian blue, right? With Alcian blue. So Barrett's esophagus, one question that was asked in NEET PG 2024 was, they gave the endoscopic image where the salmon pink appearance was seen, right? You see on endoscopy, what appearance do you see? Salmon pink appearance, right? Now, with respect to your cell injury, remember each topic is important. 2 questions from cell injury, 100% come in your exam, right? So when you talk about adaptive changes, we have 4 adaptations: hypertrophy, hyperplasia, atrophy, and metaplasia. Now, when you talk about hypertrophy, it is an increase in size of the cells, while hyperplasia is an increase in number. Always look at the examples. Hypertrophy, what was the important example? We had HOCM. Okay, interventricular septum hypertrophy, which gives you a very nice banana appearance, right? Which gives you a very nice banana appearance. You can see this is the banana appearance. Then when you look at hyperplasia, what were the examples? One in female, it was an increase in hormones. Can anybody tell me the examples? We had endometrial hyperplasia. Endometrial hyperplasia, whenever you increase estrogen, right? Endometrial hyperplasia. And this can cause cancer, okay? This can lead to, over a period of time, you can have dysplasia leading to endometrial cancer type 1. Do you remember this? I hope you do. What was the second example? BPH, okay? Because of increase in DHT. So a stimulation, overstimulation of hormones can lead to hyperplasia. Remember, it can keep on. This can turn into cancer, right? Atrophy, this is a decrease. Whenever you don't use anything, there's a decrease in number and size of cells, decreasing the organ size. Okay, what will this do to the organ size? It will decrease it. Now examples, I'll show it to you. What about metaplasia? Very important. Usually metaplasia is what is asked. Transformation of one adult cell type or one tissue to another, right? And you have reprogramming of stem cells here. So this is also a previous year question that was asked. What you can see here, you can see that this is pseudo-stratified columnar epithelium, okay? This is the epithelium of your respiratory tract, right? So squamous metaplasia is the most common metaplasia that is seen in the respiratory tract. What was the epithelium earlier? Pseudo-stratified columnar epithelium. What is it changing into? It is changing into squamous metaplasia, right? Which is seen in smokers, yeah, vitamin A deficiency. What about this? This is your Alcian blue. What can you see here? You can see your Alcian blue staining the goblet cells, okay? Staining the goblet cells. Is that clear? What about this? You can see thenar, this is an example again of metaplasia where you have mesenchymal metaplasia, myositis ossificans. You can see that there is calcification in the muscle. What about this? This is your FMGE 2020 IBQ that came in the exam. What do you see? You see denervation atrophy. What is happening? There is nerve atrophy, okay? So what is lost? Muscles are lost in the thenar eminence, okay? Muscles are lost in the thenar eminence due to denervation, or yes, very good, median nerve palsy. Now here you can see starvation atrophy. You don't see any edema, so this must be marasmus. Remember, when we talk about starvation atrophy, we had marasmus as well as kwashiorkor. Kwashiorkor, what did we have in kwashiorkor? We had edema, right? We had edema. What about marasmus? There is no edema. More calorie loss. Here there is more protein loss. Okay, there is more protein loss. Is that clear? More protein loss. Very good, guys. Very good. Look at the next question now. This was a question that was asked recent in FMG 2020. Which of the following characteristics is a feature of Barrett's esophagus? Is it squamous metaplasia? Is it cuboidal metaplasia? Severe metaplasia? Yeah, intestinal metaplasia. So you can see it is actually intestinal metaplasia. Is that clear? It is intestinal metaplasia. All right, it is intestinal metaplasia. Let's go to reversible injury now. Like I said, you will do previous year questions chapter wise, right? So what do you see here? Which of the following cellular changes indicate irreversible injury? This was asked in FMG 2023. Now what do you see? I'll give you the PDF after this session, okay? So what is it? Yes, plasma membrane blebs happens in reversible injury. This is seen in reversible. Clumping can happen in both reversible as well as irreversible injury. Mild happens in reversible, while your severe, yeah, pycnosis happens in irreversible. And lysosomal membrane, they rupture, separation, not rupture of lysosomal membranes happen in reversible injury. Okay. What about this? Amorphous densities of calcium happens in irreversible, right? Now, when we talk about reversible injury, remember the biggest sign. What is the biggest sign of reversible injury? Cellular swelling. See, you are losing ATP. Because of that, what will happen? Your ATP pump will not work, and what will happen? Water will go inside, right? So cell will swell. What about irreversible? Now cell will break down, okay? It will be damaged completely. It will be ruptured cell membrane. So due to this damage, what happens? Due to the rupture of your membranes, all the membranes will start rupturing, and that ruptures the lysosomal membrane as well. So what will happen? This lysosome, once it ruptures, it leaks hydrolytic enzymes. Okay, it leaks hydrolytic enzymes, which will start damaging tissues nearby. Okay, damages tissue. And this damaged tissue, you want to remove it with the help of acute inflammation. Okay, with the help of acute inflammation. So everything swells in reversible injury. Remember, what about irreversible? Firstly, you see damaged, ruptured membrane, plus very, very important, you see calcium will always want to go inside the mitochondria. So large amorphous densities of calciums are seen in irreversible. And the nucleus, what is the morphological hallmark of irreversible injury? It is loss of nucleus. Okay, it is loss of nucleus. So how is the nucleus lost? Through 3 steps: pycnosis, karyolysis, and karyorexis. Pycnosis, karyolysis, and karyorexis. Okay, so pycnosis, it is clumping of the chromatid. Then you have karyorrhexis, which is fragmentation of the nucleus. And finally, the nucleus dissolves, which is known as karyolysis. Is that clear? Now, which of the following is not a sign of irreversible injury? You can see many times these are repeated. So this is very, very important. Please do not write again and again, ki PDF de do. I'll give you the annotated PDF after the lecture. Is that clear? So bar wahi same cheese doesn't make sense, na? Okay. So which of the following is not a sign of irreversible injury? 1 minute. Yeah, which is irreversible injury? So that is what? Blebbing of plasma membrane. आ गई PDF, ठीक है? देख लो live chat with, I mean, go to the Telegram group. I think PDF came there in the Telegram group. Just go. All right. Annotated PDF is in the Telegram group. Okay, जाओ जल्दी ले लो. ठीक है. Now look at the next question. Look at the next question. A 12-year-old child presents with a 15-day history of cough. Okay. On examination, cervical lymphadenopathy is noted. Biopsy reveals the following. So what do you see? You see that this is a type of cell death. Okay. What is happening here? This part is only eosinophilic. Okay. Only eosinophilic, meaning only pink, no nuclei. Do you see? There is no nuclei here. That means there is necrosis here. And which kind of necrosis? If you see in the periphery, what do you notice? That there is a cell with nuclei that are horseshoe appearance. So this is a Langhans giant cell. What is this? Langhans giant cell. Is that clear? Langhans giant cell. Okay? So this is nothing but caseous necrosis. Caseous necrosis. And where do we see this? Yeah, so this is your caseous necrosis. And where do you see this? You see it in TB. See, cervical lymphadenopathy, the most important characteristic is more than 14 days cough, right? Persistent cough for more than 14 days, right? This is your TB. Now TB, please remember, it has a very important cell known as Langhans giant cell. And you see caseating necrosis here. Okay? Yes, this is enough. You don't have time to learn entire patho, right? एक महीना बचा है आपका. ठीक है? So for this timing, it is enough. So TB, how do you rule out leprosy, sarcoidosis? Sarcoidosis, please remember, you have bilateral hilar lymphadenopathy. Okay, hilar lymphadenopathy. And you see naked granuloma, yeah, non-caseating granuloma. There will be no necrosis in the granuloma. Is that clear? Chalo. How to find it is Langhans? If they want you to have, like, they'll show you a giant cell with horseshoe appearance like this. This is your Langhans giant cell. Now look at the next question that came on the same topic. A chronic alcoholic with abdominal pain, vomiting, steatorrhea, weight loss and fatigue. Which type of necrosis is seen in this patient? Can anybody tell me? So you have a chronic alcoholic. What has this patient got? Can anybody tell me the diagnosis? Chronic alcoholic mein kya hota hai? There is pancreatitis, right? And you have, can anybody tell me what is released in pancreatitis? You have the release of lipase and amylase. Which is the most specific? Lipase. Okay, so what will lipase do? It will break down fats into free fatty acid wherever fat is present, peripancreatic fat, and then your omentum, it will break it down, right? So you have free fatty acids that bind to calcium. This is known as saponification. Which kind of necrosis is this? This is your fat necrosis. Okay, this is your fat necrosis. Is that clear? This is your fat necrosis. Now with respect to necrosis, How many types of necrosis do you have? You have your liquefactive, coagulative, caseous necrosis, fat and fibrinoid. With respect to which is the most common, remember solid organs may associated with ischemia. Which one is that? Which is associated with ischemia? Coagulative. It happens in all solid organs, okay? Most commonly the heart, right? Most commonly the heart, excluding the brain. Why? In the brain you have hydrolytic enzymes like and your microglia which liquefies everything, okay? So what happens in brain? Brain has liquefactive necrosis, abscesses wherever there is a lot of hydrolytic enzyme or neutrophilic activity or infections. Remember, liquefactive necrosis will happen. Now, caseous necrosis, you see it in tuberculosis, systemic fungal infections like histoplasmosis, coccidioidomycosis, okay? And fibrinoid necrosis, where is it seen? It is seen due to immune complexes like your type 3 hypersensitivity, okay? You can also see it in RHD, okay? It is associated with vasculitis or RHD. Is that clear? Now, these are some questions that have come in your exam. Look at coagulative necrosis. You will be able to see an infarct, a wedge-shaped infarct, okay? A wedge-shaped infarct. What about your liquefactive necrosis? Enzymatic digestion happens. So, remember, tissue architecture is maintained or lost? Tissue architecture. Does this brain look like anything next to it? Tissue architecture is lost. Very good. While it is maintained in the infarct, right? Tissue architecture is maintained in the coagulative necrosis. What about caseous necrosis? You can see this cheese-like appearance, right? Cheesy appearance. One of the biggest example is TB, right? One of the biggest example is TB. And what is the investigation of choice for TB? It is TB-NAT, right? CB-NAT. So what do you see on microscopy? You will be able to see giant cells, especially in TB. Can you see these giant cells which have which appearance? Horseshoe appearance. Okay, you will be able to see granuloma. Which kind of granuloma? Caseating granuloma. Okay. Fibrinoid necrosis, because the blood vessel wall is damaged, fibrin will leak out into the blood vessel, right? And you see this fibrin deposit. Very pink homogeneous deposit, all right, like seen in what? Malignant hypertension. Why? Because the pressure is damaging the blood vessel. Then you have PAN and RHD. Is that clear? What about fat necrosis? Causes can be enzymatic like pancreatitis, where you have lipase working on the fat, or non-enzymatic, where you beat down like breast, trauma to breast, or any other fatty tissue, right? So these causes fat necrosis. Gangrene, remember, it is a type of either coagulative necrosis or liquefactive necrosis. Now, with respect to coagulative necrosis, you can see a clear line of demarcation. Okay, clear line of demarcation. Okay, clear line of demarcation. Can you see why does this happen? Because there is ischemia to that organ. So whenever ischemia happens, what is associated with ischemia? Coagulative necrosis. Okay, coagulative necrosis. So which kind of gangrene is this? This is dry gangrene. Now, when we talk about what do you see in this tissue, you can see that it is shiny, it is edematous. Okay, it is shiny, it is edematous. So why has it had edema? Because there must be some kind of infection. Okay, and that is why there is no clear line of demarcation. Because there is edema, there is no clear line of demarcation. Now, one question that was asked in your INE set, can you tell me what is the answer for this? What happens, what are the features of necrosis? So you have to always differentiate between necrosis and apoptosis. Can you tell me the features? What are the features of necrosis? Is the cell membrane disrupted? Yes, this is the hallmark of irreversible injury. Does it induce inflammation? Yes. Can swelling happen? Can swelling happen? Yes, before. Please remember, before there is rupture, there is swelling. Is it physiological? It is never physiological. Remember, it is always pathological. What is necrosis? It is, I will kill you. ठीक है, मैं तो मरूंगा, I will die, but I will not die alone. I'll die by killing everyone else. Okay, so that kind of mentality, can it be ever physiological? मैं तो मरूंगा, पर सबको मार के मरूंगा. Can it be ever physiological? It is always pathological. Like, have you seen? You have some friends जो बोलते हैं कि मैं तो फेल होने वाला हूँ, पर मैं अकेली फेल क्यों हूँ? आपको भी फेल करके फेल होता हो. Have you seen such friends? ठीक है. Now look at this question. Next question. Remember, there will always be a question between necrosis or apoptosis. From the past 2 sessions, there were questions from apoptosis. So this time there can be necrosis, right? So tell me, which of the following features is not helpful in distinguishing necrosis from apoptosis? Can you tell me? Yes, you can. Yeah. Firstly, when you talk about necrosis, when you talk about apoptosis, how do you differentiate? How do you not differentiate? What is not helpful? Intact cell contents are present on apoptosis, right? They're present in apoptosis. What about intact plasma membrane? Yes, they are present in apoptosis. Where does lysosomal digestion happen? Where does lysosomal digestion? This happens in necrosis. But altered cell shape does not give you any, it is not helpful anyway to differentiate between necrosis or apoptosis. Is that clear? Is that clear? Now look at these questions that were asked. Which of the following is an anti-apoptotic factor? So very simple questions were asked between necrosis and apoptosis. Either you have a clinical case or one-liners like this, okay? Look at the way questions were asked, always, right? What do you see here? Can anybody tell me? Which of the following is an anti-apoptotic molecule? Anti-apoptotic, everything, lambi zindagi. Who gives you lambi zindagi? Everything with L. ठीक है? लंबी जिंदगी कौन देगा? जिसके पास L है, ठीक है? जिसके पास L है. तो MCL1. What about back and backs? Back and backs are apoptotic, while bad bimbid, bad puma, they are apoptotic sensors. Okay, they are sensors. While these are apoptotic, back and backs. Is that clear? In apoptosis, flipping is seen in. Flipping of what causes apoptosis? Matlab phosphatidyl serine. Okay, so this was asked in FMGE 2024. Which of the following are features of necrosis? This we have already discussed. What do apoptotic body contents? They contain all. Okay, they contain all. So let's just go through apoptosis. Firstly, remember there is an initiator phase and you have an execution phase. Initiator is divided into extrinsic and intrinsic pathway where you are activating. Remember what is apoptosis? What is apoptosis? Do not forget the definition. It is programmed cell death, right? Programmed cell death. And what is apoptosis mediated by? Can anybody tell me? Mediated by caspases. So what are you doing? These are proteasomes that you're activating. ठीक है? तो extrinsic में you activate 8 and 10. Caspase 9, if you read, 9 has in it, right? So you remember 9 is activated in intrinsic pathway. Finally, they activate 3, 6, 7 that activates endonuclease and protease. Finally, and remember, suicide. Remember, this is cell suicide. When we talk about necrosis, we talk about murder, while apoptosis is cell suicide. So suicide, can it be physiological? Remember, apoptosis is both physiological and pathological. Have you seen people dying for your country? तो क्या होता है ये? सुसाइड करते हैं आपके लिए, आप जैसे लोगों के लिए, ठीक है? तो हमारे आर्मी के जवान आपके लिए मरते हैं और आप क्या कर रहे हो? पढ़ाई तो हो नहीं रही आपसे, ठीक है? तो what factors help in apoptosis? See, we have pro-apoptotic, anti-apoptotic and BH3 only proteins. Okay, BH3 only proteins. Now, pro-apoptotic, remember the main two, back and backs. Anti-apoptotic, everything with L. Remember, लंबी जिंदगी किसकी होगी? जिसके पास L होगा. BCL2, MCL1, BCL, XL. Okay. What about BH3 only? What are the sensors? You have bimbid, PAD, Noxa, Puma. Okay. Now, when we talk about apoptosis and necrosis, how do you differentiate? Single cells. die through apoptosis. While necrosis, क्या बोलता है? I will die, but why should I die alone? I'll kill other cells that are next to me, right? Cellular shrinkage happens in apoptosis while cellular swelling happens, leading to rupture. Now here you have nuclear chromatin condensation where this undergoes pycnosis, karyorrhexis, karyolysis. Membrane is intact here while it is disrupted here. Enzymes leak out, that's why inflammation is present, but inflammation is absent here. This is a very, very important table. Okay, this is a very, very important table. Diagnosis, how do you diagnose? NXN5 is the marker of apoptosis, A for A. Molecular marker is CD95, which is for extrinsic pathway. Microscopic में क्या दिखता है? You can see nuclear chromatin condensation and the cell shrinks, okay? The cell shrinks, so it becomes darker in color. And on gel electrophoresis, can you see this step ladder pattern? Can you see this pattern? Where there is step ladder pattern? Yes? So this is seen in apoptosis, while smear pattern, see, this is seen in necrosis, okay? This pattern is seen in necrosis. Is that clear? Very good guys, very good. Syndactyly, this was an image-based question that was asked in your exam. Remember, if we cannot remove the cells here, they'll undergo fusion, leading to fusion of two digits called syndactyly, okay? Failure of apoptosis has happened here. One question that came in your INE set was interleukin-1 related death. So go through this. I just want you to look at the keyword here. Interleukin-1 related death, or the death that is related with fever. Caspase independent programmed cell death, necroptosis. Ferroptosis is what? Iron dependent death, okay, where you have increase in iron and glutathione peroxidase. What will happen? It will exhaust. Autophagy is when I eat myself, okay. Now look at this stain. Look at this stain. Can anybody tell me the stain here? Look at this question that was asked recently. The body of an 82-year-old man determine the cause of death. So look at the age, and they have given you cardiac tissue. Now in the cardiac tissue, what do you notice? Next to the nucleus, you have a golden brown pigment. Okay, you have a golden brown pigment. What is this pigment known as? This pigment, looking at the age, you can decide that this is lipofusion. Lipofusion, what is it? It is a perinuclear pigment. It is a perinuclear pigment. Which else is a brown pigment? Hemosiderin is also a brown pigment, but it is not perinuclear. Okay, it can also deposit in the heart, but it is not brown. It is not perinuclear. Okay, and melanin is also a brown pigment, brown black pigment, but it is present in the skin. Okay, in the epidermis, right? Is that clear? Okay. What about iron? Hemosiderin is nothing but oxidized iron. Look at all the questions that were asked from intracellular accumulation and stain related questions. So metastatic calcification occurs in all of the following except, this was a question that was given. So metastatic calcification, remember, it occurs where the tissues are normal tissue, but somehow the calcium levels are increased. Okay, you have increased serum calcium levels. Okay, so where do they like to deposit? Wherever there is a buffer. Where is the buffer? Where is the buffer of acid and pH? Acid and base. Where is the buffer? In your lungs. They like to deposit the most. Then your kidneys and the GIT. Okay, GIT. So kidney, stomach, pulmonary veins, but please remember dystrophic calcification. This is atheroma is nothing but dystrophic calcification. There is calcium deposits, but what is happening here? There is endothelial injury. So calcium will deposit. Tissue is abnormal. Okay, the tissue is abnormal. Tissue is abnormal. Now, which of the following stains is used to detect hemosiderin deposits? Hemosiderin is nothing but oxidized iron. Okay, which one? Fe3+. How do you stain it? With a very famous stain known as Pearl's Prussian blue. Very good. What about Mason Fontana? Is used to stain melanin. Very good. It is used to stain melanin. What about oil red O? Lipids. What about Sudan? Black. Again, lipid. Okay. This was asked in FMGE 2020 and 2024. Please do not forget 2024. All right. Very, very important question. Can you solve this for me? Can you solve this for me? I will have to take out names now. Anirudh, Carolyn, Karthik, Manvi, very good. Okay, tell me. A 50-year-old with fever, weight loss, cervical lymphadenopathy shows granulomatous inflammation. So what are they talking about? They are talking about something which is dead. Okay, tissue is dead. Dead tissue. So calcium will go and deposit there. So what is the calcium? The calcium is normal here. Okay, normal calcium levels. Normal calcium levels. Okay, so what is this? This is nothing but dystrophic calcification with normal serum calcium levels. Okay, normal, very good, very good. So these are the stains that you need to go through before your exam. Okay, these are the stains that you need to go through. They're very, very important for your exams. They're all written here. Just go through them. Remember melanin, you have Mason-Fontana, lipofusion. Like I told you, lipo is nothing but lipid, right? So it can be stained by ZN long stain or oil red O. Hemosiderin, we have very famous pearls, Prussian blue. Lipids, again famous, oil red O, Sudan black B. Copper, you have rubinic acid and rhodonine. Calcium, again important. Alizarin red and Voncosa. So these are the stains that are important that can come in your exam. And I've already also written down gram stain, ZN stain, so you can go through this. This was asked very recently in the exam, triphenyl tetrazolium fluoride, which stains myocardial infarction. Okay, it stains myocardial tissue. All right. Now hematology, these are the stains for, this is very important, PAS stain and TdT. TdT is for lymphoblast. Okay, go through the stains. You have to by heart the stains because they are asked very, very frequently. And even questions now in hematology depend on these stains. Is that clear? All right. Look at this. This is actually cholesterolysis of gallbladder. What is this? Cholesterolysis of gallbladder. All right. This is lipid accumulation, cholesterol accumulation. This is also known as strawberry gallbladder. Okay. What is it also known as? Strawberry gallbladder. What about this? These are cholesterol clefts. Cholesterol clefts. Okay. This is actually cholesterol accumulation in the connective tissue known as xanthoma. Is that clear? How do you stain lipids? With oil red O. This is your oil red O and Sudan black B. Sudan black B. Okay. Sudan black B. What about this? This is your myocyte. Next to it, this perinuclear pigment. What is this? This is your brown pigment known as lipofusion. This is a stain that is metachromatic. This actually stains your, what do you say, basophils or mast cells. So this is your toluidine blue. Okay, toluidine blue. Stains mast cells. Mast cells. Yeah, which are this? Basophils in blood and mast cell in tissue. They are both the same, right? What about this? This is your Pearl's Prussian blue. Pearl's Prussian blue. Okay. What about this? This is actually a hepatocyte. You can see it has swollen up. So it's pointing towards reversible injury. So this is seen in alcoholic liver disease where you have this pink homogeneous material, right? That is nothing but cytokeratin. What is it? Cytokeratin 818. Okay. Alcoholic liver disease. This is known as which body? Mallory-Denk body. Okay. Mallory-Denk body. And what about this? This you can see inside the cells. What do you see? You see PAS positive and diastase sensitive. What is PAS positive and diastase sensitive? It is your glycogen. So glycogen can store, whenever you have glycogen storage diseases like von Gerke, glycogen can accumulate, right? So how do you stain glycogen? With PAS. And you can remove it with diastase. Okay, that's why it is known as diastase sensitive. Now this is your skin. What do you see in the skin? You can see at the stratum basale, what can you see? That there is a blackish color, right? This is nothing but your Mason-Fontana. And what does Mason-Fontana do? It stains melanin. Okay, it stains melanin. Is that clear? And this, you can see your bile duct. Around them there is fibrosis. What is this blue color? This is collagen. Okay, collagen. What happens? It is nothing but fibrosis. And how do you stain collagen? It stains blue with the help of which stain? Mason trichome. Okay, Mason trichome. Mason trichome. Remember, triple helix is your collagen structure. So Mason trichome. Mason Fontana for melanin. Okay. What about this one? This is your calcium, and calcium is stained by von Cosa. Okay, von Cosa. How do you know this is calcium? This is not lipid, because calcium does not have any shape. So it can be amorphous. It is amorphous. It does not have any shape. But when you look at lipid, they are clear vacuoles, right? They are vacuolar in shape. All right. Now, with respect to calcium, this table is very, very, very important, and very, very famously asked. Alizarin red is also there. Von Cosa is a black stain. Okay. Calcium. There are two stains. Remember, calcium on H&E appears blue. Okay, amorphous blue. Is that clear? Are you guys with me? Are you guys with me? हो मेरे साथ हो अभी भी? Are you still with me? Anirudh, Raj. Okay. So calcium accumulation. Remember, metastatic calcification, when we talk, serum calcium is high. And these are the causes. While when we talk about dystrophic calcification, the calcium is normal. But what is the problem? Here, tissue is normal. Okay, tissue is normal. Do not forget this. What is the problem? Serum calcium is high, so it will go from blood and accumulate in tissues. But here, the tissue is dead. Okay, dead, degenerated or damaged. Degenerated or damaged. Is that clear? Is that clear? So, these examples very, very important, and your Samoma bodies are the most, I think everybody here knows Samoma body. Hello Bhavishit. Hello, hi. Yeah, everybody knows your Samoma bodies. So they are nothing but concentric lamellations of calcium. Okay, so where are they seen is a question that is very frequently asked. Is that clear? So dystrophic calcification, remember Samoma body. Also, very recently meningioma was asked. Papillary thyroid carcinoma is always asked. Okay? Free radicals, these are your free radicals. Go through them. What are against free radicals? You have antioxidants. These are your antioxidants. Okay? One question that came with respect to aging. Okay? Choose the correct statement regarding the telomerase theory of aging. Can anybody tell me the answer? Telomere stability is associated with aging. Abnormal telomerase activation is associated. Decreased telomere length is associated with aging. Increased telomere length. What is the answer? Can anybody tell me? It is decreased telomere length. Okay. What does telomerase do? It maintains the length. Okay. What does telomerase do? It maintains the length. Okay. And how do you stay young and don't age faster? The best method is calorie restriction by 30%. Okay. That has come in the exam. One defect in aging, it is your Werner syndrome, which is DNA helicase defect. Okay. There is damage to the DNA. Now, which of the following is associated with an increased lifespan? Like I told you, which is the best? Decrease intake in calories by 30%. Okay, by 30%. Very good. Which enzyme is responsible for immortality of cancer? Very, very important. It is telomerase that maintains the length of the telomeres. Okay, what does telomerase do? It maintains length. Okay, it maintains length of telomeres. Do you remember what are telomeres? They are present at the terminal ends. I'm a very good artist, so yeah, I think many of you know already. So I'm a very good artist. See, this is your chromosome. Where are telomeres present? At the terminal ends. Okay, at the terminal end. Is that clear? All right. Let's go to the next chapter. Now, inflammation. Whenever we talk about inflammation, do you remember? We will first solve questions. Okay, which of the following molecules helps in the adhesion of the leukocyte to the endothelium during inflammation? Can anybody tell me? Which one helps? Which one helps? Are you guys with me? Yeah. Which one helps? Endothelium during inflammation? Yes, it is your adhesion, right? Adhesion. So adhesion happens due to, so you have weak adhesion, which is nothing but rolling, right? You attach and detach. And then you have what? Can anybody tell me? You have, can anybody tell me? Strong adhesion or firm adhesion, which is mediated by integrins. Okay, which is mediated by integrins. We don't have integrins here, but P-selectin, selectins, where are they present? P-selectin. They are asking you leukocyte to the endothelium, you have P-selectin. Is that clear? Very good. Okay, very good. Most effective enzyme in acute inflammation, which is that? NADPH oxidase. NADPH oxidase. Okay, it is your NADPH oxidase. Okay, it is your NADPH oxidase. All right, let's look at the events. Very, very important for your exam. The events during inflammation. You have vascular events and you have your cellular events. When we talk about vascular events, you have vasoconstriction, vasodilation, vascular permeability, and stasis. Which of these, which is the hallmark of acute inflammation? It is your increased vascular permeability. Remember, which kind of fluid comes out? It is exudate. And it involves post-capillary venules, okay, due to damage to the endothelial cell because of endothelial cell contraction. Now, when we talk about cellular events, we have margination, rolling, adhesion, transmigration, chemotaxis, opsonization, and phagocytosis. Margination, why does it happen? Because of stasis. Rolling, you have attachment with the endothelium to the leukocyte, right? Selectins on the endothelium, ENP, which binds to Salil Lewis X on the leukocytes, right? Adhesion, you have firm attachment of WBC to the endothelium mediated by integrins, okay, on leukocyte binding to ICAM and VCAM. Transmigration, you have to go from the endothelium outside. So how do you do that? PCAM1 or CD31. Chemotaxis is when you go towards the offending agent. What is inflammation? You're going to remove the offending agent. How do you remove? You make the leukocyte go from the blood vessel to the tissues where there is the offending agent present, right? So how do you do that? These are the cellular events, okay? These are the cellular events to do that. Chemotaxis is unidirectional movement. This was a previous year question. And what are your chemotactic agents? What are your chemotactic agents? You have C5A, LTB4, 458. Okay, remember 458. LTB4, C5A, AJA, okay, AJA, and interleukin 8. It's a chemoattractant, right? It attracts the WBC towards the bacteria or the offending agent. What is opsonization? You're making the bacteria very tasty or the offending agent very tasty by coating it, okay? By coating it. What do you coat it with? C3b, the most important, and IgG, which is very, very important for opsonization, okay? The most important immunoglobulin for your opsonization, very important. Now, phagocytosis, you eat the bacteria. How do you eat bacteria? And what do? You will kill it. How do you kill it? With oxygen-dependent pathway, okay? With oxygen-dependent pathway. This is the most potent form of killing. And what enzyme do you use? NADPH oxidase, which has come in your exam, okay? And you have also what? You have formation of free radicals that kill the offending agent. Is that clear? Is that clear? Nets, a question had come from Nets. This is killing outside, killing happening extracellularly, okay? Killing outside. Phagocytosis is when you kill inside, right? When you kill inside the leukocyte. What is Nets? It is neutrophilic extracellular traps. So what will the neutrophil do? It will, if it's not able to kill, if it is not able to take in this organism, what will it do? It will send its trap outside, okay? It will send its chromatin, or it will expose, it will decondense its chromatin outside. For this, you need arginine, okay? For this, you need arginine, and you have an antimicrobial site outside extracellularly, okay? So this is what NETS is. It's beneficial suicide where DNA fibers are, they trap and kill microbes, okay? What do? They form but since you have exposed your nuclear chromatin, there can be formation of anti-nuclear antibodies that associates it with SLE. Is that clear? Okay, very good. Now look at this question that was asked in your exam. Which of the following statement is not true about neutrophilic extracellular traps? Can you answer this for me? Can you answer this for me? They prevent the spread of microbes by trapping them in fibrils. Nuclear chromatin in the nets may act as a source of nuclear antigen in SLE. Yes, this is also true. Neutrophilic activation may lead to the formation of nets in circulation. Pathogenic sepsis, this is also true. Undergo phagocytosis? No, phagocytosis is inside the cell, right? Inside the cell. But this is extracellular traps. Right? It is extracellular traps. So this does not happen inside the cell, this happens outside the cell. Is that clear? Okay, great guys. I'm so happy with you. Now these are disorders of your phagocytosis. Let's do a question before we answer it. See, these were the questions that were asked from disorders of inflammation. Can anybody tell me the answer of the first one? Which blood group can be given to a patient with Bombay blood group? Which blood can be given to a patient with Bombay blood group? So Bombay blood group is seen in LAT2, leukocyte adhesion defect 2, okay, where you have missing H antigen, right? Now if you don't have H antigen, you don't have any exposure to A antigen, B antigen or H antigen, right? So you will make antibodies against all three. So what blood can be safely transfused? OH only, okay? If this is not in the options, then choose O negative. Is that clear? Now, when we talk about the second question that was asked, a 7-month-old boy present with a 2-day history of fever and abscesses over the neck. Similar dihydroamine test is positive, which is the most likely diagnosis. So, see guys, look at this. This is your CHD. Chronic granulomatous disease, okay, chronic granulomatous disease, which is CGD, right? CGD. Always remember, CGD happens because of, CGD people are more susceptible to catalase positive organism, okay? There is formation of granuloma. You can't remove the organism. So what will your body do? Make granulomas. Which test is very important or investigation of choice? DHR, which is a screening test, NBT. And what is the defect? CGT is a 3-letter word. The defect is a 4-letter gene. Fox gene defect, okay? Fox gene defect. Will you remember this? Fox gene defect, right? So this is nothing but your CGD. Remember the keywords which are important for the exam, and the keywords will come in the exam whenever there are clinical questions. Pray that you have clinical question, because a lot of keywords will be present in the clinical question to solve it, right? Now look at this quickly. What is the pathogenesis of CGD? Just now I told you it's a Fox gene defect. And which gene? This gene codes for which enzyme? NADPH oxidase. NADPH oxidase, right? It is mainly X-linked recessive, and you have, what do you say, recurrent infections from which organism? Catalase positive. DHR is investigation of choice. When we talk about Shinya Hikashi, I told you to remember it as China P, right? China P. What is China P? Shinya has huge granules. Okay, what does it do? It has huge granules and recurrent infections. Then you have neurological delay, or milestones are not reached, right? Neurological delay, delayed milestones, and there is oculocutaneous albinism. So there is China P. What is P? There is phagolysosomal defect, okay, leading to what else? Bleeding. Even platelets are affected, so it leads to bleeding. Is that clear? So remember Shiryak Higashi is China P. This guy will have silvery grey hair, okay? This guy will have silvery grey hair. Silvery grey hair. Is that clear? Good, good guys, very good. Brutins came in June 2024, okay? Again, important. Brutins, what is it? It is X-linked recessive. So it is present only in boys. It's a B cell defect. Maturation of B cell is affected. So your immunoglobulins will not be made. That is why it is known as agamma-globinemia or hypogamma-globinemia. Okay, results in defective opsonization, because which is the most important opsonin? You have IgG, right? You need immunoglobulin G for opsonization. That is defective. That came in your exam. BTK, Brutin, B cell, boys. Okay, LAD1 and LAD2. See, LAD1 is beta integrin, while LAD2 is a defect in Salai Lewis X. Okay, defective here, both of them will show absence of pus formation. Okay, and here you have a special characteristic which is delayed separation of cord. Okay, very good. Yes, and yes, this phagolysosomal defect is list gene defect. Okay, list gene is defective. Let's go to inflammatory mediators. Now, when we talk about inflammatory mediators, we have something which is already made, something which is freshly made, right? So, what are preformed mediators which are already there? Your lysosomal enzyme, histamine, serotonin. So, when we talk about histamine, these are the highest concentration in mast cells, okay? And they cause vasodilation, bronchoconstriction, and increased vascular permeability. While when we talk about serotonin, they are derived from tryptophan, present in platelets, and enterochromaffin. Role in inflammation doesn't matter, right? So look at this question. A child, upon disturbing a beehive, has several stings. After a few minutes, the child develops symptoms of shock, respiratory failure, and vascular collapse. What happened to this child? He went into, can anybody tell me the diagnosis? Anirudh, Subiksha. Can you tell me the diagnosis, guys? What is happening to this child? He has anaphylactic shock. Very good, anaphylactic shock. Okay, anaphylactic shock. Okay, so what is anaphylactic shock? Mediated by mast cells. Mast cell degranulate what? Histamine. Okay, very, very important. Okay, histamine is very important. So preformed mediator will come very fast. What about arachidonic acid? You know arachidonic acid goes into two pathways. Which one? LOX and COX. Do you remember this? LOX and COX, right? LOX and COX. So COX gives you prostaglandins, while LOX gives you leukotrienes, right? So prostacyclin is a part of prostaglandins, right? It causes vasodilation, while your E2, F2. When we talk about PGE2, that is the one causing fever and pain. Thromboxane A2, it's just opposite to prostacyclin, okay? And when we talk about leukotrienes, please remember they are bronchoconstricted, but they are more potent. They are more potent than histamine. More potent than histamine. Interleukins important again. बहुत सारे one-liners आते हैं इससे, right? So you have interleukin 1, TNF alpha, interleukin 6. All of them cause fever. Which is the most important in fever? Can anybody tell me? Lecture notes, you can just go to Bhanu sir's channel on Telegram. Okay, the notes are there. All right. Which is the most important? Medicine U6V. Okay, interleukin 1. If I ask about fever, now just now I told you one death associated with interleukin 1. Can you tell me that also? Can you tell me that also? One death that is associated with interleukin 1. It is pyroptosis. Do you remember? I hope you are following through. Okay. Yes, pyroptosis. Now, when we talk about interleukin 3, you just turn. It is myeloid cell proliferation. Interleukin 4 and 5 involves something with E, right? 4 is a protein, while 5 is eosinophil. Okay. What about your 7? Just turn. It is lymphoid cell proliferation. Neutrophil, interleukin 8, important. What does it do? It eats, right? What does it eat? What does interleukin 8 do? It attracts neutrophils. Okay. and interleukin 10 TGF beta, they are anti-inflammatory. Always remember TIL for anti-inflammatory. What is TIL? TGF beta. Remember, TGF beta causes it causes fibrosis, right? Fibrosis is nothing but a form of repair. Okay, so they are involved in repair or anti-inflammation. Interleukin 10. And how do you add interleukin 10? Interleukin 4 plus interleukin 6 gives you 10, right? So these are the interleukin that cause anti-inflammation. And lipoxins. TIL is what causes anti-inflammation. Okay, what is anti-inflammation? TGF beta, interleukin 10, 4, 6 and lipoxins. So look at these questions that were asked in your exam. Which of the following is a mediator of chronic inflammation? Can you tell me? Is it interleukin 1, interleukin 6, TNF alpha or TGF beta? So what is chronic inflammation? It is when you have inflammation and repair happening simultaneously. Okay, so chronic inflammation is when you have tissue destruction and tissue repair happening simultaneously. So they are literally asking you, where do you see tissue repair? Okay, so what is it? Yes, TGF beta. TGF beta. You see tissue repair as well as what do you call it? Tissue destruction. Now a patient with COPD presents with ARDS like symptoms. ARDS is, what is the most important cytokine? What is the most important cell in ARDS? It is neutrophil. It is the recruitment of neutrophil. And how do you call neutrophil? Can anybody tell me, how do you call neutrophils? How do you call neutrophils? You call them with the help of interleukin 8. Okay, interleukin 8. They are cytokines that recruit neutrophil. Okay, macrophage activation. Who does macrophage activation? It is interferon gamma. Okay, it is interferon gamma. Interleukin 1 causes fever. What about interleukin 6? It mediates acute phase reactants. Okay, is that clear? Now with respect to acute phase reactant, these are things that increases during inflammation or decreases during inflammation. These are proteins, right? That can either increase or decrease during inflammation. Now with respect to your, exam, what had come in your exam? They had asked you which of the following is a negative acute phase reactants. Like look at this, which of the following is decreased in acute inflammation? Can you tell me which is decreased? Remember NAT, okay? Remember ATT, negative is nothing but ATT. What is ATT? Albumin, transthyretin, transferrin. Just remember the negatives, okay? Just remember the negatives. So can you tell me the answer now? Subhalakshmi, can you tell me the answer now? Yeah. So you have, yes, negative is nothing but albumin. Everything else is positive, okay? Everything else is positive. Deficiency of complement. All of them are previous year questions, especially MAC deficiency came in NEET PG 2023. Okay, 2023. So let's look at what happens whenever there is a deficiency. If there is a deficiency of complement inhibitor, right? So C1 esterase inhibitor, it inhibits C1q. Now you don't have the inhibitor. What will happen? I always told you between a good friend and a bad friend. What if you don't have the good friend? What will happen to you? You will be free, right? What if you don't have your parents stopping you from doing anything wrong? What will you do? Aap avara ban jaoge, avara angara, right? So all these toxic. So do you want to become that? Do you need parents to stop you? So just imagine you don't have the inhibitor of complement. What will happen? Overactivity of complement. So C1 esterase inhibitor leads to hereditary neurotic, angineurotic edema. What about early complement? If you don't have these leads to SLE. MAC deficiency, which is nothing but C5b2, C9, these are very, very important for causing cell lysis. Now, you don't have MAC, you cannot cause cell lysis of specially encapsulated organisms, okay? Infection from encapsulated organism like Neisseria, okay? CD55, CD59 protect RBC platelets and your, RBC platelet and your leukocyte from complements. So you don't have that, all three of them will be destroyed, leading to PNH, paroxysmal nocturnal hematuria. Factor H and I will cause atypical hemolytic uremic syndrome. Okay, factor H and I are again inhibitors of complement. Is that clear? Is that clear? Are you with me? Are you guys with me? Yeah? Are you guys with me? Hello? Okay. So chronic inflammation, what did I tell you? It's a prolonged inflammation where you have tissue destruction as well as tissue repair. Both happen together. Okay? Damage bhi ho raha hai, repair bhi ho raha hai. I'll give you an example, something that is very personal to me. My father has rheumatoid arthritis. Do we have a cure for rheumatoid arthritis? Anirudh, Manvi, Regen, do we have a cure? What is the cure? Can you eradicate rheumatoid arthritis? Can you eradicate it? Yes or no? Yes? No, you have to take immunosuppressants, right? So my father has rheumatoid arthritis. So will he have it only for a short period of time, or is it an ongoing process? It's an ongoing process, right? So here what happens, you cannot remove this. So there will be, whenever there is, what is rheumatoid arthritis? It is a kind of autoimmune disorder where your own body attacks your own body. So there is inflammation, right? So to repair the tissues that are destructed by this inflammation, you have repair. Okay, so tissue repair and destruction happening at the same time is chronic inflammation. Is that clear? Is that clear? So the most important leukocyte here is your macrophage. Macrophage are different in different organ, like in brain it is known as microglial cell, lungs it is known as dust cell, Kupffer cells in liver. So that was the question that was asked. What are the macrophages in the liver known as? What are the macrophages in the liver known as? Can anybody tell me? What are the macrophages in the liver known as? It is known as your Kupffer cells. Is that clear? They are known as Kupffer cells. Now you have a kind of, what do you say? Granulomatous inflammation is a kind of chronic inflammation. You have caseating granuloma and non-caseating granuloma. Examples are very important. Look at the examples. TB happens in both, but if you have to choose, always choose caseating. What about sarcoidosis? Happens in both, but if you have to choose non-caseating granuloma. You see stellate granuloma, you can see a star-shaped granuloma. This is present. This is due to Bartonella Hensley, seen in cat scratch disease, or LGV, right? Dirk's granuloma, donut granuloma, these are all granulomas that are important. Naked granuloma is seen in sarcoidosis. What granuloma? Naked granuloma. Okay? Naked granuloma. Yeah, good. Now what about special giant cells? You have Langhans giant cells. I told you which appearance is this. This is horseshoe appearance, right? Horseshoe appearance. Where do you see Langhans giant cell? Mainly TB. Rutin is seen in xanthoma, where you have lipid, okay? Where you have lipid vacuolation, right? This is nothing but a giant cell. Warthin-Finkeldied giant cell. Do you remember what is this? Where you see intranuclear inclusions as well as intracytoplasmic inclusions, okay? So measles, it is seen in what? It is seen in measles. So measles, do you remember the keywords of measles? Can anybody tell me? Anirudh, Alia, Pratyush. Measles, the 3 C's, cough, coryza and conjunctivitis. And what else do you have in measles? Koplik spots, right? Very good, very good. So remember, there are only two diseases which shows both inclusions, intracytoplasmic as well as intranuclear, CMV and measles. Questions come from there, definitely. Now, when we talk about your foreign giant cell, you can see haphazard arrangement. This is actually Reed-Sternberg cell, where you have what? You have eosinophilic eyes. Eosinophilic eyes. Okay, eosinophilic eyes. The eyes, it is owl eye appearance. Okay, so you see owl eye appearance in CMV as well as in Hodgkin's lymphoma. Okay, this is seen in Hodgkin's lymphoma. How do you differentiate? Pink eyes are seen in HL. What about blue eyes? BC, remember? Blue eyes are seen in CMV. And where do you see CMV? Can anybody tell me? कोई मुझे बता सकता है जल्दी जल्दी CMV कहाँ दिखता है? CMV, where do we see CMV? We see it in, yes, owl eye appearance. You can see, like I told you, there are both intracytoplasmic as well as intranuclear inclusions, right? You have blue eyes here and you see them in immunosuppressive patients. This infection is seen in immunosuppressive post-transplant patients, right? Yeah, post-transplant, very famous post-transplant. What is the choice? What do you say? Drug of choice? Ganciclovir, right? Very good. Ganciclovir. Very good, guys. Very good. Now, these are some other special points, some other, what do you say, bodies. Go through them, very important. All of them are previous year questions and a part of, integrating with derma as well. See, this was given in FMGE 2024 as well as NEET PG 2024. Tell me what is the answer for this. So, instead of two eyes here, see, you have two eyes, right? You either have blue eyes or it can be like this also. So, what is this? This is your CMV. Very good. This is your cytomegalovirus. Okay, so only one eye they are showing you, but again the same concept is there. Blue eyes, basophilic eyes are there. Okay, is that clear? Reed Sternberg में pink eyes होगा ना? So this is not Reed Sternberg. See, you can see basophilic eyes, right? Reed Sternberg, here I have shown you how are the eyes. They are eosinophilic. Okay, the eyes are eosinophilic. Is that clear? चलेगा? चलो आगे बढ़ते हैं. Look at this question. Tell me the answer of this. A 30-year-old patient presents with a 1-month history of pain in the left knee. X-ray shows a 5 centimeter mass in the distal femoral epiphysis. So bubble appearance is there. Microscopy is, so epiphyseal tumor. Just by looking at it, epiphyseal tumor, you must have heard of ECG. What is the epiphyseal tumor? You have giant cell tumor. Okay, giant cell tumor. Now, where is this happening? In the bone. What is the giant cell of the bone known as? It is known as osteoclast. Okay, so this is osteoclastoma, right? Osteoclastoma. Do you get it? Osteoclastoma. It is nothing but your giant cell tumor which has soap bubble appearance. Very, very famous integration with orthopedics, right? Chalo, good. Look at the next question. A transbronchial biopsy of a patient with fever, cough, weight loss is given. Granulomatous inflammation. Which chemical mediator is involved in its pathogenesis? So granulomatous inflammation matlab, what is the most important leukocyte? जब भी मैं बोलूँ chronic inflammation या granulomatous, which is the leukocyte that you want? Macrophage. And who attracts macrophage or activates macrophage? It is interferon gamma. Okay, gamma. What did I tell you about gamma? What does it do? It activates macrophage. What does it do? It activates macrophage which forms a granuloma. Okay, so it is telling you, gamma बोल रहा है आपको कि मैं ऐसा करता हूँ, ठीक है? तो उसको सुनो. The best thing you can do in your life is listen, right? You have to listen to things. ये बोलते सब है, सुनना, that is more important, right? चलो, are we done? Now wound healing changes जब whenever there is tissue destruction, your heart broke, there will always be repair. ठीक है, wound healing होगी. So dates, the timeline matters. 0, 1, 3, 5, second week. End of second week या starting of third week, and then you have 28 days, right? So what happens on day 0? किसी ने काट दिया आपको, तो क्या होगा? Definitely you would want to stop the blood, right? या नहीं बहने दो, मत जाते हैं, ऐसे जोन में हो आप, ठीक है? तो यहाँ पर खून रोकना है या नहीं रोकना? रोकना है ना? तो what will happen? Clots will form. Who will come? Which is the first cell to come? Always neutrophils. So day 1, neutrophil plus you always have the clot. Day 3, what happens? 3 things happen, okay? After 48 hours, neutrophils will always be replaced by macrophages. Okay, so this is the first thing. Then you have formation of granulation tissue, which is the hallmark of repair. Okay, what is granulation tissue? It's formation of new blood vessels. and collagen 3 will start forming. Okay, now don't remove this tissue. ठीक है, हमारी आदत है हम ऐसे करते हैं कि कभी भी there is a wound, we'll try to remove it. What do? You send it back to day 0. It starts bleeding and you send it back to day 0, right? So we don't want that to happen. Day 5, what happens? You have maximum granulation tissue. So how will the wound appear? Sorry, am I audible to all of you? Am I audible? There was some mic issue. Okay, so what happens on 5th day? You have granulation, maximum granulation tissue. What happens after the end of 2nd week? You have maximum collagen deposition. Now see, this collagen is which one? Type 3. You want to change it to the most important collagen, or the collagen which is the strongest in your body. So you will do collagen remodeling, which will lead to scarring. Right? This happens on 28th day. Is that clear? Is that clear? This happens on 28th day. Okay? So, look at this question. During wound healing, which cell first appears due to chemotaxis at the site of the wound? Can anybody tell me? These are the kind of questions that are asked in pathology. See. But remember, now pathology is integrated with different subjects, right? So, what is the answer for this? What is the answer? This is neutrophil. The first cell to always arrive will be neutrophil. And chemotaxis, who will cause chemotaxis? Can you tell me? Can you tell me who will cause chemotaxis? It will be interleukin 8. Okay, it will be interleukin 8. Now you can see these are when there is a lot of wound healing, okay, excessive scarring happens, okay. So keloid, you can see that this is a raised scar outside. This was the wound margin and this has gone beyond the wound margin. Remember, this is darker in color, okay, this is darker in color and it does not resolve by itself. So you need to treat it. How do you treat it? Intralesional steroids. This was a question that was asked in FMGE June, August 2020. Intralesional steroids are given because it does not regress, right? So what is the site? The most common site is sternum. Okay, this is the most common. Then you have earlobe. It happens in dark, like Africans. The scar is also darker. ठीक है? Hypertrophic क्या है? This is within the boundaries. Okay, this is within. This is a raised scar within the boundaries. I had a hypertrophic scar here, but now I cannot feel it anymore. Okay, first it was a raised scar. अब मुझे नहीं लगता ये. So what happened? Did it regress? Did it regress? Yes. So is any treatment required? Is any treatment required? No, treatment is not required for this, right? Now, a patient who underwent surgery presents with a scar that is limited to the original wound boundaries. Look at the English here, okay? Look at the way the question is framed. Incision site that is limited to original wound boundaries. What does this mean? That it does not cross the wound boundaries. So what is this? What is this? Can anybody tell me? Yes, this is your hypertrophic scar. Okay, keloid will cross the wound boundaries. Very good. Now, wound strength. Once your heart is broken, it will never go back to its normal So a wound never goes back to 100% normal strength. The maximum you can have is 70 to 80%. Okay. What promotes wound healing? Vitamin C and zinc. But which factors delay wound healing? The most common is infections. This is a dread because whenever you have infections, you will have inflammation. So you cannot cause anti-inflammation in between that, right? And the other causes as well. Okay, what is this now? If you have zinc deficiency, what does it lead to? And acrodermatitis enteropathica. This is seen due to zinc deficiency. Okay, this is seen due to zinc deficiency. Very good, guys. Look at this now. A patient presents with truncal obesity, abdominal stripe, poor wound healing. What is the most likely cause of his symptoms? What is this? Can anybody tell me the diagnosis here? Can anybody tell me the diagnosis? Yes, hypercortisol. What is this? This is Cushing's. Very good. This is Cushing's syndrome. Very smart guys, huh? Good, good. Now let's go to hemodynamics. Now when we talk about hemodynamics, the most important is shock, which you'll do it in your surgery, exudate and transudate, as well as emboli formation. Okay. So with respect to emboli, what comes in your exam? Let's do a question and see first. Look at this. This question was asked in FMGE 2022. Hi Abdul Rahman. Yeah, Anirudh, thank you. Okay, look at this. A 58-year-old man suffered a RTA. See, look at the keywords. RTA was there, brought to the hospital. He has multiple fractures in the lower limbs, ribs and lung contusion. Ultimately, he succumbed to his injuries. An autopsy of the lungs shows the following appearance. This is the appearance that was shown. Okay, clear vacuoles were seen. All right. So what is the likely cause of his death? So in the lungs, you see clear vacuoles. What has happened? What has happened? Fat embolism. Okay, fat embolism. Look, when did he die? Actually, they didn't give much of clues here, but the most important is fractures. What are the keywords? Fractures and road traffic accident. Okay. And they had given fat vacuoles. Clear vacuoles can either be fat, water, mucin, or lipids, right? Or what do you say? Air, glycogen as well. Now look at this. A 24-year-old man, severe injuries from a motorcycle accident. Presence with pressure of blood pressure of BP has gone down. Okay, there is a ruptured spleen shown. So what is happening? There is blood loss. Okay, blood loss is present and metabolic acidosis has happened. So what has this patient gone into? Can anybody tell me? Yes, very good. What is the answer? Hypovolemic shock. Hypovolemic shock. Very good guys. Very good. Yes. So with respect to shock, what are the four things? Either the pump is failed, okay, cardiogenic shock, or you have sepsis. Remember, sepsis will present with vasodilation. Usually vasodilation early. Okay, so extremities are cold or warmed? Extremities. So there is a, what do you say, cytokine storm, right? Due to nitric oxide. What happens? There is vasodilation of extremities. So this will lead to warm extremities. Okay, warm extremities. The extremities become warm. But when we talk about shock, the extremities are usually cold, right? This septic shock presents with warm extremities. Okay, please remember this. Now nutmeg liver, look at this. A patient presents with ascites and edema. Okay, ascites and edema. JVP is elevated. Gross examination shows a tissue biopsy of this. What is the most likely condition? Okay, what is the most likely condition? So what has happened? What do you see here? You see nutmeg liver. And when does nutmeg liver happen? When you have right-sided heart failure. Okay, right-sided heart failure. So blood will go back to the body. Okay, blood will go back to the body, and that is why. What is the cause of this? Yes, it is venous congestion, AV congestion. Okay, right-sided heart failure has happened here. The blood will go back to the inferior vena cava, and then back to the superior, inferior vena cava, superior vena cava, and back to the body, where in the liver as well as the spleen, okay, and the peripheral extremities. That's why you have edema, peripheral edema. Is that clear? With respect to emboli, what is the most important emboli? Pulmonary emboli. What happens in pulmonary emboli? One important emboli is saddle embolism, where you block both the pulmonary arteries. Usually the patient doesn't die, but where do you see thromboembolism, pulmonary thromboembolism? Mainly due to DVT, okay? DVT where the patient is, sitting for a bedridden or in long flights, right? So what happens here? There is a block to both the pulmonary arteries. Because of this, there is sudden death, right? Fat embolism, most common cause is fracture of a long bone. Look at the timelines. When we talk about pulmonary embolism, saddle embolism, there is sudden death. But fat embolism, when does death happen? When does that death occur? Remember, it will happen after 72 hours, okay? 48 to 72 hours. So what is happening here? Because you have fractures. What is happening here? Because there is fracture, free fatty acids are released, they are toxic to the endothelium, they damage the endothelium, okay? Now, this always presents with the triad of thrombocytopenia, and you have pulmonary dyspnea and neurological symptoms. Very, very important, neurological symptoms. Patient will go into coma, suddenly stop speaking to you, okay? So what about amniotic fluid embolism? Happens postpartum because the tissue, fetal tissue has gone into the maternal circulation, okay? So suddenly the patient will start having dyspnea, cyanosis, go into shock, coma, okay? And poor prognosis because the patient goes into DIC. Is that clear? Okay, let's go to the next. Look at this. Which of the following is a primary lymphoid organ? Which of the following is a primary lymphoid organ? Can anybody tell me? What is it? It is your thymus. Yes, your thymus is your primary lymphoid organ. Now thymus, what matures in thymus? T cell. Okay? T cell maturation. A defect in T cell maturation. You don't have thymus. Do you remember the defect? Can anybody tell me? A defect in T cell maturation. You don't have T cells. What will happen? Can anybody tell me? Anirudh, dopamine, regent. T cell maturation is affected. Do you remember DiGeorge syndrome? DiGeorge syndrome, right? What is DiGeorge syndrome? 22q11.2. Okay, there's a defect in 22 chromosome 11.2. Okay, because of this defect, what happens? You don't have your parathyroid, third and fourth. Pharyngeal pouches are affected. That's why you don't have your parathyroid gland as well as thymus. No T cell maturation and no PTH, leading to hypocalcemia and infections because you don't have maturation of thymus, right? Antibodies, very, very important. See, when we talk about antibodies, these are made by B cells, right? And can anybody tell me what do we need to do to make B cells? They go class switching with the help of, and they give you antibodies, right? How? With the help of interleukin 4. Okay, with the help of interleukin 4 that is released by the T cells, okay? When B cell and T cell interact with the help of which CD marker? CD40, all right? So what will B cell give you? They'll give you antibodies, which is the most important antibody that acts as secondary immune response that comes late, okay? Which immune comes late but always stays with you, ठीक है? तो boyfriend क्या होता है? जल्दी आता है पर चला जाता है, but husband, he will come late in your life but always stay with you. IgG is like that husband, okay? जो आता है late पर हमेशा आपके साथ रहेगा, ठीक है? That's why he's, and you will love your husband more than your boyfriend, right? So highest concentration, okay? It can cross placenta, and this is very important, provides passive immunity, right? It is also an opsonin. What about IgA? It is present in your saliva, okay? And IgA antibodies, do you remember where do you see IgA antibodies? Yes, IgG. What IgA antibodies, do you remember the disease where you see IgA? Yes, you see it in colostrum also, and where else IgA antibodies are made? Do you remember dermatitis herpetiformis, which is extraintestinal manifestation of which disease? Can anybody tell me? Okay. What about IgM? This is the first antibody to come. It is also known as multimilliers or mega antibody. And the shape of this has been asked in your exam. It's an IBQ. Please remember it is pentameric. Okay, it is pentameric, millioners antibody. And it comes first because this is present with the B cell. B cell already has IgM. Okay, so this appears first. That's why it is known as primary immune response. But it is very huge, so it cannot cross placenta. Okay. What about IgE? Very, very important. This is present in which kind of hypersensitivity? Type 1 hypersensitivity, right? Type 1 hypersensitivity. Okay, mediates hypersensitivity reaction and is involved with allergic conditions, right? Who activates IgE? Can you tell me? Interleukin 4. Okay, interleukin 4. This is also a previous year question. Now, during pregnancy, ABO incompatibility does not occur due to which antibody? Is it A or B? It does not occur due to IgM. Okay, it occurs due to which antibody? Can you tell me? ABO incompatibility occurs due to what? IgM or IgG? It occurs due to IgG. Is that clear? It occurs due to IgG. Okay, very good, very good. Subhiksha, Anirudh, very good. Now, types of hypersensitivity, see, go through this table, that's all you need to learn. Type 1, type 2, type 3 and type 4. With respect to type 1, type 2, most commonly which is asked, you have your type 1. It is IgE mediated, right? Type 1 hypersensitivity. And what is present here? Mast cell and histamine. Okay, please go through the examples, very important. Type 2 is cytotoxic. Let's do a question. These are the questions that were asked in your exam. First, do this question. A and B is one option only, okay? Just imagine this as A, okay? I'll tell you this session will be very effective for your exam. So how many questions come? Mostly all the questions we will be covering here itself, okay? You can see it's a very concise PDF, but I've like question by question we are covering all the chapters, okay? Now, can you tell me the answer for this? Okay, very good. So, Rh negative mother delivers an Rh positive baby. What is the mechanism of hypersensitivity? So, there is, what is Rh incompatibility? What kind of hypersensitivity is this? Type 2. And what is type 2 hypersensitivity? It is cytotoxic. Cytotoxic. So, A and B both are right, right? Look at the second question. Person with recurrent seasonal conjunctivitis presents with itchiness and watery in the eyes. What is the most likely cell involved in immediate phase of this reaction? Immediate phase? Immediate phase. Can anybody tell me? Is it A or B? Eosinophil will come in later phase. Remember, the first thing to come, what will happen? Immediate phase? I'll tell you, eosinophil come in later phase. Okay, later phase. Immediate is when you have mast cell degranulation. Okay, mast cell degranulation, do not get this wrong. Please, this has already come in your exam. Okay, what does it degranulate? Histamine. What does histamine do? It does three things: vascular permeability, vasodilation, and bronchoconstriction. Okay, those are the symptoms that you see in the patient. The patient starts flushing. Okay, there is swelling, and the patient cannot breathe because of bronchoconstriction, vasodilation, and vascular permeability. Eosinophil, what do they have? They have MBP. What is MBP? It is major basic protein which damages the respiratory epithelium. Okay, it damages respiratory epithelium. Okay, respiratory epithelium. Is that clear? A person is brought to the emergency department with facial swelling, itching, hypotension following a bee sting. This is due to which immunoglobulin? Batao? Anirudh is the most active person here. Anirudh, kahan se ho aap? IgE. So which kind of hypersensitivity, what is happening to the patient? Anaphylactic shock. Which kind of hypersensitivity? This is type 1. Very good, guys. Type 1. Okay, type 1. And type 1, which antibody is involved? IgE. So ek baar just quickly go through this. Type 1, type 2, type 3 and type 4. All the type 3 are antibody dependent. While when we talk about type 4, it is cell mediated. Okay, T cell mediated. So this takes time. That's why this is known as delayed type as well. This is delayed type. While when we talk about type 3, what is it? Immune complex mediated. Okay, immune complex mediated. What about type 2? Here you have a fixed antigen. मैं बोलती हूँ ना आपको जिंदगी में ऐसा होता है कि आप सब कुछ सही करते हो. Okay, you're happy here. You're this antigen who's happy here. सब चंगा सी सब अच्छा कर रहे हो लाइफ में. पर क्या होता है? कुछ लोग आपसे जल जाते हैं. ठीक है, कुछ लोग आपसे जल जाते हैं. तो वो क्या करते हैं? वो आपकी सक्सेस नहीं देख सकते. तो वो क्या करेंगे? आपको आएंगे और मार देंगे. ठीक है, आप अपनी जगह पे फिक्स्ड हो. पर क्या होता है? कोई एंटीबॉडी आती है और सब खत्म कर देती है. दिस इज टाइप 2. दैट इज व्हाई इट इज नोन एज व्हाट? साइटोटॉक्सिक. Cytotoxic hypersensitivity. Okay, it kills the cell or kills the antigen. What is the examples? My blood group is Rh positive. Myasthenia gravis, blood transfusion reaction, good pasture syndrome, Graves' disease, IHA, ITP, rheumatic fever, Rh incompatibility, hyperacute transplant rejection, pernicious anemia, pemphigus vulgaris. All the antigens are fixed, but this antibody is abnormal क्योंकि वो आपकी सक्सेस नहीं देखती है, आकर आपको काट. ओके, व्हाट अबाउट टाइप 3? यहाँ पे दोनों कमीने होते हैं. क्या होता है? बोथ ऑफ देम आर बैड. सो द एंटीजन एंड एंटीबॉडी will bind together. You have seen those couples जो दुनिया गई भाड़ में हम रहेंगे प्यार में, that kind of couple. Okay, तो वो क्या करते हैं? अपने प्यार में सबको separate करते. Okay, so what are the examples? So this antibody and antigen, they are very much in love. They will go and destroy the tissues. Wherever they deposit, they destroy the tissue. Okay, so what are the examples? Serum sickness, SLE, Henoch-Schönlein purpura, which came in your exam, Arthur's reaction, reactive arthritis, PSGN and PAN. Very, very important. Okay. Type 4, contact dermatitis. Remember the differentiation between atopic and contact dermatitis. Can anybody tell me what is atopic dermatitis? Atopic dermatitis is type 1. While when we talk about contact dermatitis, it is type 4. Remember nickel, वो होती है ना fake jewelry. तो वो क्या दे देती है? Fake लोग आपको बहुत बर्बाद करते हैं ना. तो यहाँ पर भी fake jewelry made up of nickel. That really affects the females.
To do that,
okay?
you'll need to.
And even detergent, rheumatoid arthritis, wherever, granuloma formation. Please remember all of this is type 4 hypersensitivity. Cells are involved here. ठीक है? Cells are involved here. Is this clear? Chalo, let's go to B and T cells. Now when we talk about B and T cells, like I told you, in our body, these T cell, what is a master regulator of immune system? It is, who is the Modi G of immune system? It is our T cell. Which T cell? CD4 T cell. Okay, CD4 T cell. And please remember, your T cells are 60-70% in the serum, right? While when we talk about B cells, they are only about 20 to 30%, while less than 10% is NK cell. But we don't write here because this is adaptive immunity, right? Now, where does T cell mature? Thymus, just now I told you. B cell matures in bone marrow. These are the markers that you need to remember. Very, very important. Okay, the markers, very important. You have to remember them, because if you remember them only, you will remember CLL, ALL, okay, all the leukemias. Ultimately, T cells have to make CD4 and CD8 T cells. Remember, CD4 are master regulator. This is the Modi ji of your immune system. Okay? Master regulator of immune system. Okay? What about CD8? They are cytotoxic T cells. Okay? They kill. They are cytotoxic. What about B cells? Their function is to secrete immunoglobulins. Now, B cells are induced by what? Can you tell me? IgE. They produce IgE by the inducement of what? Batao, batao, jaldi batao. Who induces B cells? It is your interleukin 4. Okay, it is your interleukin 4. While interleukin 1 is involved with fever, this mediates acute phase reactants. Okay, seen in anemia of chronic disease. Interleukin 6 is seen in anemia of chronic disease, important. Okay. Yeah, good Bhavishit, very good. Now, when we talk about MHC class 1 and 2, again, these are, what do? They help you identifying self from non-self. Okay, self from non-self. मतलब मैं किसको जानती हूँ और किसको नहीं जानती. Who will tell me? MHC. Okay, MHC will tell me what is self and non-self. So MHC 1 is always bound to. So what happens whenever you have an antigen? Who takes up the antigen? Antigen presenting cell. Who will they give it to? They will give it to MHC. Okay, they will give it to MHC to a T cell. Okay, this is how your immune system works. Whenever there is an antigen, it is taken up by antigen presenting cell, presented to T cell on MHC. Okay, so MHC1 and MHC2, remember, MHC1 is presented on all nucleated cells. Okay, this presents the antigen to which T cells? We use the rule of 8 here. Okay, so it presents it to CD8. You ultimately have to get 8, right? So MHC1 into what gives you 8? Into what gives you 8? You have to multiply it with 8. What about MHC2? You multiply it with 2. Okay, MHC2, you have to multiply it with 4. Is that clear? MHC2, you have to multiply it with 4. So you will get 8, right? So what T cell does it bind? Present to CD4. Is that clear? Again, let me repeat it one more time. See, MHC, what is the feature of MHC? What is the present, whenever there is an antigen? What do? You take it up. Who takes it up? Antigen presenting cell. Do you remember the antigen presenting professional APCs? You have your B cell, dendritic cells and your macrophages. The most important being dendritic cell. तो क्या होता है? ये जाके present करते हैं antigen को T cell से, right? How do they present? On MHC, right? So you have MHC1 and MHC2, and these MHCs present it to CD4 and CD8 T cells. Is that clear? For your exam, if these MHCs, if there is any polymorphisms in the gene that make MHC, that will lead to you not recognizing something that is normal, like HLA-DQ8. What is it? It leads to celiac sprue. This is a previous year question. DR4 is also a previous year question, where this leads to rheumatoid arthritis. Look at this. Reiter syndrome is associated with which of the following? Can you tell me? Reiter syndrome. Reiter syndrome is associated with which of the following? HLA-B27. Very good. HLA-B27. This is very, very important. I always remember HLA-B27 because my birthday is on 27th April and I was always searching for my pair. Okay. So with R, remember reactive arthritis and Reiter syndrome. I stands for IBD, A for ankylosing spondylitis and P for psoriatic arthritis. So I always remember Reiter syndrome क्योंकि मेरे बारे में है, ठीक है? HLA-D4 again rheumatoid arthritis, HLA-DQ8 celiac sprue, very important. At least ये तो पता होना चाहिए आपको, एग्जाम के लिए important है, ठीक है? Amyloidosis, very, very, put a question mark, very, very important. Let's first solve a question. Look at this. There's a question here. Solve this first. A 70-year-old man, male, presents with fatigue, breathlessness and palpitations. He has no comorbidities. but does not smoke or drink. On examination, pedal edema is noted, ECG is normal. Echo shows restrictive cardiomyopathy. A biopsy reveals apple green birefringes under polarizing right and Congo red staining. What is the diagnosis? So definitely this is cardiac amyloidosis. Why cardiac amyloidosis? Please remember, guys, when we talk about amyloidosis, what is this? This is the word that came in your exam. Put a star mark again. They know that you know amyloidosis. So how have they told about it? Amyloidosis is nothing but extracellular amorphous. This was given in your exam, okay? Amorphous pink deposition. Can you remember this? Extracellular amorphous pink deposition. Can you see this? So these are your cardiac myocytes, and you can see this amorphous. There is no shape to it, pink deposition. On light microscopy, what stain do you use? Congo red. Okay. Then you can, on polarizing microscopy, it gives you an apple green birefringes. Okay, polarizing microscopy. What do you see? Apple green birefringes. Okay, refringes. Now these are the types of what happens. You have normal protein that have misfolded. Okay, you have this precursor protein that have misfolded. Okay, this precursor protein that has misfolded, and what are they doing? They are depositing extracellularly. तो आपने वो लोगों को देखा है जो आपकी लाइफ में होते हैं, और have you seen toxic relationships जहाँ पे you know there's a guy and a girl and the guy is like very toxic, मारता है, पीटता है, और फिर he doesn't do anything, कमाता भी नहीं है, लड़की कमा रही है, लड़की बाहर जा रही है, लड़की सह रही है. So what does he do? He doesn't work, he's like a parasite, and he also starts disrupting the function of this girl who was beautiful. I've seen so many people ये relationships में जाके कि मैं pretty दिखती हूँ, मैं pretty, you are pretty, but what has this guy done? He has destroyed your self-confidence and your self-esteem, right? So that is amyloidosis. It's like a parasite, extracellular deposit, and you cannot remove them also. Okay, you cannot remove them also. Amyloidosis is like that. It's insoluble. Misfolded, insoluble. So it accumulates. Okay? Okay? It keeps accumulating in the body. Just imagine that. तो पहले तो वो कुछ नहीं कर रहा, फिर वो आपका भी function destroy करेगा. Is that good? No, right? So primary amyloidosis is seen in multiple myeloma. What is happening? You have light chains. Multiple myeloma, what is it? It is a plasma cell cancer. So you make a lot of light chains, they get misfolded, and you get AL, amyloid light chains. Alzheimer's disease, you have, what do you say? APP protein that keeps misfolding and making A beta. Okay, A beta. What about hemodialysis? In hemodialysis, you cannot remove beta microglobulin. So it gets misfolded and becomes A beta 2. What about AA? This is seen in secondary amyloidosis. Okay. ACAL, again, previous year question, it is seen in medullary thyroid carcinoma. Very, very, very important. Kabir Singh. Yeah, Kabir Singh. Transplant rejection. So these are the different transplant rejections. Please remember, what kind of rejection is this? Post-transplant. मतलब आपने transplant कर दिया, पर क्या हो रहा है? थोड़ी देर के बाद organ is getting rejected in the recipient. Okay, so there is a donor and recipient, right? Recipient. So what is happening? The first 3 rejection happen inside the body happen because of recipient antibodies, cells. Okay, so hyperacute is when it happens within 48 hours. Acute, days to weeks or less than 6 months. Chronic is more than 6 months. Okay, more than 6 months. Why does hyperacute happen? Because this patient already has preformed antibodies. Preformed antibodies are present, and due to type 2 hypersensitivity, which is antibody mediated, right? What about acute? It is both type 2 and type 4. What about chronic? It is cell mediated. Okay? T cell mediated response to foreign antigen. Okay? graft versus host, very important keyword, donor T cells. Variable hai timeline, and it is due to donor T cells. Okay, it is due to donor T cells. Look at these questions that were asked. Look at these questions. Look at these questions. Which of the following organs has the highest incidence of graft rejection? So which is it? Can you tell me? Yes, it is lungs. Lungs have had the highest incident of graft rejection. Okay? I still remember during COVID times, like back in 2021, there was this one patient, जो एक MLA था, who had come to my hospital, and his family was like, they had so much money, and they were like, we'll get a lung transplant, and they were like, we'll give you crores of money, they were telling to my consultant. And I still remember वो MLA को pulmonary fibrosis हो गया था, तो could you have saved him? Could you have saved him? But the whole family was, you know, threatening the doctors and causing a ruckus in the hospital. I still remember it. So graft rejection, especially lung transplant, high rejection happens. Okay. Cells responsible for graft rejection are, what are the cells responsible? Most important cells are T cells. Okay. T cells, especially your CD4 T cells. Okay. Graft rejection from an identical twin is known as, and I still remember that I had a very nice student, okay, and he was so good in pathology, और फिर वो गया, this question had come, identical twin, and he has marked it as allograft. Am I saying it right? Is it allograft? He marked it as allograft. सही किया क्या बंदे ने? So allograft is same species. What is isograft? What is isograft? Same DNA. Okay, same DNA. So this is present in, this is present in your isograft is identical twin. Okay, same hai ye. Okay, identical twin. Very good. Identical twin. Very, very important. Isograft. So what is the answer? Isograft. What about autograft? You get a graft or an organ from yourself, right? So from self. Xeno is from animals. तो क्या होता है? Many times in the exam you know the answer, but आप बहुत tension ले लेते हो and you're stressed out and ऐसे करके बैठोगे तो what happens? You make silly mistakes. So don't make mistakes like. And he was coming and telling me कि मैम ये question आया था, मैंने उसको allograft mark किया, so don't do the same. Okay. Now these are your primary immune deficiencies. First, let's do a question. Look at this. Which of the following condition is associated with hypocalcemia, thymic hypoplasia, cardiac abnormalities, and deletion of chromosome 22q11.2? Can you tell me? Can you tell me? Yes, it is your DiGeorge syndrome. It is your DiGeorge syndrome. Now, when we talk about Cry-Do-Chat syndrome, what is this? This is chromosome. Can anybody tell me? Cry-Do-Chat syndrome, cat-like cry, which is chromosome deletion of what? Chromosome 5. Very good. Now, what about the rest? Like, go through this. It's important table. DiGeorge syndrome, I told you, I remember it as DiGeorge syndrome. You can remember it as Cash22 also. But there's deletion of 22q11.2. So micro deletion is there, due to which third and fourth pharyngeal pouches fail to develop. अब इसके result क्या होता है? They give rise to parathyroid and thymus, so they are not made. And PTH controls calcium. So you have hypocalcemia and T cell defect is there. So you have, what do you say, recurrent infections. Also, it is associated with tetralogy of Fallot, which was your previous year question. Important. And abnormal facial features like cleft lip and palate. Okay. Wiskott-Aldrich syndrome, X-linked recessive, again, previous year question. Please remember, WASP gene. This is the only gene defect where you have small platelets. Okay, this is the only condition with small platelets. So that leads to thrombocytopenia, okay? And you have decreased IgM but increased IgA and E, all right? What about SCID? The most common deficiency is adenosine deaminase deficiency. Both B cell and T cells are defective. These are keywords, remember them. This is very, very important. Every time there are at least 2 disorders that come from immunodeficiency disorders. So we have disorders of inflammation and disorders of your primary immunodeficiency disorders. Go through them, very, very high yield table, okay? Very, very high yield tables. All right, let's go to SLE now. These are your other disorders which like SLE, type 3 hypersensitivity, okay? What is important for the exam? The most sensitive antibody. The first one to rise, but can rise in scleroderma as well. So what is it? Anti-nuclear antibody, which is your most specific antibody. Anti-Smith antibody and anti-double-stranded DNA antibody, right? Anti-double-stranded DNA antibody. Is that clear? These antibodies are very, very important for the exam. Now, when we talk about scleroderma, you have diffuse and limited. Very important. Again, you must have learned it in medicine, associated with anti-SCL70 antibodies, and they involve visceral, even pulmonary fibrosis. They'll give you a case of pulmonary fibrosis if they want to ask you about diffuse scleroderma, tightening of skin, okay? Limited scleroderma is CREST syndrome, okay? And which antibodies? Very famous antibody, anti-centromere antibody. Drug-induced anti-histone antibody. What are the drugs? What are the drugs that induce SLE? You must know them. Anirudh, can you tell me the answer? Drug-induced? Your SHIP-D drugs, right? Sulfonamide, hydralazine, isoniazid, procainamide, dapsone, right? Very good. Very good, Prem Kishore. Good job. What about Sjogren syndrome? Dry eyes, dry mouth, okay? What are the antibodies? Anti-Ro, anti-La. So, anti-Ro matlab, aap dry eyes hai to ro nahi sakte, and La, whenever you have dry mouth, what will you do? You will stutter, la 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 la. So, anti-Ro, anti-La. These are the, again, very high yield table. Put 10,000 star marks here. 100% question will come from there. Definitely enough, okay, definitely enough. 100% question will come from here. ठीक है, चलेगा? ये go through करना है ये table से, ठीक है? Very, very important. कुछ ना कुछ आएगा ये table से. Take a screenshot or put it on your wall. Very important. Look at this now. Solve these 2 questions for me. Solve these 2 questions. A 24-year-old female presents with a malar rash, recurrent oral ulcers, multiple joint pains. Female, remember SLE is female induced, right? Thrombocytopenia, positive anti-Smith antibody. The minute I hear anti-Smith, it is specific to which syndrome? Systemic lupus erythematosus, okay? Which of the following is implicated in the pathogenesis of rheumatoid arthritis? Huh? So, SLE, how will you remember it? SLE, okay? Firstly, what is the antibody that is sensitive? Sensitive is ANA, and specific is anti-Smith, okay? Anti-Smith. What about, what do you remember from L? Do you remember there is one more, if it involves the heart, you can have endocarditis. Which endocarditis? Lehmann-Sack endocarditis. Okay, can you remember it like this? And due to sun exposure, because see, one thing that is very common in SLE is what? Photosensitivity. What do you get? Which rash do you get? Malar rash, okay? Okay, where does this occur? Lehmann-Sack endocarditis, okay? It usually affects both sides of the leaflet. Both side of leaflet, okay? Mainly which leaflet? Lower. Most common on the lower side. Is that clear? Can you remember it like this? And erythematous, why? Because the rash is red. okay, the butterfly rash, yeah, mala rash, okay, in the face, but due to sun exposure, you have photosensitivity, you get mala rash. And what is this? This is a stree. Remember, SLE happens mainly in what? Females or males? 9 out of 10 cases are females, okay? So it happens in stree. Is that clear? Is that clear? You remember this SLE with this flashcard, okay? All right. Pathogenesis of rheumatoid arthritis, it is autoimmunity. Okay, rheumatoid arthritis, they really love. What are the two things that you see in the extremities in rheumatoid arthritis that you learn in your medicine? Now, with respect to genetics, again, at least 3 to 4 questions will 100% come from genetics. From the past 5-6 sessions, 3 to 4 questions have been asked from genetics, okay? So very, very important, okay? Very, very important. Genetics, you have Mendelian disorders, non-Mendelian disorders. From the past few sessions, they are asking more questions from non-Mendelian disorders. Now, with respect to Mendelian disorders, you have autosomal dominant, autosomal recessive, X-linked dominant, X-linked recessive. Definitely, you will have to remember this, okay? So, you can see here, this was asked this time. 2 questions came on Marfan syndrome. Do you remember? Bottom ear and swan neck deformity. Very good, very good. Who is that? Mohammed Sheikh. Very good. MBBS 8981. Okay. So, look at this. A 17-year-old man, okay, thin adolescent man presents with recurrent joint pain and occasional chest discomfort, reveals erectodactyly, high arch palate, generalized joint hypermobility. His father had similar features and died suddenly at a young age. Fibrillin 1 gene mutation. What is this? This is Marfan syndrome. Okay. How do you differentiate Marfan syndrome from homocystinuria? Homocystinuria is autosomal recessive. Okay. What is homocystinuria? Autosomal recessive. And the lens dislocation. How is it? Can anybody tell me? Lens dislocation in homocystinuria? How is the lens dislocation? It is inferonasal. Very good, inferonasal. So, lens dislocation here is superotemporal. Okay. So, remember defect in fibrillin 1, 2 questions had come from Marfan syndrome alone. So, this is something that NB is, I don't know what are they doing, but this is YouTube. NB is a girl, okay. I'm not saying anything. I love my board. All right. So, a very dominant father has heirs. You remember the autosomal dominant disorders. Most commonly, we have autosomal dominant disorders because, again, autosomes are present in all of us, right? What are the disorders? You have to remember them. Marfan syndrome was asked this July examination. Okay, 2 questions from Marfan syndrome came. All right. NF1, NF2, again, they are Marfan syndrome, what do you say, autosomal dominant. And with respect to NF2, remember Miss-me tumors are seen. What is Miss-me tumors? Multiple inherited schwannomas, then you have meningiomas and ependymomas, okay? They are associated with NF2. Cafe au lait spots are more in NF1, okay? Cafe au lait spots and your Lish nodules, okay? They are seen in NF1 most commonly. Is that clear? So there was this 14-year-old girl with cafe au lait spots and Lish nodules. What is the most likely diagnosis? Tell me. DVT will also be there in homocystinuria. Very good. Who is that telling? Mohammed Sheikh. Very good. Very good, very good. What is it? Is it NF1 or NF2? Always remember, when we talk about NF1, you will have all these symptoms. NF2 is associated with tumors, associated with Miss-me. I'm just writing. When this session is over, Miss-me. Okay? What about TSC1, TSC2? This is involved in which gene mutation? What does this lead to? Tuberous sclerosis. Okay? Tuberous sclerosis. Is that clear? Osteogenesis imperfecta. This is brittle bone disease. Okay? Multiple fractures, blue sclera plus SNHL. okay, because it affects your bones. Okay, type 1 collagen is present in the bone, right? So it affects the bones, right? The sclera becomes so thinned out that you can see the choroid plexus behind it. That's why you have the blue sclera and multiple fractures, because the bones are so brittle. Falling down will result in fractures, okay? Ehlers-Danlos syndrome, again, this is an autosomal, it has many inheritors, but the most common is autosomal dominant, okay? Autosomal dominant. Look at this. These are the two questions that were asked about. Look at this again. Marfan syndrome is very famous, okay? Aneurysm due to excessive degeneration of connective tissue is seen in which of the following disorders? So fibrillin 1 gene will affect the fibrillin, which will ultimately affect elastin. So it affects the connective tissue, right? It affects the connective tissue, right? What is this? This is Marfan syndrome. What about this? What is the likely protein involved in this? It is your fibrillin. You see the same question asked in different ways. Okay. Shall we take a break here? Shall we take a break for some time? Like 15 minutes? I think we have been going on and on since the past 2 hours. Have you stayed with me till 2 hours? So when we have longer sessions, like if this was a shorter session, maybe 2 hours, we would have had a bigger audience. But usually whenever we have long sessions, like 6-7 hours, people prefer to watch it on 2x speed, right? क्योंकि आपकी generation तो normal है ही नहीं, ठीक है? ठीक है. Any questions still here? Any questions still here? We'll take a break. You watch movies also for at 2x, no? 1.5. I remember there was a student and he was watching something and it was at 2x. So I asked him, why are you watching it like this? So he's like, ma'am, I want to watch it fast. So I was like, अरे ये क्या कर रहे हो? मतलब you skip, no? Why are you watching at an abnormal speed? He's like, नहीं नहीं मुझे सब कुछ देखना है. So Gen Z people, क्या करूँ मैं? All right, now I'll take a break, 15 minutes, okay? 15 minutes. We'll start after 15 minutes. Okay, hi guys, welcome back. Welcome back. Okay, so shall we start? We were doing autosomal dominant disorders. Please remember here, what is the thing about autosomal? Happens, see, one heterozygous state, it is good enough, okay? Autosomal dominant, always remember, manifests in heterozygous state, meaning one gene mutation is enough to cause a disorder, right? And usually affects structural proteins. While when we talk onset is usually adult, right? When we talk about autosomal recessive, onset is childhood. You need, because it is autosomal recessive, recessive only expresses in which state? Homozygous state. So both alleles should be mutated. Both alleles on both the chromosomes should be mutated for this disease to, manifest, right? For this disease to manifest. Good evening, Royal Khan. Good evening. Welcome back. Come back, all of you who left and went to have tea and everything. Okay, so now this is most commonly seen in enzyme defects, like inborn errors of metabolism. When we talk about autosomal dominant, remember these are structural protein defects mainly. And what is the onset? Childhood. Okay, and here the clinical features will not be different from each other. Every child will have the same presentation. Okay, now what are the examples? You can look at it. You have alkaptonuria, alpha-1 antitrypsin, blood disorders like beta thalassemia, very, very important, sickle cell anemia. Okay, that's why the presentation of beta thalassemia patients and sickle cell anemia is usually a child. Okay, cystic fibrosis, this is CFTR gene defect, which channel is affected? Chloride channel, right? That is why, which baby do you call it? Which baby? Can anybody tell me? Royal Khan, Prem Kumar, Anirudh, are you guys here? Yeah, salt baby, yes, very good, salt baby, right? And the mucus is so thick that this patient ends up having bronchiectasis, okay, finally dying, right? So what question was asked? Even albinism. Albinism was a previous year question that was asked in your exam, okay? Enzyme deficiencies like glycogenous lysosomal storage disorders, very, very famous biochem. Last time 22 questions came. Friedreich's ataxia, Gaucher's disease, galactosemia, homocystinuria, just now we have discussed, hemochromatosis, very, very important. It's a metabolic liver disease, and inborn errors of metabolism like phenylketonuria. Okay, so you can see here, what is this? This is actually Tay-Sachs disease. Both Niemann-Pick and Tay-Sachs show you, what do you say, cherry red spot, right? It is seen in both. Tay-Sachs disease, what is it a defect in? An onion skin appearance is seen in Tay-Sachs with balloon degeneration. Okay. Can you tell me what is the defect in Tay-Sachs? Tay, A, is hexosaminidase A, while Niemann-Pick is sphingomyelinase. Okay. Onion skin appearance is also very, very famous in malignant hypertension, primary sclerosing cholangitis. We'll discuss this when we do liver. And Ewing sarcoma. Ewing sarcoma, can anybody tell me anything else about Ewing sarcoma? Very important, X-ray of Ewing sarcoma. Okay, you also see something. Yes, what else do you see? Onion skinning appearance. Yeah, very good. Niemann-Pick disease, everything is same as Tay-Sachs except for these bodies. Here you have zebra bodies, okay? And it is due to sphingomyelinase, right? Sphingomyelinase. Sunburst appearance is seen in another tumor. Which tumor? Osteosarcoma, right? Yes. Sphingomyelinase. What is the gene mutation in Ewing sarcoma? It's very famous. Okay. Gaucher's disease. Now this is the most common lysosomal storage disorder where you see the macrophage has a crumbled tissue paper appearance. This is very famous, crumbled tissue paper appearance. Who has this? Your macrophage. Okay. Lysosomal storage disorder hai, hepatosplenomegaly and Ellesmere-Flas deformity. HCD detected clinically a fragile woman. This is for X-linked recessive disorders. X-linked recessive disorders. Can anybody tell me X-linked recessive kin mein dikhta hai? Is it seen in males or females? Remember, when we talk about X-linked recessive disorders, what do you need to remember? Females are carriers. And what are males? Males are affected because they have only one X chromosome. Please remember recessive disorder है, ठीक है? तो females have double X, right? So वो double X, if only one gene is mutated, will it present? No. So females are usually carriers while males have only one X chromosome. तो ये disease manifest होगी, ठीक है? So what are the examples? Hemophilia A and B. There was a question about hemophilia recently. Color blindness, G6PD, very, very important. Duchenne muscular dystrophy, what do you remember about Duchenne muscular dystrophy? Do you remember there is a sign known as Gover sign? Huh? Do you remember the Gover sign? Right? Color blindness, again, you must have seen all these males who go for, becoming a pilot and all, they come to know. Usually it's a male that comes to know that color blindness, right? So, A gamma globulinemia, this is nothing but Bruton's. Fragile we will discuss now. WASP gene mutation we have just discussed. Okay, Wiskott-Aldrich, WASP gene mutation. What is the triad of Wiskott-Aldrich syndrome that has been asked in your exam? Thrombocytopenia, you have eczema, and what else? There is, jaldi batao, recurrent infections. Come on, it's a primary immune deficiency disorder. So definitely क्या होगा? Infections. ठीक है? What decreases? IgM. What increases? IgE and A. Okay, this increases. That is why you have eczema. ठीक है? Is that clear? ठीक है. Now, when we look at these diseases, what are these? These are very, very important. Mitochondrial diseases. Mitochondrial inheritance. These diseases show mitochondrial inheritance. अच्छा, what is mitochondrial inheritance? देखो, mitochondrial, you just remember M. How do you get mitochondrial inheritance? From mothers. Your mitochondrial DNA is inherited by mitochondrial DNA is inherited by mothers. Okay, mothers give you mitochondrial DNA. And what is the most common disorder? Melas. Okay, Melas. So triple M. ठीक है, क्योंकि माँ कभी भेदभाव नहीं करती, तो she gives it to all her kids. Okay, she gives the mitochondrial DNA to all her kids. I always tell you in class, माँ कभी भेदभाव नहीं करती. All her kids, she loves the same. Okay? The diseases also, she gives to all her kids if she is defective. What about dads? Do fathers give the DNA to their kid? Mitochondrial DNA, do they give it to their kids? No, it undergoes apoptosis. So if the father has a disease, will the children inherit it? No. So this is very famously known as mother to all, father to none. Remember Melas. Remember these diseases names. Okay. What is Melas? It's an acronym for mitochondrial encephalopathy, lactic acidosis, and stroke-like symptoms. Okay. Is that clear? Now look at this. I always want you to, whenever you do a pedigree, we have had pedigree. Last time also there was a pedigree of adopted child. So let's do it nicely. ठीक है, ये important है. Whenever there's a circle, she's round, she's curvy, she's a female. Okay, circle is a female. और कौन hard रहता है? Male. Okay, so square is a male. Now when you have a shaded square, that is affected male, right? Affected male. Now what about female? What if she's half shaded? Can anybody tell me what is this? Half shaded? What is half female? Carrier. Which carrier? Autosomal recessive carrier. Okay. If she's a half shaded female, autosomal recessive carrier. Now if there is a, what is this? This is an X-linked carrier. X-linked recessive carrier. Okay. Because carrier will always be female, right? And now what is this? This is when both are married to each other. And what is this? This is going towards the next generation. They're married, they do something, they produce children. Okay? Now what is the meaning of this? Can anybody tell me? This is what came in your exam. Look at the child, the male child. Male child, what is it? The male child is adopted. This is the meaning of adopted child. Okay, what is a twin? You have a female and a male. Okay, what is this? What is this? When you get two children from the doing it only once, what is that? That is giving you twin delivery. Do you understand? So this came in your exam. This came in your exam. Please remember this. Okay, please remember this. All right. Now look at this. What is, whenever you see pedigrees, what do? You always look at the generations. Now, how many generations are there? First, second, and third. Okay, 3 generations are there. Out of this, can you see if any generation is skipped? Is there any generation? First, you see whether there is a problem with the generation or there is some gender bias. Now, this is a non-Mendelian disorder, right? So, what do you notice in this non-Mendelian disorder? When the mother is affected, in the second generation, all the kids are affected. When the father is affected, none of the kids are affected. Here, even when the mother is affected, all the kids are affected. This is famously known as mitochondrial inheritance, mother to all, father to none. Okay, this came in your exam. This is a PYQ. Okay, this is a PYQ. This is a previous year question. This pedigree came in an exam. Always look at the generations, see if there is any problem with the gender or if there is some kind of like mother is giving to all, father is giving to none, something like that. What about this? Now, what do you notice here? Again, 3 generations are there. Every generation is affected. First, the father, then the male and a female, and finally the female. Can you tell me if there is any gender bias? Very good, Naveen. I'm happy you're done with the GT. Is there any gender bias here? Is there any gender bias here? No, there is no gender bias. Okay? There is no gender bias here. Okay? So, I can call it as autosomal disorder, but as every generation is affected, this must be autosomal dominant. Okay, this does not skip any generation. These are your rules for pedigree. Okay, why? Because one gene mutation is enough for the disease to manifest, right? What about this? You can see in the first generation, the second generation, and the third generation. What do you notice? The first generation, if you do a Punnett square, you will notice that this is a normal female, and the male is actually, there is a mutation. Which mutation? Recessive mutation in the female. Okay, in the female. The male is normal, while there is a mutation in the female. Now, what do you see? This female is a carrier. Why? She's half shaded. Which carrier? Autosomal recessive. So, is there any manifestation in the first generation? Can you tell? This generation is skipped. What about this generation? Again skipped. But what do you now notice? That there are 2, there is a male, there is a female. See the circle, that is a carrier, and another carrier. They get married. 2 carriers get married. Now, please remember, what will happen? Disease will manifest. Okay, disease will manifest. 25% of the progeny will be affected. 25% of progeny will be affected. 25% of progeny will be affected. You do the Punnett square, okay? And here generations are skipped. Why? Because you need, which state do you need? You need homozygous state. You need both the genes to be mutated for disease to manifest. So, you need a homozygous mutation. Is that clear? Generations are skipped here, okay? What about this? Can you see the males are affected and the females are carriers? So, this must be a pedigree for what? Can anybody tell me? Please tell me, Raul Khan, what's your doubt? See, males are affected. Look at this. This is a shaded square. This is a shaded square. What are females? Females are carriers. So, what is this? This must be X-linked recessive, where males are affected because they have only one X, while the females are carriers. Okay, exception 1 is Turner syndrome. Now, what about X-linked dominant? See, when the female is affected, माँ कभी भेदभाव करती है क्या? माँ कभी भेदभाव करती है? Yes or no? Does a mother ever have some kind of biasness? Does the mother ever have some kind of biasness? बोलो मुझे. Does the mother have any kind of biasness? Is there any kind of biasness? No, right? there is no kind of biasness. So माँ कभी भेदभाव नहीं करती. X-linked, whenever there is a dominant disorder, remember 50% of the progeny is affected. Now when the mother is affected, what is happening? 50% progeny is affected. मतलब both boys and girls are affected. But fathers, you must have seen, my father really loves me a lot. Okay? मैं अपने पापा से लड़ती हूँ तो next day I go and tell him, I'm sorry papa. He will be fine with me. He will be like, अच्छा जाने दो मेरी बेटी. But मेरा भाई मेरे पापा से लड़ता है तो एक महीना वो उनसे बात नहीं करते. Like my father will not talk to my brother for a month if he fights with them. So you know, fathers have a kind of love towards papa ki pari, right? So fathers, whenever fathers are affected in dominant disorders, who is dominant? Fathers, right? So fathers will affect 100% of their daughters, okay? 100% of the daughters. Please remember this. X-linked dominant, if mother is affected, माँ कभी भेदभाव नहीं करती. Father is affected, पापा की परी. ठीक है? So 50% is affected. Is this clear? Do you remember the examples of X-linked dominant? Alport syndrome, Reiter syndrome, and then you have your, what do you say? This, what do you say? Rickets. Vitamin D resistant rickets, okay? All right. Now let's go to this question. Can you solve this question for me? Which condition is inherited according to the given pedigree? So this is a good question. Tell me, which question? NEET PG 2024, what was asked? See, NEET PG questions are directly, no, just cut, copy, paste it in your exam. So make sure you're very good with them, okay? You message me later, Royal, okay? What is this? See, what happens first? Male is affected, female is not affected. Female is a carrier. So what is this disorder? Can anybody tell me what disorder is this? Male is affected, female is a carrier. This is X-linked recessive. Now search for the X-linked recessive disorder. Out of this, which is X-linked recessive? It is Wiskott-Aldrich syndrome. Okay, HCG detected clinically a fragile woman. Okay, so W stands for Wiskott-Aldrich syndrome. It is X-linked recessive. Okay, all right. There was a question on Prader-Willi syndrome as well. Okay, Prader-Willi syndrome as well. Now genomic imprinting. Look at this question that was asked in NEET PG 2024. Then there was another question repeated exactly after this NEET PG in your July examination. There was a question on Prader-Willi. So बहुत important है. See, I told you, no, questions are directly repeated from NEET PG papers. Look at this. Can anybody tell me what is the most likely diagnosis based on the image given below? So what is happening here? See, this is a normal chromosome 15. What is happening on the, and this is paternal, this is maternal. Now there is a gene deletion in paternal chromosome, okay? There is a gene deletion in paternal chromosome. Maternal is there, or either this, or I can have maternal uniparental disomy, meaning I get both the genes from what? Mother or father? From my mother. So automatically I have deleted my father's genes, right? So this is seen in which disorder? Prader-Willi. And how do you remember it? Remember Pappu. What is Pappu? Prader-Willi. Exam ke baad, July ke exam ke baad, I still remember students had called me and told me, ma'am, Pappu aa gaya. So Prader-Willi is present on what? Present on which allele? Paternal allele. Okay, paternal. Prader-Willi present on paternal. So remember Pappu. How do you remember Pappu? Pappu. See what is happening? There is gene deletion. What is genomic imprinting? There is random inactivation of your genes. Okay. So basically there are two chromosomes. One from father, one from mother. You inherit, right? When will there be any protein made? When one of the genes is active. But what is genomic imprinting? There is random inactivation of one gene. Like if this was my active gene, What will happen to father's gene? It will be genome, there will be imprinting of this gene, or what do you call it? You call it inactive gene. But now imagine if one gene was inactive, okay? What if my mother's gene was inactive? Okay, what if my mother's gene was inactive? Imprinted, I can say imprinted, and father's gene was deleted. Will there be any protein made here? Will there be any protein made here? No, right? No. So Pappu, who is Pappu? Look at this. This is your Pappu. This is my Pappu. Okay? Why Pappu is like this? Because Pappu is Prader-Willi. What Pappu doesn't have a brain, okay? He's mentally retarded. And Pappu eats a lot, okay? He is obese. Okay, he is obese. There is obesity. And he eats like this. Okay, why? Because his hands are short, very short. So he cannot eat with his hands. So he eats with his mouth. That's why his mouth is always open. Okay? So please remember, this patient has short stature. Okay? Like that he eats. Okay? His hands are short. And what is this? Pappu is very cute. Okay? He has hypogonadism. ठीक है, हाइपोगोनाडिज्म. तो ऊपर कुछ नहीं, ठीक है. तो दिस इज पप्पू, ही इज वेरी क्यूट. ठीक है, Prader-Willi, you will never forget it. Remember chromosome, what gene deletion? Always remember the gene deletion. Paternal P for P, it is Prader-Willi. Please remember, angel mean my mother is an angel, so you delete her. Okay, my mother is an angel. Maternal deletion. Happy puppets is Angelman syndrome. Okay. Happy puppets is Angelman syndromes, where you have seizures, ataxia, mental retardation. Imagine मैं मर गई, आप मेरे funeral में आए और आप बोल रहे हैं मर गई, तो वो inappropriate हो गया ना. तो this is, you know, she has ataxia, she cannot, you know, she has ataxia plus she laughs at inappropriate times. Angelman syndrome. All right. Now we have other non-Mendelian, defects like trinucleotide repeats. Look at this question. Which of the following features is a feature of Fragile X syndrome except? So Fragile X syndrome, I always remember it as Fragile X syndrome. Fragile X syndrome. Fragile X syndrome. Why? Which repeats do you see in Fragile X syndrome? CGG repeats. Okay, CGG repeats. Okay, CGG repeats. What about Friedreich's ataxia? It is GAA repeats, CTG repeats, and myotonic dystrophy. Okay, these are nucleotide repeats. More than how many nucleotides? 200 nucleotides. Okay, so complete repeat of CGG for more than 200 times is known as trinucleotide repeats. Okay, so this can happen in non-coding or coding region. Coding region, what do we have? We have CAG repeats. Okay, CAG repeats, which is seen in Huntington's disorder. Huntington's, what kind of inheritance is it? Can anybody tell me? कोई मुझे बता सकता है Huntington's का inheritance? It is autosomal dominant. So we have hunting in a cage, right? Why cage? Because you always remember the codon. Please remember, it happens in which region? Exons. CAG repeats in exon. And it happens on chromosome 4. It is autosomal dominant. Autosomal dominant. And with C, what can you remember? There is caudate atrophy. Sorry. Caudate atrophy. Caudate atrophy. Okay. Okay. Now, all of the following are features of Fragile X syndrome. So, what do you remember? Fragile X is also a very, very easy thing to remember. I remember it with an image. Look at this. This is the image. You can remember it like this. Why? Because again, Fragile X syndrome is the second, it's familial mental retardation gene. So, again, दिमाग है क्या? नहीं, there is no mind. Okay, mental retardation gene है. So, mental retardation is present, okay? And how are the ears? They are long everted ears, yeah, large everted ears. And how is the mandible? Again, it's a long mandible. And this patient has macro-orchidism. Okay, so what is not present in Fragile X syndrome? Tell me. What is the answer? Trinucleotide repeat hai, FMR1 gene, definitely. Second most common cause of mental retardation, most common being Down syndrome. Mental retardation is there, large everted ears, but macro-orchidism hai, micro-orchidism nahi. Okay, so it's very, very, very funny. Okay, but definitely unko nahi, jisko hota hai na. Which of the following has hexanucleotide repeat? So this was asked once. Hexanucleotide repeats kisko? Who has it? Frontotemporal dementia in your FMG 2024. Okay? Amir Khan, PK. Okay. So these are structural disorders. What question was asked in your exam? What question had come in your exam? It was this balanced translocation, balanced reciprocal translocation. Anyways, we will do it. Go through the notes. They're important. We'll do it, what do you say, in our, when we do CML. Okay? See, which mutation is linked to Philadelphia chromosome? Can anybody tell me? Acha, can you just let it be? This is not a right question. Look at this. A newborn presents with hypotonia, upward slanting palpebral fission, a round facial profile, flat nasal bridge, inward incurved small fingers. Okay? What is this? This is nothing but, sabko aata hai ye. This is your, what is this? Yahan pe, what do you say? Okay, this is wrong. It should be, what is this? Can anybody tell me? What is this? Can anybody tell me this? This is your Down syndrome. This is your Down syndrome. Okay, this is your Down syndrome. Right? Yes, this is Down. So the options are given wrong. Please correct them. This is your Down syndrome. Is that clear? So Down syndrome. This is the most common trisomy overall. And you must have seen, I've just seen a model that was a Down syndrome kid. Okay, on Instagram I was able to see. This is the most common cause of intellectual disability. But she draws also. Have any one of you seen? There's this kid who went for modeling and she draws also very well. Down syndrome. So what is the main cause of this? Maternal meiotic disjunction. Main problem is maternal age. Okay, especially after 35. It's very hard to, you know, the ovum. Maternal age is the biggest risk factor, right? And what do you need to remember? Look at the clinical features. Go through the test also, it's important. What do you see? You see a sandal toe gap. Every Down syndrome patient has mongoloid facies, okay? Has mongoloid facies. What is mongoloid facies? What was described in the question? Flat nasal bridge and then upward slanting palpebral fissures and macroglossia, micronathia. Okay, these are all mongoloid facies. What do you see? This crease, one single palmar crease. You look at your palm, there must be three lines usually. Okay, I hope you have 3 lines. Okay, so this is simian crease where you have one single palmar crease. Okay, and in the eyes you have brush field spots. Okay, brush field spots. Edward and Patau, in your exam, what had come for, what do you say? Patau syndrome was asked. What do you call it? Patau syndrome was asked. So Edward and Patau, again, they are trisomies. Trisomy 18 is Edward syndrome. और 13 साल की लड़की को पटाना है नहीं पटाना? Edward is trisomy 18. Patau is trisomy 13. Okay, trisomy 13. All right, trisomy 13. Very, very important. This was asked in the question. It presents with mental retardation, rocker bottom feet, both. But polydactyly, cleft palate, Columbo of iris, this is seen mainly, this is been seen specifically in Patau. P for P. Remember, polydactyly, cleft palate is seen in Patau, PPP. What about your prominent occiput, micronathia, overlapping flex fingers? This is seen in Edwards syndrome. Okay, so here you can see Your chromosomes are given. Tell me, all of them are in pair except for this one. What is this? Can anybody tell me what is this? Which syndrome is this? This is trisomy. Trisomy. Can anybody tell me? Count. 1, 2, 3, 4. This is trisomy. Batao, jaldi batao. Edward. Okay, trisomy 18. Very good. It is Edward. What about this one? What about this one? This is trisomy. This is your Down syndrome. And Patau syndrome, karyotyping was given. Okay, karyotyping, when do you do? In the metaphase. Okay, how do you arrest the lymphocyte? Usually you use lymphocyte. How do you arrest it? With colchicine. Okay, and with stain? Yes, good. ये वाला कौन सा? This is trisomy 13. ठीक है, रॉयल खान दिख रहा है आपको? This is trisomy 13. चलेगा? Trisomy 13. Okay? Patao, Edward. Okay, good. Now what about this one? Look at this child. Tall male with gynecomastia, testicular atrophy. What is this? This is your Klinefelter syndrome. Again, what is it? One extra X chromosome. So the male has atrophic feminizing features, doesn't have absence of secondary sexual characters, right? Absence of secondary sexual characters. And there is gynecomastia. What are the drugs that cause gynecomastia? Does anybody know? And because there is an extra X chromosome, do you remember Lyon's hypothesis where one X undergoes a random, inactivation? So there is a presence of Barr body, right? And mitral valve prolapse risk. What is this? This is your Klinefelter syndrome, 47 XXY. What about Turner syndrome? Turner syndrome is a short female. Okay, Turner syndrome, she is a short female with one X chromosome lost. Okay, and her ovaries are streaky. So there is absence of secondary sexual characters, right? Streaky ovaries, and she presents because she has absence of secondary sexual characters. She never gets her periods. Okay, so she presents with primary amenorrhea. Flat chest. You can start from the top. Her IQ is normal because in Noonan syndrome, what happens to the IQ? IQ is low, right? So IQ is normal. She's short. Her neck is webbed. More the webbing, more severity. And then as you go down, her chest, it is shield-shaped chest. You have widened nipples, widely spaced nipples, and she has fourth short metacarpal. Okay. What is the most common congenital, heart disorder in your Turner syndrome? Can anybody tell me? Heart disorder? Heart defect? She has bicuspid aortic valve, normal IQ. Usually Turner syndrome has normal IQ. Okay. Now look at this genetic abnormalities and match them. Trinucleotide repeat. So, trinucleotide repeat, tell me which one? Huntington's. Okay, I can match it with Huntington's. Trisomy 18 is Edward. Trisomy 13 is Patau. And this is sickle cell anemia. So what is the answer? 1B, 2D. Very good. So 1B, 2D, 3A and 4C. Is that clear? Okay, bicuspid aortic valve. Very good. Carolyn Francis. Very good. Okay, let's go to the last chapter and we are done with general. Okay, and general, usually 5 to 8 questions come from general, and general many times integrates with others. So 8 questions you can expect. Okay, so characteristic of neoplasia, always remember what are the features of cancer. You have anaplasia where there is no differentiation. You cannot tell the tumor. Okay, differentiation is what? How the tumor cells are similar, okay, in function and morphologically to the normal cells. Okay, so absence of differentiation matlab I will not behave like the normal cells, I will not look like the normal cells. Okay, rate of growth is definitely higher when we talk about benign tumors. They are well differentiated, while malignant tumors are undifferentiated. What about your local invasion? This is the biggest, second most common reliable sign of malignancy. What is malignancy? It is when you, what are the two signs of malignancy? Metastasis, spread. Okay, whenever I have invasion, means I've invaded from the normal tissue, remember I've become malignant. Okay, so local invasion, nearby tissues I am invading. What about metastasis? Distant organs I am invading through blood or lymphatics. Okay, that is known as metastasis. All malignant tumors metastasize except for your gliomas of CNS like astrocytoma, basal cell carcinoma. One question was asked on basal cell carcinoma. The whole history was given, right? I've put it in this PDF. Now, what are hematoma, teratoma, choristoma? Now, when we talk about choristoma, this is normal tissue but found in abnormal location. Okay, normal tissue but in ectopic site. I always remember it like this: normal tissue, but how is the site? Ectopic. Okay, ectopic site. So remember, choristoma is ectopic site, abnormal site. What about hematoma? The tissue is abnormal but normal site. Okay, so pulmonary hematoma. Please tell me what kind of, especially pulmonary hematoma, what appearance is given in pulmonary hematoma? Can anybody tell me? It will invade, Bhavashit, it will invade. Okay? Popcorn appearance, very good. Popcorn appearance. Yes, it is. Yes, it is. Popcorn appearance. Basal cell carcinoma is also, see, when you say carcinoma, it is malignant already, no? Carcinoma. Okay, it is the malignant tumor. The nomenclature of, always learn neoplasia like this. Understand the nomenclature, then see it under the microscope. I always tell you in classes. Okay? Now, popcorn calcification is seen in pulmonary hematoma. Popcorn appearance on mammography. Can anybody tell me? Can you remind me? Popcorn appearance on mammography. Where do you see it? In fibroadenoma. Do you remember? Okay. Teratoma, put a star mark. Again, it was asked very recently in your exam. Many times the images is asked. They ask you what kind of tumor is this. So it is composed of tissue with more than one germ layer, like the endoderm, mesoderm, and your ectoderm. Okay, that is why, and it originates from totipotent cells. Remember, this is the most common benign tumor. Most common benign tumor of ovary. Okay, ovary and testis also, right? Usually it is benign. It is a mature teratoma. Most commonly, it is seen as a mature teratoma. So that was the answer. Okay, what is desmoplasia? It is your response to cells. Okay, what is desmoplasia? It is excessive fibroblastic response of triggered by neoplastic cells, leading to the formation of dense connective tissue. That's why usually cancer, like if there is any cancer, when you touch it, it's very hard because of desmoplasia. Is that clear? Look at this question now. A 22-year-old woman with a large tumor in the right ovary shows it originates from all three germ layers. What is this? What is this? Dysgerminoma in females is known as seminoma in males. Okay, seminoma in males. And seminoma in males, you have this potato appearance. That was an IBQ that came recently in your exam. Okay, very good. This is a teratoma. Now, if I have to choose between mature and immature, remember mature is more common. Okay. Now, what is the differentiating factors between metaplasia, dysplasia, and anaplasia? Remember, metaplasia is an adaptive change. It is reversible. All adaptive changes are reversible. Dysplasia is partially reversible in the sense that low-grade dysplasia you can reverse. But once it involves whole epithelium involvement is there, please remember, it is irreversible. When the whole epithelium is involved, it is irreversible. What is dysplasia? It is a disordered growth of cells. See, cells are supposed to grow normally, okay? But because you are having so many cells, the order gets disordered, okay? And because of this, there is change in uniformity. So they lose architecture. They become disorganized or disarranged, right? Disordered growth of cells. And this is a pre-malignant change. Okay, this is a pre-malignant change. Please remember, what is anaplasia? It is the hallmark, molecular hallmark of cancer. Is that clear? It is irreversible. Now, you will see all these on microscope. Pleomorphism. What is pleomorphism? There is variation in shape and size. This is seen in low grade. Remember, we are talking about grade whenever we look under the microscopy. What about your stage? Stage matlab how far it is spread. Always remember, what is grade? When I say grade of cancer and all, what am I doing? I am looking at it under the microscope. I am telling you the microscopic changes, grade of the tumor. Okay, what about stage? Stage matlab spread. Always remember this, stage with spread, how far it has spread. Okay, so that tells you the stage of the cancer. So which will tell you prognosis better, grade or stage? This was the question that was asked in your exam. Which is better, stage or grade? Which will give you a better prognosis? It's very logical, right? If it has spread too much, will you have a better prognosis? Yes or no? No. So which one? Solid tumors, what is best to check? You always check for stage, and it gives you the prognosis. Okay, it gives you the prognosis. Is that clear? Is that clear? So what is pleomorphism? There is variation in size and shape. What about hyperchromasia? Because the nucleus is continuously dividing, because there is more, what do you say, function of the nucleus, there is hyperchromasia, and this is more blue color. That's why tumor cells appear blue in color, right? Mitotic figure is definitely when there is a lot of mitosis, there will be mitotic figure. Now, nuclear, what do you say, nuclear to your NC ratio, nuclear to cytoplasmic ratio usually is 1:4. It increases in your, what do you say, dysplasia, but it is 1:1. The nucleus becomes as big as the cytoplasm in anaplasia. Is that clear? These are the examples of all three. Now look at this question, which was asked in NEET PG 2022. There is a pap smear that shows hyperchromatic nuclei, marked pleomorphism, low maturation index, atypical cells almost the full thickness of the epithelium but do not breach the basement membrane. What is this? Is this cancer? See, the whole epithelium is involved, but they do not breach the basement membrane. Please remember, what is this? This is carcinoma in situ. When the whole epithelium is involved, whole epithelium involved, but what is not breached? But basement membrane intact. This is your carcinoma in situ. Is that clear? Okay. Now, whenever we do neoplasia, I always tell you, first understand how to name them. Name the tumor. Then see them under the microscope. Okay, under the microscope. Then see what are the genetic problems due to which cancer cannot occur. Okay, so what are the mutations, right? So we have growth factors, tumor suppressor genes. We have our oncogenes, tumor suppressor genes, DNA repair genes, and apoptotic genes, right? If there is a mutation in any one of this, that will lead to cancer, right? So oncogene mutation. This is a table that you have to by heart, okay, and can come in the exam. Like, let me show you if there is a question. Okay. Very recently, BRAF mutation was asked. Okay, BRAF mutation was asked. Then we have had c-MYC mutation in the FMGE exam. c-MYC mutation leads to what? What are these? These are all genetic mutations. So growth factor mutations, PDGF, you have your astrocytoma. Okay, breast cancer, B2, your HER2 new leads to breast cancer. Everybody knows this. These are growth factor receptor mutations. Okay, gain of function. Remember, there is a gain of function in all the oncogenic mutations. Red gene mutation will lead to medullary carcinoma. Again, this is a previous year question. Adenocarcinoma lung happens due to ALK gene mutation. Anaplastic tumor, neuroblastoma, they are all associated with ALK gene. It leads to GIST. These are things that you have to remember, okay? RAS is the most common, please remember, RAS is the most common oncogenic mutation. Most common oncogenic mutation. Okay, most common oncogenic mutation. Right? ABL BCR fusion, again it causes CML. That's very, very important. CMYC, NMYC, LMYC. CMYC is BC, Burkitt's lymphoma. LMYC, less small cell lung carcinoma. And NMYC, N for N, neuroblastoma. They're very, very important. Okay? Cyclin dependent kinases. See, whenever you want to start a car, always remember genes. Okay? Genes, you always think of car. How do you increase the speed? You increase the speed by pressing on the accelerator. Who increases cell growth? It's your oncogenes. Okay, oncogenes. So gain of function in them will lead to cancer. What about tumor suppressor genes? They act like brakes. Okay, tumor suppressor genes, they will stop the growth. They decrease growth. Right? What about DNA repair genes? These repair the DNA. And apoptotic genes, this will kill the cell. Right? So these are the 4 genes. Now you need cyclin dependent kinases and cyclins. Why? Whenever you want to start a car, you need the engine to work, right? What is the engine dependent on? The key. What is key? Your cyclin. Okay? Your cyclin. What is the engine? The cyclin dependent kinases. Your engines will always depend on the key. Right? So cyclins work with cyclin dependent kinases and they push the cell into the cell cycle. Okay, so DEAB pushes. What does it require? It requires cyclin dependent kinases 4, 6, 2, 2, 1. You have to remember the sequence. Okay, now when you look at this cell cycle, how does it go? G1S, G2M. Okay, now out of this, please remember, we always have a checkpoint. See, whenever you cross borders or whenever you go from one city to another, you always have a checkpoint, right? Just like that, tumor suppressor genes, what do? They stop the cells so that they can check whether the cell is normal or abnormal. So G1S phase, what do we have? We have RB gene and P53. G2S phase, we have P53 plus BRCA gene as well. Remember, P53 is present in both, okay, but has greater activity for G1S checkpoint. This is a previous year question. G2M are the most sensitive, again previous year question, and S phase is the least sensitive, okay. Ewing sarcoma is very highly associated with radiation. Seminoma are the most common sensitive testicular tumors, okay. Lymphocytes are the most sensitive cells, while platelets, what are platelets? They are radio resistant. Okay, radio resistant. And what is the most common or most radio sensitive tissue or tissue? Can anybody tell me what is the most radio sensitive tissue? Again, I'm telling you all the questions that are asked as well. What is the most radio sensitive tissue? Anybody knows? Okay, now this was asked in FMG 2024. What is the most radio resistant phase of cell cycle? It is your S phase. Now, if I ask you most sensitive, what is it? G2M. This is the most sensitive phase of your cell cycle. Is that clear? Now, what are the tumor suppressor genes? Again, if there is a loss of function in them, okay, loss of function, it will result in all these mutations. Okay, loss of function will result in all these mutations. Okay, loss of function will result in all these mutations. RB gene, if RB gene is lost, you have retinoblastoma, osteosarcoma. P53 is the most common gene mutation overall, plus you have the familial, mutation leading to Lee-Fromeny syndrome. APC, colon cancer, very, very important, previous year question. BRCA, just now Aini said question, BRCA was asked. VHL, again this was asked in NEET PG, VHL, 3P gene deletion, okay. It leads to renal cell carcinoma. There was a question on that. Okay, so what about WT1 and WT? VHL was asked in FMG as well. Okay, FMG as well, just recently, FMG 2025. NF1 and NF2, you know it causes neurofibromatosis. NF2 especially, can you tell me what does it lead to? I have just told you, miss me. Okay, when this session is over, miss me. What about CDH1? It leads to cadherin loss, right? Cadherin is lost. It can lead to stomach cancer, your gastric adenocarcinoma, diffuse type, and lobular invasive breast carcinoma. Again, this was your previous year question. STK11, again, so many times it has been repeated. It leads to Peutz-Jeghers syndrome. Perioral melanosis is there, right? P10 leads to Cowden. P10 leads to Cowden. Okay, is that clear? You remember it as P10B. Okay, P10B. It leads to polyps, breast cancer, thyroid, and endometrial cancer. Okay, is that clear? Now, look at this question that came recently in your exam. Look at this question. A 3-year-old child has leukocoria and absence of red reflex in the left eye. Tumor biopsy shows loss of cell cycle control. That means there's a problem with some tumor suppressor gene. Okay. So what is the most likely diagnosis? It is retinoblastoma. And what do you see here? It is retinoblastoma. And what do you see here? Retinoblastoma. It has Winter-Steiner. Yes, Flexner-Winter-Steiner rosettes. Okay, very good, very good. What do you see here? Flexner, Winter-Steiner rosettes. Okay, rosettes. Is that clear? Rosettes. Very good, very good, very good, guy. Okay, rosettes. Okay, yeah, they are known as the true rosettes. क्योंकि आँखों में हमेशा सच दिखता है, right? Look into my eyes, yeah, look into your own eyes. जब भी आप आँखों में देखते हैं सच दिखता है, right? So these are true rosettes. Okay, they are true rosettes. What about other rosettes we have? We have see small blue cells surrounding a blood vessel. Okay, surrounding a blood vessel. What is this? This is your perivascular pseudorosette. Okay, perivascular pseudorosette. Where is this seen? Can anybody tell me? Where is this seen? This is seen in ependymoma. Ependymoma. Okay, what about another one? We have small blue tumor cells surrounding a pinkish material. Okay, surrounding a pinkish material. These are known as Homer-Wright pseudorosettes. Okay, Homer-Wright pseudorosettes. Okay. And where are they seen? They are seen in neuroblastoma. They are seen in, yes, very good, neuroblastoma, Ewing sarcoma. They are also seen in, can you tell me, where else are they seen? Neuroblastoma, ependymoma, and medulloblastoma. Very good. What is the other one? We have one more, right? Does anybody remember that? Yes, very good, very good. So these are your pseudorosettes. Yes, so they are seen in medulloblastoma, and Ewing sarcoma, and neuroblastoma. Okay. Now Flexner-Winter-Steiner, what are these? You have blue tumor cells surrounding nothing. Okay, there is empty space. So these are known as the true rosettes, which surround empty space. If anything comes in between, that is a fake rosette. Okay? What is that? That's a sap. Okay. Now look at these questions. Which of the following is associated with BRCA gene? Look at this. Which of the following is associated with BRCA gene? Try to solve this question. Try to solve this question. Okay. So when we talk about what is associated with BRCA gene? Okay, what is associated with BRCA gene? Remember, Fanconi's anemia. What is Fanconi's anemia? Fanconi's anemia. Tell me, is it a tumor suppressor gene? Yes, it is a tumor. Will it lead to risk of development of ovarian cancer? Yes. Is it DNA repair? What is it? It's a tumor suppressor gene. It will lead to development of ovarian cancer. But will it lead to mutation seen in subset of Fanconi anemia? Fanconi anemia leads to remember, this is due to DNA repair. Okay. So what is the answer for this? There is a mutation in a DNA repair gene, homologous DNA repair gene, right? For Fanconi's anemia. So what is the answer for this? 1, 2, 3. Okay. 1, 2, 3. Match the following gene with its cancer association. This is how questions can come and have come in your INI set. Okay. So KRAS, you match it with what? KRAS is seen in colon, lung, pancreatic tumors. KIT is seen in GIST. JAK usually is seen in what? Polycythemia vera, and ALK gene leads to lung cancer. 1A, 2B, 3D, 4C. Is that clear? Is that clear? Today's GT 158, very good cable, very good. I'm very proud of you. Good, it was a moderate paper, so I'm happy you scored well. All right, now look at, always remember what can cause cancer. You have chemical carcinogens, you have biological carcinogens. So this is the next part of neoplasia, very important. When we talk about chemical carcinogens, alkylating agents will lead to AML and bladder cancer. You don't need to remember dyes will cause bladder cancer. What about angiosarcoma of liver? This is a previous year question. Arsenic, polyvinyl chloride, your pipes, okay, and thorotras can lead to angiosarcoma of liver. Asbestosis, put a star mark. This is a previous year question. Most common cancer is adenocarcinoma. Most specific is mesothelioma. Okay, most specific is mesothelioma. Estrogen leads to, definitely you know this, benzodiazepine, will lead to bladder cancer. What about benzene? AML. Okay, benzene will lead to AML. Is that clear? Look at the questions that were asked. Hepatic angiosarcoma is associated with, can you tell me what is it associated with? It is associated with arsenic. Okay. What about asbestosis? Most commonly associated with which malignancies? It is mesothelioma. Okay, mesothelioma. All right, mesothelioma. Let's go to the biological carcinogens. Now, these are your biological carcinogens. Out of this, which is very important, which came just now also, HPV, HV8, because it leads to Kaposi sarcoma. Okay, all of them are very, very important. EBV, again, they'll ask you, nasopharyngeal carcinoma, Burkitt's lymphoma, Hodgkin's lymphoma, they're all associated with EBV, right? Which among the following carcinogens is associated with hepatocellular carcinoma? Can anybody tell me? Hepatocellular carcinoma? Yes, bronchogenic carcinoma is nothing but adenocarcinoma. No, we don't have that in options, right? Anonymous, that's why we chose mesothelioma, right? Hepatocellular carcinoma, please remember it is associated with aflatoxicosis. Aflatoxicosis, how do you get it? It's a fungi, okay? It comes from Aspergillus flavus, right? Aspergillus flavus. And where? To the farmers in groundnuts, yes, groundnuts, right? Arsenic will lead to angiosarcoma of liver, asbestosis, like I told you, most common is adenocarcinoma. The most specific is mesothelioma. Benzene will lead to AML. Benzidine, bladder cancer, okay? Now, with respect to HPV, remember one thing about HPV, it is made up of two proteins, E6 and E7. And HPV, we have two strains, right? Can you tell me the strains? One that causes warts, one that causes cancer. What causes warts? HPV 6 and 11. HPV 6 and 11, what does it cause? Warts. What about HPV 18 and 16? This causes cancer, right? What warts? You remember condyloma acuminata, right? Those are the warts that are caused by HPV 6 and 11. So when we talk about HPV 18 and 16, what do they have? They have two proteins, E6 and E7. Remember E6, what will it do? It will inhibit P53. What about E7? It inhibits RB. Okay, and you can see we do pap smear. We do pap smear and find out whether this is exfoliative cytology, right? Whether there is any problem or whether the cells are abnormal. So what do we see when we do this exfoliative cytology? First of all, what is this instrument? Can anybody tell me? Can anybody tell me which instrument is this? हाँ बताओ, जल्दी बताओ. This is your? Yes, very good. This is your speculum, right? Now you will be able to see coelocytes. Yes, coelocytes. Very good. 31, 33, 16, 18. Look at this question that came in NEET PG 2022. Look at this question. Now with respect to this question, what do you see? Warty lesions on vulva and perianal lesion. She has high risk HPV type. Which HPV type is more strongly associated with the progression to cervical cancer in this patient? Cervical cancer, again, this you have your 16, 18, most specifically 18, right? 6, 11, you have, it is associated with warts, okay? And what is this warts here that you can see in the perianal region? This is condyloma acuminata. Right? They are showing you warts, but they are asking you progression to cervical cancer. So if you look at just the image, you will want to mark 6 or 11. But they are asking you what is associated with cervical cancer. So that is 18. With respect to DNA repair, there was a question that was asked in NEET PG 2024. Okay. What was the question? It was a question on xeroderma pigmentosum, right? What did they ask? See, nucleotide excision repair, you have the presence of pyrimidine dimers, okay? So there will be increase in pyrimidine dimers. If you don't have, if there is a defective in NER, there will be an increase in pyrimidine dimers, all right? That leads to xeroderma pigmentosum. Just remember, mismatch repair gene lead to HNPCC, okay? Also known as Lynch syndrome. And recombination repair leads to FAB or Fanconi's anemia, ataxia and Bloom syndrome. Okay? If there is a problem with DNA repair genes, these are the genes and this is what it leads to. Okay? How do you diagnose cancer? You have immunohistochemistry. All of them are very important. Okay? They are very important, and tumor markers. There have been questions that have come from tumor markers. Let's just do these questions and we'll go back to them. A patient's presence with hypertension, palpitation, sweating. His catecholamine and aldosterone level were found to be elevated. What is the most likely diagnosis? So catecholamines, where do they increase? Guys, you tell me, where do they increase? Catecholamines. They increase in pheochromocytoma. Very good. They increase in pheochromocytoma. You can see here, you have tumor markers. What are these? These increase in any kind of blood, saliva or any kind of bodily fluids, okay? And they are associated with tumors like beta-hCG. It is associated with choriocarcinoma, okay? And there was a question that was asked, what is choriocarcinoma associated with? Very poor prognosis, happens in elderly patients, and there is pulmonary metastasis, okay? Leading to which appearance? Leading to which appearance? Cannonball metastasis, okay? Cannonball metastasis, right? This was X-ray that was given. What about calcitonin? Calcitonin is associated with medullary thyroid carcinoma, very important, okay? You'll get the PDF. Catecholamines is associated with pheochromocytoma. Your 5-hydroxyindole acetic acid, 5-HIAA, carcinoid tumor, flushing, diarrhea, right? vinyl mandelic acid, neuroblastoma, pheochromocytoma, again very important. Alpha fetoprotein, again AFP, it is seen in liver cell cancer like hepatocellular cancer. Okay, AFP. Recently they had asked what is the tumor marker for hepatoma. Hepatoma is nothing but a old name of hepatocellular carcinoma. Okay, so hepatocellular carcinoma. And non-seminaceous germ cell tumor like yolk sac tumor. Okay, yolk sac tumor. CAE, definitely colon, pancreas, lung. Prostatic, you know, it's neuron specific enolase for small cell carcinoma. Immunoglobulins, very, very important, multiple myeloma. And you have CA125, C1, 2, 3, 4, 5. It is for ovary. CA19-9, you just turn it, it becomes, it looks like pancreas, right? CA15-3, you turn it, it looks like, right? Of course, imagine, okay? Which of the following tumor marker is for carcinoid tumor? See, I told you it's a previous year question. Tell me. So very direct questions, okay? Yeah. This is your 5-hydroxy-indole acid. This is for medullary thyroid carcinoma. Catecholamines is for pheochromocytoma. Okay, pheochromocytoma. Is that clear? Okay, look at these questions. Let's finish them fast. Testicular tumor, raised LDH. Okay, raised LDH. Normal AFP, beta-hCG is increased. Post-orchidectomy histology is provided. It's not given here, but you understand this is a young patient. What is it? Normal AFP. AFP is increased in yolk sac tumor, so I can rule it out. Okay? This must be seminoma. If they have to ask about teratoma, they would have told me about germ layers, right? This is seminoma. Is that clear? Why not A? Because A, just now I told you, no, yolk sac tumor, what increases? Alpha fetoprotein, please do not. And which bodies do you see in yolk sac tumor? Schiller-Duval bodies, right? What about this? This was given in FMGE 2024. A slow-growing tumor, ulcerated nodule over the tip of the nose. Chronic sun exposure due to outdoor work. Histopath is given. What is this? This must be, see, near the nose means medial epicanthus, okay? Ulcerated nodule, so it is pointing towards basal cell carcinoma, okay? Basal cell carcinoma. Malignant melanoma, do you remember? It has ABCDE. It is asymmetric, okay? The borders are irregular, then colors are different, diameter is more than 6 mm, and evolution. Squamous cell carcinoma, there will be horn-like appearance, okay? And they'll mention cytokeratin or some IHC marker or paraneoplastic syndrome, okay? With this, we are done with general, okay? With this, we are done with general. Now we will be faster. Is that clear? Are you still with me? Did you survive? Did you survive? Did you survive? Are you here, guys? Subiksha, very good. Wow, 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 dopamine. Yay, patho. Yes, very good. Chalo, I'm happy you survived. So with respect to hematology, we have RBC disorders, WBC and platelet. Okay, so let's do question by question. Shall we continue? Shall we finish our hematology? Shall we continue? या बस हो गया आपको आज के लिए? बोलो, 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 जल्दी बोलो. Yes, ma'am. Stop, ma'am. Okay, chalo, good. Now let's go to our RBC disorders. Look at this. What is the answer? There's an 18-year-old male with gum bleeding and fever. Okay. See, there is gum bleeding and fever, right, for the past 2 months. General examination shows pallor and systemic examination is unremarkable. Lab test reveals a hemoglobin of 3. That means our normal hemoglobin is 12 and 13, right? But this male has 3 hemoglobin. That means this patient has anemia. TLC is 1500 while normal is 4002. 11,000. So this is leukopenia. Okay, so you have leukopenia, and platelet count is 15,000 while the normal is 1.5 to 4.5 lakh. So there is thrombocytopenia. So this patient actually presents with thrombocytopenia, okay, anemia and leukopenia leading to pancytopenia. Okay, pancytopenia. The patient has pancytopenia, and what does the bone marrow show? Fatty streaks and absent megakaryocyte with no immature cells. That means the whole bone marrow is filled with fatty streaks, right? This is nothing but your aplastic anemia. Okay, most common cases are idiopathic. We don't know why it happened, but one infection that can cause. So pancytopenia without hepatosplenomegaly. Usually, this is the presentation. Splenomegaly. And what will they give you? They'll give you a case. Okay, they'll give you a case. A case where when you did a bone marrow aspirate, what happened? You were not able to aspirate anything. There was a dry tap. Okay, bone marrow biopsy will show you a lot of fatty streaks and less hematopoietic stem cells. Okay, let me remind you. See, for your bone marrow biopsy, you use Jamshidi needle, okay, and for aspirate, you use Klima and Sala needle. Aplastic anemia, you can see these are the bony trabeculae, okay, bony trabeculae, and you can see there's a lot of fatty streaks, okay, a lot of fat and less cells. This is aplastic anemia, okay, this is aplastic anemia. Suddenly it happened. What infection is associated with this? Parvovirus B19. Oh, pancytopenia is there, and absent splenomegaly. Please remember, the presentation will be like that. Pancytopenia, absent splenomegaly, reticulocytopenia. Your bone marrow fails to make any cells, okay? So retic count will be low. Retic count will be low. Is that clear? Aplastic crisis is often triggered by parvovirus B19. Now, dry tap. What are the differential diagnoses of dry tap? Can anybody tell me? It's a previous year question. Dry tap. Can anybody tell me? You have, firstly, aplastic anemia. Okay, aplastic anemia. Then what else do you have? You have Down syndrome. What do you say? AML M7, that is associated with Down syndrome. That also presents with dry tap. You have hairy cell leukemia. Okay, hairy cell leukemia. And also, what else? You have myelofibrosis. All of them have dry tap on bone marrow aspirate. Okay, dry tap on bone marrow aspirate. Now look at this, reticulocytes. We have talked about reticopenia. So what is a reticulocyte? It's a premature RBC that is present in the blood. The first RBC to come in the blood is a reticulocyte, okay? And this is an indicator of bone marrow function. What is a reticulocyte? It's a indicator of bone marrow activity, whether the bone marrow activity is normal or abnormal. Imagine there is blood loss, okay, and you have a high retic count. That points, if there is a high retic count, remember, it points towards hemolytic anemia, where there is destruction of your RBCs, okay. So bone marrow is functioning normally, so it will make more RBCs, right? It's a negative feedback. But what about hypoproliferative anemias? Like, let me give you an example. Iron deficiency anemia, or megaloblastic anemia, or aplastic anemia. What is happening? Your bone marrow dysfunctions. Bone marrow is not functioning properly. Okay? That leads to decrease in retic count. Okay? Hypoproliferative anemia leads to decrease in retic count. Remember, these are immature RBCs, and what is the problem with them? They're bigger than RBCs. They have remnants of RNA in their cytoplasm. Okay, and how do you visualize it? On supravital staining. On supravital staining, you can visualize it. Supravital staining. Which stain do you use? The best stain for supravital staining is new methylene blue. Okay, new methylene blue. Is that clear? Yeah, brilliant crescile blue also, new methylene blue. Now, what can you see here? This is your, reticulocyte, and it contains meshwork of RNA. Meshwork of RNA. Is that clear? Now, these are the RBC morphology. Go through them. Okay, go through them. They're important. This is a direct page taken from the first aid. Classification. First, when we do classification, remember you should be able to tell me the RBC indices first. Okay, indices. What are the RBC indices? You have your MCV, mean corpuscle volume, which is 80 to 100 femtoliters. What else do you have? You have MCH, which is mean corpuscular hemoglobin, which is 27 to 32 picograms. Okay, picograms. What about MCHC? MCHC, this is mean corpuscular hemoglobin concentration, which is the amount of hemoglobin present in the hematocrit, yeah, your pure, what do you say, red cell volume, right? PCV. So this is 33 to 37. Okay, 33 to 37. And what is RDW? It is the range of, it is the variation of size in your RBCs, which is 11.5 to 14.5. These are RBC indices. And what is the RBC count? It is 4.5 to 5.5. This is the normal RBC count. Is that clear? This is the normal RBC count. These RBC indices you should always remember. Okay, this RBC indices you should always remember. Now we can classify anemias on the basis of MCV, which is nothing but the volume of RBC. Okay, they can be big or small. Small RBCs are known as microcytic. They are less than 80. Right? What are the examples? We remember it as tails, Sita, Sital, anything. All microcytic, normochromic, and macrocytic RBCs. Macrocytic, where you have RBCs more than 100 femtoliters, right? So remember it as fat RBC. What was the question that was asked in your exam? They had asked this question in FMGE 2022. In which of the following condition is macrocytic anemia typically seen? Look at this. Can you say? Crazy. Tell me. Can you tell me? What time class gets over? I'll let you know. So we started at 2, right? By 8 o'clock, I think we'll be done. Yeah. What is the answer for this? Where do you see macrocytic anemia? Okay, you see it in liver disease. Please remember, in liver disease, you see macrocytic anemia because lipids keep accumulating inside the cells, right? So in liver disease, you see macrocytic anemia. Thalassemia, anemia of chronic disease, sideroblastic anemia, all are examples of microcytic anemia. So please remember this. Questions have come from this as well. What about your normocytic, normochromic anemias? Please remember, you have two types of anemia. You can have high retic count and low retic count, right? High retic count is when you have hemolysis, destruction of RBCs, right? I'm completely fine, but somebody else is destroying me. That is hemolytic anemia. It has a high retic count. What about low retic count? There's a problem with me itself, okay? Bone marrow failure, okay? Or there can be a problem with stimulation to the bone marrow, okay? So kidney failure. If there is renal failure, I don't have erythropoietin, I cannot stimulate the bone marrow, it leads to anemia. Anemia of chronic disease, I am stopping, okay? This is a kind of anemia which is mostly normochromic. Please remember, it is mostly normochromic, then normochromic, okay? And normochromic, and this anemia happens because of interleukin 6, lot of inflammation. It's an anemia of chronic disease. Now, myelofibrosis, this anemia happens because the whole bone marrow is filled with fibrous tissue, okay? Fibrous tissue, so it cannot make enough RBCs. Cancers metastasizing like myeloproliferative anemia. Myeloproliferative anemia. What happens? Cancers like prostate cancer, and breast cancer, they metastasize to the bone marrow, okay, leading to failure of, like, you will not be able to make RBCs. Is that clear? Let's talk about your hemolytic anemias. When we talk about hemolytic anemias, look at this. Which of the following is not a feature of hemolytic anemia? Look at this. So when we talk about hemolytic anemia, you have intravascular hemolysis and extravascular hemolysis, right? See. Very good, Naveen. 204. Very good. The results came. Good job. Okay. Now look at this. When we talk about intravascular hemolysis, see, all of the following, which of the following is a feature of hemolytic anemia? Which is a feature? You have decreased haptoglobin. Okay, so when you look at intravascular hemolysis, what is happening? There is hemolysis occurring inside the blood vessel. So what will happen? Hemoglobin will come out. It will bind to haptoglobins, and you will have saturation of haptoglobin levels. Now, hemoglobin, if there's a lot of hemolysis, you will still have hemoglobin that is free, that will go out from the kidney to the urine, leading to hemoglobinuria. It can get oxidized by the PCT cells into hemosiderin, but they are toxic. Hemosiderin is a free radical, so it is toxic to the PCT cells. So it will again go into the urine, leading to hemosideриnuria. And there is no hepatosplenomegaly here because the destruction doesn't happen in the liver or the spleen. What about extravascular hemolysis? It comes with a triad of hepatosplenomegaly, jaundice and anemia. Okay, extravascular hemolysis. It occurs in spleen and liver. What are the examples? Very, very important. G6PD, you see both. Okay, both extravascular and intravascular hemolysis is seen. Mostly all the disorders are extravascular. Remember, they will present with this triad, right? MAHA, microangiopathic hemolytic anemia, like your TTP, DIC, HUS, HELP syndrome, they all lead to intravascular hemolysis. Is that clear? Okay. Let's do a question first. Look at these two questions. Which of the following? These are the questions that were asked in your exam. Look at these questions. Which of the following correctly represents the effect of the mutation causing sickle cell anemia? Which of the following does that? What is replaced by? Yes, good boy is replaced by villain, okay, at beta 6 position, okay, is valine replaced by glutamate or good boy to villain? So glutamate is replaced by valine at beta 6 position of your hemoglobin, right? What about this? A patient presents with fatigue, pallor and generalized weakness. Lab shows a low hemoglobin. Retic count is markedly increased. What is this pointing towards? Can anybody tell me? Retic count, if it is increased. Can your retic count increase in iron deficiency anemia? Can it increase in anemia of chronic disease? Pure red cell aplasia is when you have decrease in erythroid precursors. So in all of this, what will happen to retic count? That will actually decrease. So this is hemolytic anemia. Why A? Retic count is increased, right? So you're making more RBCs. Where will it be increased? It will be increased where the destruction is occurring outside the bone marrow, right? Is that clear? Did you get it? Okay. So what are the hemolytic anemias? Go through them. Firstly, sickle cell anemia. You know it is autosomal recessive. We have talked about it in our genetics. Missen's point mutation, very important. At beta 6 unit, glutamic acid changes to villain. Good boy changes to villain. Okay. Now what happens? There is vaso-occlusive. Because of this, whenever there is stress or oxidative, whenever there is stress, any change in pH, okay, any change or hypoxia, what will happen? What will happen? Where there will be sticking of the RBCs, okay, there will be sickling of the RBCs. This RBCs can become irreversibly sickle, leading to vaso-occlusive crisis, okay. They'll go and start blocking small blood vessels. Okay, so they can affect the blood vessels of the extremities, leading to painful crisis affecting bones, or They can lead to splenomegaly. Why? Because there is destruction of these RBCs that are sickled, right? So splenomegaly. Ultimately, what will happen? The spleen will undergo autosplenectomy. Investigation of choice. These are different kinds of investigation of choice. What do you see here? You see fish mouth vertebra. Okay, sickle cell anemia. Please remember this. What about G6PD? What kind of inheritance? G6PD is X-linked recessive. Sickle cell anemia is autosomal recessive. G6PD is X-linked recessive. Happens mainly in men, right? And there is oxidative stress. Why? You need NADPH, okay, for reducing glutathione. And glutathione is a very good antioxidant for RBCs. Now, if you don't have NADPH because of loss of this enzyme, what will happen? There will be oxidative stress. So whenever there is, remember this is an intermittent disorder, and the causes include fava bean infections, because infections will release free radicals, okay? So this will lead to oxidative stress. This is the most common cause. Infections, drugs like primaquine or nitrofurantoin or sulfonamides, ETT. So features of chronicities are not seen because there will be cessation to this whenever you stop the reason, the cause of oxidative stress. So it's an intermittent disorder, okay? Remember about sickle cell anemia like this. Remember it as sickle. Remember the RBC becomes sticky, insoluble and sickled. There will be infections, especially osteomyelitis caused by Salmonella typhi. This was a NEET PG question. You see crew-cut appearance. ESR decreases here because RBCs are not forming a rouleau. Okay, and you see extravascular hemolysis. Is that clear? Now with G6PD, what do you see? You see Heinz bodies. You can see this. These are Heinz bodies seen on supravital stains where there is hemoglobin, where the hemoglobin denatures. The same cell, when you see on Romanowski stain, it appears as a bite cell. Okay, so bite cell and your Heinz body are seen in G6PD. Is that clear? Hereditary spherocytosis, autosomal dominant, they'll give you a history of, this disorder being inherited, okay? Father also had it, it was passed on, something like that. What is the most common mutation? Ankyrin. What is the most specific mutation? Yeah, most severe mutation? Spectrin, okay? So, there is definitely jaundice, pallor, splenomegaly because of extravascular hemolysis, right? And please remember MCV decreases here. MCHC, this is the only place MCHC increases due to dehydration. Okay, RDW is, what is RDW? It will be normal because this is a genetic defect, right? This is a genetic defect. Remember HS like this. See, the only thing increasing is MCHC. Please remember it like this. Hemolysis. H stands for hemolysis. Which kind of hemolysis? Extravascular hemolysis. What is the triad of extravascular hemolysis? Hepatosplenomegaly. Then you have pallor and jaundice, right? You see spirocytes here because this is, hereditary spirocytosis affects the membrane. So you lose the biconcave shape, leading to this cell becoming a spherocyte. Microspherocyte, and it is a small cell that is holding the entire volume, so it is fragile, okay, and it has lost its flexible biconcave shape. Is that clear? Severe is spectrin, while ankyrin is the most common autosomal defect. One test that we can do is osmotic fragility test. Please remember, left shift is thalassemia, right shift is hereditary spherocytosis. Look at this question, okay? So please remember, conditions with spherocytosis, these are differential diagnosis, okay? These are differential diagnosis. Autoimmune hemolytic anemia is the most common condition with spherocytosis, but it is Coombs test positive, while hereditary spherocytosis is Coombs test negative. What about thalassemia? Remember, this is autosomal recessive, right? And they'll give you, whenever we talk about beta thalassemia, we have beta thalassemia major and minor. Middle, you don't need to remember, okay? Major is also known as Cooley's anemia. It is autosomal recessive. That means globin chains are lost, okay? Now, when we talk about hemoglobin, we have HbA, which is 96% is HbA. It is made up of 2 alpha chains and 2 beta chains. What about HbF? It is less than 1% and this is made up of alpha 2 and gamma 2 chains. While when we talk about HbA, it is almost around 3%, less than 3%, and this is made up of alpha 2 and delta 2 chains, right? Delta 2 chains. Now what happens in beta thalassemia major? They will always give you a history of repeated blood transfusion because we have enough RBCs, okay? RBCs are actually more, okay? RBCs, when you look at the RBCs are more. RBC number is more or normal. But what is the problem? This RBCs don't have the hemoglobin beta 2 chains, okay? So beta 2 chains are not produced. So they are not able to carry. They turn into what? They become hemoglobin F because your hemoglobin, what do you say? Alpha chains will bind to gamma chains, all right? So hemoglobin F increases here, and hemoglobin F is the kind of hemoglobin that has a lot of oxygen affinity. So it will not give oxygen to the tissues, and that is why you have hemoglobin that is reduced, and this patient is always in a state of hypoxia. Hepatosplenomegaly is seen here, jaundice, pallor, plus crew-cut appearance. And can anybody tell me what else do you see here? Crew-cut appearance, and can anybody tell me what else do you see here? Which faces? Which faces? Which faces do you see here? Chipmunk faces, very good. Chipmunk faces. Is that clear? Let me repeat it one more time. Always they will present you with a history of blood transfusion because beta globin chains are not produced in beta thalassemia major. It's a child which doesn't make beta globin chains, okay? Again, this patient will have hepatosplenomegaly, jaundice, pallor, and history of repeated blood transfusion, ultimately leading to secondary hemochromatosis, okay? So this patient will usually die because of dilated cardiomyopathy. Okay, so what are the RBC indices? MCV will be reduced because thalassemia is a microcytic anemia, but RDW will be normal, no variations in size because this is a genetic defect. Iron will be increased because of iron overload. You keep giving iron and iron absorption is more, and HbF increases, okay? What about beta thalassemia minor? Please remember, one beta chain is normal, right? And autosomal recessive disorder, so this patient is asymptomatic. But what do you see? You see that hemoglobin is around 8%. So this mimics iron deficiency anemia. But if you give the patient iron, will they become better? Will the hemoglobin level become better? Yes or no? So you always have to differentially diagnose it with iron deficiency anemia. How do you do it? Please remember here what increases, which hemoglobin increases in beta thalassemia minor? Your HbA2, okay? Usually in us it is less than 3, but in thalassemia minor patients it increases more than 3.5%. Is that clear? Is that clear? Yes. And how do you differentiate between iron deficiency anemia and beta thalassemia minor? You have your Menzer's index. Very good guys, very good. So this is your hemoglobin gel electrophoresis. You can see who runs the fastest towards the, yes, very good. So you can see hemoglobin A is the maximum. 96% of your hemoglobin is A. Then less than 1% is F, and A2 is more positive, okay? It is around 3%. This is normal. Now what do you see in trait? You see more A2, right? More A2, more than 3.5%, okay? What about beta thalassemia minor? See, look, there is no HbA. HbA is not present because one beta globin chain is not present, right? So what is it replaced by? It is replaced by HbF. So this must be beta thalassemia major, okay? What about this? This is sickle cell anemia. What is it? Trait? Yeah, sickle cell anemia disease. It must be trait because HbA is around 60%, while HbS is around 40%. Okay. Now here you have lost HbA again, and you see maximum HbS. That means this must be sickle cell anemia. Go through this. This is your crew cut appearance. I don't know in your generation whether you watch cartoons or not, but when I was a kid, we used to watch cartoons, and you remember like whenever Jerry did this crew cut appearance. Tom and Jerry, did you watch? In my generation, we watched Tom and Jerry. Okay? Okay, so what about this? This is your crew cut appearance and this is your chipmunk faces. Okay, chipmunk faces. What is chipmunk faces? Where you have a flat nasal bridge, frontal bossing and maxillary prominence. Okay? Okay. Alpha thalassemia, go through the notes. What about these? This is how you differentiate between iron deficiency anemia and beta thalassemia trait. Very, very important. RDW, it increases. Why? It's a nutritional anemia. It depends on how well you feed yourself. Okay. Now, though, you have a very shed diet because क्या बोलते हैं आप लोग क्या बोलते हैं? You have a shed diet because you are studying. Okay, all of you are studying, right? तो आपकी diet पूरी गई इधर उधर. So it really depends on how you feed yourself. Some days you feed yourself better, you have mercy on yourself. Some days you're very bad with yourself. Okay? So you eat processed food, empty calories. So RDW, there is a variation in sizes, right? Menzel's index is what? MCV by RBC. See, MCV by RBC. So MCV by RBC, here MCV will be less, right? Because iron deficiency anemia, and RBC count will also be less. Okay? So Menzel's index will be high. I always remember it like this. You remember it like this. Iron deficiency anemia, what is high? Menzel's index. While in beta thalassemia trait, because the RBC is more or normal, what will happen? Denominator is normal or more, so the end result will be less. Okay? Is that clear? And definitely what hemoglobin will you see? HbA2 will be more than 3.5. Okay? More than 3.5. Now with respect to this, PNH, what is PNH? It is, this is your immune hemolytic anemia. Just remember, there are 3 types. This leads to extravascular hemolysis. This also leads to extravascular hemolysis, while the last one leads to intravascular hemolysis. Warm antibody type, this is a type 2 hypersensitivity, right? Immune hemolytic anemia, type 2 hypersensitivity. So what happens? You have antibodies against fixed antigen. The first antibody you have in warm antibody type is IgG, that is against the Rh antigen. While when we talk about cold agglutinin type, you have IgM against the I antigen. What about cold hemolysin type? This is against the P antigen, IgG against the P antigen. Just remember this one, this much, and definitely cold hemolysin type, you will be able to see this, what do you say, clots, okay, RBC clumping together. Also, you will be able to see what? Spherocytes, okay, spherocytes. The most common cause of spherocytosis is, what do you say, immune hemolytic anemia, which is warm antibody type, present in females or SLE patients, or what do you say, on drugs like alpha methyl dopa. Okay, PNH. PNH, we have already discussed this. This is a problem with inhibitors of complement CD59 and CD55. What is the triad? It is characterized by hemolytic anemia, pancytopenia, because there will be destruction of RBC, platelet and your WBCs, right? And finally thrombosis. The cause of death will be thrombosis. Okay? Usually an older patient has PNH. Look at this question. Try to solve this. Try to solve this question. Try to solve this question. Chalo, jaldi, jaldi. See, again, look at the history. Patient's presence with anemia. Father and paternal aunt had a similar illness treated successfully with splenectomy. Okay? His peripheral blood abnormalities. Smear is given blue. What do you see in the peripheral smear? Look at this. There is no, is there any central pallor in any of the RBCs? Is there any central pallor? No central pallor. So this means these RBCs are, what are they? They are spherocytes. Now spherocytosis plus inheritance, they are talking about, what do you say, similar illness being treated. So this must be This must be what? This must be, diagnosis is hereditary spherocytosis. And how do you treat hereditary spherocytosis? With splenectomy. Okay, with splenectomy. So once you do splenectomy, remember your spleen is not present to remove the DNA remnants. Okay, in the reticulocyte you will have some DNA remnants, right? Who removes that? Your spleen. But now spleen is not present, so it will be present as a dot inside the RBC. This is known as what? Hurthle-Joly body. Okay, Hurthle-Joly body. What is it? It's a DNA remnant present in the RBC. Is that clear? It's a DNA remnant present in the RBC. It is seen in splenectomy patients and in megaloblastic anemia. Where do you see Hurthle-Joly body? Splenectomy and what else? Megaloblastic anemia. Is this clear? Okay. Now, anemia of diminished erythropoiesis, you have iron deficiency anemia. Look at this. Firstly, very, very important. What increases iron absorption? Can anybody tell me what increases iron absorption? Increase in iron absorption. Increase in iron absorption, the most important vitamin. You have vitamin C, yeah, ascorbic acid, yeah, anything acidic increases iron absorption, right? So, vitamin C. Vitamin C. What decreases iron absorption? So, there was a question that was given recently, right, about tea. So, phytates, carbonate, alkaline, anything alkaline or coffee, all of them decreases iron absorption. Now, what do you see? This is a peripheral blood smear. What do you see in the peripheral blood smear? Always compare this peripheral blood smear with the lymphocyte. See, this is a lymphocyte. It has scanty cytoplasm, very less cytoplasm, right? Look at this. This is scanty cytoplasm. Look at the cytoplasm. It's scanty, right? Scanty cytoplasm. And what is happening here? You always compare the nucleus of lymphocyte. Okay, nucleus of lymphocyte. With what? With the RBC. Okay, they are the same with the RBC. So now you can see that the RBCs are smaller compared to the lymphocyte, right? So can I call this microcytic anemia? Because they are smaller, right? Can I call it microcytic anemia? Yes. And look at the central pallor. Usually the central pallor is 1/3 of the RBC. Now has the central pallor increased? Has the central pallor increased? So there is increase in central pallor. What does this point towards? This points towards, what does it point towards? Hypochromic anemia. Now look at this. Do you have different variations of sizes? See, this is a little bit bigger RBCs, but this is smaller, this is smaller, this is smaller. This is a little bigger, but this is very small. So is there a different variation in sizes, like more variation in sizes? Yes or no? So can I say that this shows me anisocytosis? Anisocytosis is variation in size. Also, do you see the cell here? So it looks like a pencil, okay, pencil. So does it show me a change in shape as well, which is nothing but poikilocytosis? So it shows me anisopoikilocytosis. Is that clear? This is seen in iron deficiency anemia. So what is iron deficiency anemia? It is a microcytic hypochromic anemia which presents with increase in RDW, variation in size as well as shape. Okay, you see pencil cells in iron deficiency anemia. This is a very, very important. This is a very, very important peripheral blood smear. On with stain, Romanowski stain. Very good, Bhavashit. Very good. Now, what about sideroblastic anemia? This is there can be congenital defect like ALA synthase, yeah, acquired. B6 was asked. Anti-TB drugs also like isoniazid or lead poisoning. Please remember, heme is made up of iron as well as protoporphyrin. Here you have iron overload, okay? And you don't, there's a problem with protoporphyrin somehow, all right? So what do you see here? When you take the bone marrow biopsy, you will be able to see iron surrounding the nucleus, okay? This is known as a sideroblast. What is it known as? Sideroblast. Sideroblast. Iron surrounding the nucleus in the erythroblast. Is that clear? So you can see basophilic stippling also, and Pappenheimer bodies as well as sideroblast in sideroblastic anemia. What about anemia of chronic disease? One keyword. See, usually it is normocytic normochromic, but we can also call it as microcytic microchromic. But if you have to choose one, always remember normocytic normochromic. I told you my father. I'll give you an example of rheumatoid arthritis. He has rheumatoid arthritis. What is the key mediator? Interleukin 6. And if you remember, interleukin 6 mediates acute phase reactants. What does it do? It increases hepcidin. It's an acute phase reactant. What is hepcidin? It's master regulator of iron. What is hepcidin? Master regulator of iron. What does hepcidin do? When you have enough iron, it will block ferritin, which is the storage form of iron. Okay, block ferritin and even block absorption of iron. Even block absorption of iron. Is that clear? By blocking ferropotin. Okay, by blocking ferropotin. Is that clear? So ferropotin is a channel. If you look at this, this is how iron gets absorbed in your body. So you can see iron needs to go, it should have a 2 valency. It needs to go through DMT1, which is a divalent metal transporter. It needs to come out through ferropotin on the basolateral side, okay? And it gets converted. Once you come out, it gets converted to Fe3+, goes into the blood, and transferrin either throws it into the bone marrow or the liver. Liver will eat up the iron and store it as ferritin in the macrophages, right? Now, what does hepcidin do when you have enough iron? What do? You block ferropotin as well as block the liver, okay? Block the liver. Is that clear? So that is a function of hepcidin. Now look at this. Which of the following inhibits ferropotin? Please tell me. Which of the following inhibits ferropotin? Bolo, bolo, jaldi bolo. Which of the following inhibits ferropotin? Tell me. Bhavashit, are you here? So, ferropotin is inhibited by what? Hepcidin. How do you get hepcidin? Who increases hepcidin levels? Who increases hepcidin levels? Please tell me. It is interleukin 6. Very good. It is interleukin 6. Okay, interleukin 6. Is that clear? Okay. Now this is, put a big star mark. This is one thing you always go through before your exam. This is that table, okay? So, how do you differentiate between iron, the iron profiling of iron deficiency anemia, anemia of chronic disease? You have your thalassemia and what do you say? Anemia of chronic disease plus sideroblastic anemia. So, look at these three. When you look at iron deficiency anemia, iron is not there. So, serum iron will be definitely decreased. Transferrin saturation, how much transferrin is carrying? Definitely it will be decreased. If iron is not absorbed, there will be no carrying of iron, right? There will be definitely no storage of iron. Everything will be decreased, but your body would want iron, right? So serum TIBC will increase in iron deficiency anemia. Everything decreases except what? TIBC, which increases. Please remember this. What else increases? RDW increases, Menzel's index increases. Is that clear? You see pencil cells here, microcytic hypochromic anemia with anisopoikilocytosis. Anemia of chronic disease, you have iron, okay, it is stored, but can you absorb it? Can you, what is blocked? Hepcidin blocks what? It blocks absorption of iron, so serum iron will decrease. You will not be able to carry iron, because definitely if you cannot absorb, how will you carry iron? But what about ferritin? Do you have enough iron? Do you have enough iron? But what happens to this iron? What happens to this iron? This iron is not, yes, you have enough iron, it is stored. You have enough stored iron, but who blocks it? Who blocks ferritin? Hepcidin. So ferritin levels are normal, okay? But you cannot block. See, anemia of chronic disease usually happen to old patients, right? And I'll tell you something. What happens when you are older? Have you seen some people who keep saving? Many, I'll tell you, generational trauma. Many people who didn't grow up with money, you know. One thing that they have in common is they are very much into savings, and they grow old and they never use their money. Have you seen such people? Have you seen such people? Yes or no? Have you seen such people? So what happens when you're older? You have all the money in the world, but you don't have health to do what you want. Okay? Anemia of chronic disease is like that. They have money, but what happens? You cannot use it. Okay? You have iron, but you cannot use it. Okay? So I have seen the same thing in my own parents, okay, especially my father. He loves saving money, but he has a very big problem if that money is spent. And I'm sure you must have seen such people who keep saving. पर कब use करोगे भाई उसको? मुझे वो भी बता देना. And then there are this other extreme of people who keep spending. तुम लोग, okay? You don't earn, right? Your parents send you money within 1 week over. So there are two extremes. Wo middleman will win, okay? Who knows when to spend, when to save. All right. So this, please go through this. Megaloblastic anemia, put a big star mark. Big star mark, very, very important. See, megaloblastic anemia happens due to deficiency of 2 vitamins. What are the 2 vitamins? Vitamin B12 and vitamin 9. Now, when we talk about vitamin B12, remember when do you have vitamin B12 deficiency? Firstly, how do you get vitamin B12? From animal products, right? So vegans are a cause of deficiency. Vegans, yes, strict vegetarians, remember, thank you. Vegans, yes, strict vegetarians, please remember, they have vitamin B12 deficiencies. Infections like Diphyllobothrium latum, fishworm, fish tapeworm, while hookworm is associated with what? Can anybody tell me? Hookworm is associated with what? It is associated with? Yes. Yes, very good. Now, at stomach level, this was a previous year question, whenever you do gastrectomy, because your B12 gets absorbed through the ileum. So if you do gastrectomy, what will happen? There will be pernicious anemia, which is nothing but megaloblastic, immune megaloblastic anemia, type 2 hypersensitivity, and there are antibodies against parietal cells. Antibodies against parietal cells. Yeah, intrinsic factor, okay? So what will happen? Again, there will be no absorption of vitamin B12, okay? If you don't have pancreatic lipases, what will happen? There will be no absorption, okay? There will be no absorption of vitamin B12. At ileum, GIT-TB affects the terminal ileum, and Crohn's disease also mainly affects the terminal ileum. So this leads to vitamin B12 deficiency. What are the findings that you see? Like I told you, you will see oval jolly body where you have DNA remnants. I told you post-splenectomy, and you see it in megaloblastic anemia. Very, very important. Look at how many lobes are there. 1, 2, 3, 4, 5, 6. 6 nuclear lobes. Remember, in a neutrophil, usually there are 3 to 5 nuclear lobes. Okay, 3 to 5 nuclear lobes. But here you have more than 5 nuclear lobes. That means this is a hypersegmented neutrophil. And you see macroovalocytes, big macroovalocytes, right? Because this is a macrocytic anemia. You also see Cabot rings, which is a ring made up of mitotic rich spindle. Okay, what are the physical clinical features that you see with megaloblastic anemia. Firstly, hyperpigmented knuckles. Again, this is a previous year question. And atrophic glossitis. Okay, and atrophic glossitis. So atrophic glossitis, because you have lost all the papillae, tongue papillae, so what will it lead to? A smooth tongue. Okay, so this is known as atrophic glossitis. Is that clear? So how do you diagnose? How do you differentiate between folate and your vitamin B12 deficiency? Please remember, for vitamin B12, you need increase in homocysteine, because homocysteine, but it is non-specific. Okay, why? Homocysteine becomes methionine. Okay, homocysteine becomes methionine. For that, you need three vitamins. What? You need vitamin B12, B6, and B9. So if you don't have either, it can lead to increase in homocysteine levels. Okay, it can lead to increase in homocysteine levels, right? So what is specific? See, methylmalonin levels. Okay, good evening, good evening. Methylmalonin levels, can anybody tell me? They are increased by what? Methylmalonin levels are increased by methylmalonin levels. Do you remember the reaction of vitamin B12 here? Your methylmalonin gets converted to succinyl-CoA. Okay, this conversion is very important. Why? Because succinyl-CoA is very important for myelin sheath. Okay, for maturation of myelin sheath. Now imagine you don't have vitamin B12. What will increase? Serum methylmalonin. This is specific to vitamin B12. It is very, very important. And definitely, blood, what will happen? MCV will increase, because this is a macrocytic anemia. Okay? Methylmalonin plus with symptoms, neurological symptoms. Why neurological symptoms? Because myelin sheath, what is needed? Succinyl-CoA, which you don't have here. So this patient will present with neurological symptoms. This is very specific to vitamin B12 deficiency. What about folate deficiency? Now remember, folate is more common deficiency compared to vitamin B12, because folate we get it from green leafy vegetables, everything green, right? But as fast paced that we have become, and especially you students, kya khate ho? Noodles, all bullshit food, right? So there is no intake of fruits या vegetables. ठीक है, आप लोगों की life में, especially as a student, right? So that is why this can lead to folate, decrease in folate absorption. Where does it occur? In jejunum. What about iron deficiency? Iron is absorbed in duodenum. Your what B12 is absorbed in terminal ileum, while jejunum absorbs folate, right? What are the clinical features? You have megaloblastic anemia, again the same thing, but no neurological symptoms. Okay, no neurological symptoms. No neurological symptoms. Now look at these questions. These are the questions that were asked in your exam. Please look at these questions. Tell me, what are these questions? Batao. A 9-month-old boy presents with progressive pallor, abdominal distension. Investigation reveals hepatosplenomegaly, malar eminence. His peripheral blood smear is shown below. It is this blood smear. Okay. Sorry. I'm sorry. The peripheral blood smear is this. Can anybody tell me what is this? So a 9-month-old boy, progressive pallor, abdominal distension. So you can see this is extravascular hemolysis, right? Menzer's index is less than 13. Okay, less than 13. Yes, subacute combined degeneration of cord. That is seen in your vitamin B12 deficiency. Very good. What is this? This is thalassemia. Major or minor? Beta thalassemia, major or minor? Very good, Bhavashit. Major or minor? Tell me. Major or minor? This is definitely major. And what do you see on on the peripheral blood smear? You see target cells. You see target cells. Okay, target cells. I think we have it here. Thalassemia. Acha. But go through the notes, target cells is seen. Now look at this. This is the next question. A child visits to the hospital with severe fatigue, lethargy, pallor and irritation. She is a known case of IDA and on oral supplementation. On reviewing the child, it starts IV iron supplementation. What is the next best step, or what is the most sensitive test? Sensitive test. What will be the first indicator that the serum iron is working? Can anybody tell me? Again, this is your previous year question. Serum ferritin will increase. Okay, serum ferritin will increase. What is the most sensitive indicator? Serum ferritin. Is that clear? Look at this question now. A 45-year-old patient presents to the hematologist and complains of weakness and fatigue, decrease in hemoglobin and reticulocyte count. WBC platelet counts are normal. Bone marrow shows a selective decrease in erythroid precursor. Selective decrease in erythroid precursor. The minute you hear the word, only erythroid precursors are decreasing. This is pointing towards which anemia? Pure red cell aplasia. Pure red cell aplasia. What about this one? And it is associated with parvovirus B19 also. Now, a 35-year-old with body pain and AC fatigability, hemoglobin 7. Okay, hemoglobin 7 is given. The peripheral blood smear is given in the image. Indicates elevated levels of homocysteine and methylmalonine. Which one will lead to? This can also lead to what? Bhavashit. What is the answer here? This can also lead to very good. It can lead to what? Subacute combined degeneration of the spinal cord. Okay, subacute combined degeneration of the spinal cord. Is that clear? Okay, good job guys, good job. With this, we are done with our RBC disorders. Now, what are we left with? WBC and platelet. Okay, we'll take a short break here. We'll take a short break, 15 minutes. Okay, shall I take a break? And then we'll finish the rest of the pathology. Okay. Any doubts? Good job. Okay, we'll take a break here. Chalo. Okay, welcome back. Welcome back, guys. I hope. Hello, who is here? Divas, Bhavashit, Veena, are you here? Carolyn, are you back? Yeah, all right. Now let's start with leukemias. See, when we talk about leukemias, we have two types. We have four types, right? ALL, AML, CML, CLL. Okay. So how do we differentiate them? What is the problem with leukemias? It's a cancer. It's a cancer of your leukocytes, right? And when we talk about, remember your hematopoietic stem cell, always remember this. It differentiates into two progenies. You have a myeloid progeny, okay, myeloid and lymphoid. Now, what does lymphoid progeny give rise to? B, T, and NK cells, natural killer cells. While when you talk about myeloid cells, myeloid is like mother, okay? Mother works at home and works out also, right? She cooks also. Many times you must have seen, my mother was like that. She was an all-rounder. So myeloid makes platelets. It makes NBE, which is neutrophil, basophil, eosinophils, as well as your megakaryocytes, okay? So myeloid cell makes everything else. Now imagine there is a lymphoid cancer. What will increase in lymphoid cancers? Can anybody tell me? What will increase in lymphoid cancer? Definitely your lymphocytes, your lymphoblast. Now, when we talk about acute leukemias, okay? Acute leukemias, there is a maturation defect. When we talk about acute leukemias, what is acute leukemia? Acute and chronic? Chronic points to increase in mature cells. Increase in mature cells. Okay? Well, when we talk about acute leukemias, what is this? It is, WHO classifies it as more than 20% blast. There is an increase or there is a maturation defect. Okay? So there is an increase in 20% blast by WHO. Okay? So let's talk about ALL. What is ALL? Acute lymphoblastic leukemia. So what will increase? There will be increase in lymphoblast, B and T lymphoblast, right? Now when we talk about lymphoblast, you remember we can stain it with TdT. Go back to the first page, like where I have given stains, right? You can see hematological stains there. So when we talk about ALL, we have two kinds of classification. FAB and WHO. More important for the exam is WHO. How does WHO classify ALL? This is very simple. It is classified into BALL and TAL. Okay? It is classified into BALL and TAL. Now remember B, ball. Whenever you see BALL, you can read it as ball. And who plays with ball? Bhavashit, can you tell me? Who plays with ball? Who plays with ball? Bacche. Okay, who plays with ball? You can remember it like that, bacche. And remember the ball has PAX5 written on it. Okay, because what is the defect here in BALL? There is maturation defect. Now, for you to mature your RBC, what is important? I mean, for you to mature your B cell, you need, what do you say, PAX5. Okay, you need PAX5 gene. Now, if it is mutated, your B cell will not mature. Is that clear? So immunophenotype, all the B cell markers like CD19, CD10, okay? And TdT is present in both, okay? TdT stains lymphoblast. What does TdT do? Stain lymphoblast. Now, bacche, how are they? They are अच्छे, lymphoblast. Please remember, बच्चे अच्छे हैं. तो उनका दिल कैसा होता है? साफ होता है. Okay? दिल कैसा होता है? साफ होता है. There is no tissue infiltration. There is no tissue infiltration. The tissue involvement is not there because बच्चे साफ होते हैं, दिल के सच्चे होते हैं, ठीक है? बच्चे अच्छे सच्चे होते हैं. And what is a good prognosis? When there is hyperdiploidy, trisomy 4710 or translocation 1221, because you know the kids flip, right? Kids flip. So just 12, you flip it to 21. Flip it to 21. Translocation 1221 is good. What other things are good? If the age is between 2 to 9. Females, if females have it, whites and L1. L1 of FAP classification. Okay, so BALL and TAL, remember these are the differences. What about TAL? What is a mutation? Notch mutation. T, remember tall. Who are tall? Teenagers. And how are teenagers? They are turkey. Okay, they're very turkey. Remember the teenager community, the adolescent community. They're very, very, what do you call it? बहुत ठरकी होते हैं, right? And that is why you should always remember they don't think with their mind, especially guys, right? At this age, they do not think with their mind, they think with their you know what. So where is the involvement? They start thinking with their mind, go to the heart, then finally the brain. So where is the involvement? Testis, mediastinum and CNS involvement is seen. Okay? Now please remember these are the prognostic factors. This is how you differentiate between BALL and TAL. Is that clear? Teenagers always think of what? TALL. Think of teenagers. Okay? Think of teenagers. Is that clear? Now what is the general diagnosis? How do you need more than 20% blast. Stain, you get dot positivity with PAS. PAS stains both. Okay? And investigation of choice is flow cytometry because you can see which receptors are there, right? Whether B cell receptors are there or T cell receptors are there, right? So this is about your ALL. You have TAL and BAL. Let's do a question and see if you can answer. Look at this question. A 10-year-old boy with fever and weight loss presents with significant lymphadenopathy. He is pale and bone marrow histology shows the final finding. See, lymphoblast, whenever you think of lymphocyte, always remember there is a nucleus that is huge and cytoplasm is almost very scanty. Okay, now look at this cell. When you look at this cell, can you appreciate that the cytoplasm here is very scanty? That means very less cytoplasm. So scanty cytoplasm, very big nucleus. So this must be a lymphoblast. What is this? This must be a lymphoblast. And what is the history? Whenever they give you a history of a boy, think of ALL. Always think of ALL. Okay? Is that clear? Is that clear? Good job. Okay. Now what about this one? Okay, this we'll do later. Let's go to AML. Now with respect to AML, what should you remember? We have FAP classification that classifies it into 7 subtypes. M0, 1, 2, 3, 4, 5, 6, 7. Okay. So when we talk about M0, remember it is undifferentiated. M1 is without maturation. M2 is with maturation. M3, very important, it is acute promyelocytic leukemia. What is M4? Myelomonocytic leukemia. What is M5? Monoblastic. M6 erythroleukemia, while megakaryoblast is M7. You should remember some key features of each one. Okay. So when we talk about with maturation, remember this is the most common AML overall, and translocation, 3 translocation in AML are very common. M2, M3 and M4. M2 is translocation 821. Okay, 821. Think of it as 821. Whenever you hear 2, 821. Okay, 821. Translocation 821. Remember this is the most common and it is associated with what? Chloroma. What about acute promyelocytic leukemia? This is 1517. Translocation 1517. Very, very important. Translocation 1517, where there is fusion of PML RARA. Okay. This fusion happens because of a decrease in vitamin A. So if you give the patient vitamin A, this patient will be treated, right? So AML M3, very, very important. Firstly, what is present? See, this is myeloblastic leukemia. So myeloid cell have a very important feature. What is this? Look at this. Firstly, what can you notice in this cell? What can you notice in this cell? You can notice that there is a lot of abundant cytoplasm. What is the first thing you notice? Abundant cytoplasm. So now just by looking at it, okay, just by looking at it, you can say that this is a myeloblast. And in the myeloblast, you can notice something. There are some rods, these crisscross rods. What are these? These crisscross rods, these are OR rods. Okay, OR rods. And OR rods are made up of procoagulant material. Okay, procoagulant coagulant material. Procoagulant material. Now with respect to this material, please remember, or rods, if you kill these cells or give chemotherapy, what will happen? Because there is procoagulant material, if it comes out, it can cause disseminated intravascular coagulation. Okay, we don't want that to happen. So what is contraindicated in acute promyelocytic leukemia? We do not give. What is contraindicated? Chemotherapy is contraindicated. Chemotherapy is contraindicated. Okay, chemotherapy is contraindicated. Is that clear? Chemotherapy is contraindicated. So acute promyelocytic leukemia, there is translocation 15-17, and what is contraindicated? Chemotherapy. Why? Because you have myeloblast having OR rods in them, crisscross OR rods. This is known as Facet cell. Okay, so whenever you do chemotherapy, what will happen? This procoagulant material will come out, can lead to DIC. DIC has a very poor prognosis. So do you want the patient to undergo that? No. That is why chemotherapy is contraindicated. How do you treat it? With ATRA. Okay, with vitamin A. Basically give vitamin A, maturation will happen. Okay, vitamin A is very important in differentiation of cells. Okay, is that clear? Now myelomonocytic, what is it? What is the translocation here? Translocation 16-16 or inversion 16. Remember, monoblast is monoblast. It's stained with NSE, neuron specific. Please remember, NSE, it stains your monoblast. Now you can see monoblast is present in both. So NSE positive is both M4 and M5. What do you see here? You see tissue infiltration, gum infiltration, skin infiltration. So anytime they mention that, remember it is talking about M4 or M5. What about M7? It is mega karyoblastic. What do you mean by that? This is the least common out of all. And this is associated with two DIRs. Remember, it is associated with Down syndrome. We were talking about your acute myeloid leukemia, and in FAP classifications we have from M0 to M7. Remember, the most common out of all is M2, which is a translocation of 821. What about M3? It is 15-17. I told you three keywords. First of all, vitamin A is decreased, PML RAF fusion. Because of that, you know, there is procoagulant material inside it. So we don't want that to spread. That's why we don't give chemotherapy, and ATRA can be given as a drug of choice. It's very much treatable, right? M4 is myelomono, which is NAC positive. There is tissue infiltration like gum or skin. Okay, and what about monoblastic? It is same as M4. What about megakaryoblast? M7, it is the least common. There are two Ds that you should think of. Firstly, dry tap, which I've told you already, and it is associated with Down syndrome. Okay, it is associated with Down syndrome. Look at this. This image is a previous year question. This can be M4 or M5. What about this? Chloroma is nothing but soft tissue, leukemia going into soft tissue. So this is seen in M2. Is that clear? Now when we talk about CLL and CML, see guys, CLL, if I write CLL like this, can you see that CLL presents with convent schoolgirl appearance? Okay, convent schoolgirl. How do I know convent schoolgirl? See, convent schoolgirl because they wear the same uniform. Now look at this, can you see a double L? Are they same to each other? Yes, that's why. Which appearance? Convent schoolgirls. Double L is important because you need dual positivity. Dual positivity of what? Of CD23 and CD5. Okay, CD5. What else? You can also have CD200 positive. This this is a chronic lymphocytic leukemia, right? So you see mature cells. Which cells? Mature lymphocytes, right? And it is mainly seen in elderly. It is mainly seen in which kind of population? Elderly population. Is that clear? You see it in elderly. Elderly. Second, it can form into a large lymphoma. Large lymphoma. That is known as which transformation? Richer transformation. Richer transformation. Okay, large lymphoma. What is that large BL? It can become richer. DL BCL. Okay, DL BCL. And another thing you should remember, sir, with that, what appearance do you see? The lymphocytes are very fragile, so they break when you put the cover slip, okay? These cells are known as smudge cells or parachute cells, okay? Smudge cells or parachute cells. Can you remember CLL with this? Now, all leukemias happen due to radiation except for CLL, okay? Not associated with radiation. Not associated with radiation. Okay, not associated with radiation. Not associated with radiation. Is that clear? It is not associated with radiation. Okay, so the same things are written here. Absolute lymphocytic count, you need more than 5,000 with CD23 and CD5 positivity. Investigation of choice is flow cytometry because you can check for the receptors. And notch mutation, all these mutations are seen. These are the complications, usually in elderly patients, and you can also write lymph node enlargement. Okay. As you can see, this is smudge cell. This is smudge cell. What about CML? When we talk about CML, see, what you can remember ABC. Firstly, there is translocation 922, which is a balanced reciprocal translocation. Okay, a balanced reciprocal translocation. Why is this? Balanced reciprocal translocation, okay? Balanced reciprocal translocation. So what is the pathogenesis? So what is balanced translocation, reciprocal translocation? You have two chromosomes. Which two chromosomes? Chromosome 9 and 22, okay? So what happens? A part of the chromosome goes here, another comes here. At chromosome 22, you already have BCR. Okay, and ABL comes here and fuses. There is BCR-ABL fusion. Okay, this is known as balanced reciprocal translocation. Very, very important, which was asked in your exam earlier. Okay, so this is translocation 922. It is also known as Philadelphia chromosome. What happens due to this? Tyrosine kinase activity increases. Okay, what are the clinical features? This patient can be middle-aged to elderly, but a very, very important thing, massive splenomegaly without lymph node enlargement is seen. Okay, what are the phases you have? The most important phase is accelerated phase, where you have increase in basophils more than 20%. And here you have a garden party appearance. What is garden party? Because we have chronic myeloid leukemia, you see different cells. Okay, myeloid progenitor cells make platelets, they make neutrophils, basophils, eosinophils, and they make RBCs as well, right? So you see different, I mean, they make all these different WBCs, RBCs, and platelet, right? So you see increase in different types of cell. Like if you see this is a band-shaped neutrophil. If you see this is a eosinophil, basophil, right? So also if you see this is a D-shaped nuclei, right? So this must be, this is a D-shaped myeloblast, okay? This must be a myeloblast. Do you understand? This must be an eosinophil. And you see a lot of band-shaped neutrophils and immature RBC, immature leukocytes, right? So this is known as guardian party appearance, and there is a shift to left, okay? There is a shift to left where more immature cells are seen, all right? So CML, how will you remember? Just write down CML like this. Firstly, C stands for which appearance? college schoolgirl appearance. Okay, it stands for college schoolgirl appearance because all the letters are different. Okay, different types of cells are seen in chronic myeloid leukemia. Second, what you can notice is M. M stands for massive splenomegaly. Okay, massive splenomegaly, because that is one keyword you should always remember about CML. Third, you remember ABC. Why ABC? Firstly, balanced reciprocal translocation is seen here. You have accelerated phase. Okay, in accelerated phase. What happens in accelerated phase? Basophils increase. There is increase in basophils, and this happens because of chronic myeloid leukemia happens because of balanced reciprocal translocation, which is nothing but translocation 922 Philadelphia chromosome. Okay, ABL BCR fusion, increase in tyrosine kinase activity. Okay, what about your L? L stands for left shift. I always remember it like this. Okay, and one drug you can give is an tyrosine kinase inhibitor known as imatinib. Okay, is this clear? Is this clear, guys? All right, let's go to the next. What is the investigation? PCR or FISH. Look at these questions. Look at these questions. Try to solve them with me. Massive hepatosplenomegaly, WC count more than 50,000 is given. Which genetic abnormality is this most likely associated with? Can you tell me? Which genetic abnormality? Definitely it must be, which one? Translocation 922. A patient with massive splenomegaly, a WBC count more than 50,000. Okay, that means this must be chronic myeloid leukemia. Okay, this is how questions are asked. Okay, very good, guys, very good. Now look at this. Which mutation is linked to Philadelphia chromosome? I've just told you Philadelphia is which one? Reciprocal translocation. Now when you look at this, a 34-year-old with low hemoglobin, a platelet count of 25,000, decrease in platelet count, RAS, PT and APTT. A peripheral smear shows disseminated intravascular coagulation. That means this is pointing towards M3. Okay, what is M3? It is the fusion of PML, RARA. Very good. Very good, very good, guys. Yes. So what can you see? You can see OR rods, right? And this must be a myeloblast. This is known as which cell? Paget cell. Okay. A 20-year-old complains of fatigue for 1 year with bleeding gums. Okay, bleeding gums. He has massive splenomegaly, hemoglobin of 8. Immature cells are seen in the peripheral blood smear. TLC is 150. What is the most likely diagnosis? Is it ALL, AML, CML, CLL? He comes with, what do you think this is? Is it B or C? C, she has bleeding gums. Whenever you think of bleeding gums, what can be the differential diagnosis? Yes, good job. What about this one? Again, bleeding gums for 20 days, gingival hyperplasia, lymphadenopathy, hemoglobin is 11, platelets are 95, WBC is 45, 100% cellularity with many blast. So this is pointing towards blast now. Okay, non-specific esterase positive, right? So this must be AML 5. Very good, good job. Yes, AML 5. Okay, this must be AML 5. Okay, all right. Now these are chronic myeloproliferative disorders. Go through them. They don't come in your exam much. But look at this. This is a teardrop RBC. Teardrop RBCs is seen in primary myelofibrosis as well as myeloproliferative anemia. Okay. What about this? See, one keyword will make you solve this. Okay. Blood smear shows, peripheral blood smear shows what? It shows teardrop RBCs. Can you tell me what is this now? Just this keyword. What is this? This is myelofibrosis. Okay. primary myelofibrosis. Is that clear? Yeah, good job. Now with respect to lymphoma, see lymphoma, there are two types of lymphoma. You have Hodgkin's and non-Hodgkin's lymphoma. Hodgkin's lymphoma, Reed-Sternberg, you know. Non-Hodgkin, Burkitt, hairy cell, follicular. Do three, at least do Burkitt, because Burkitt comes in the exam, right? Even last time Burkitt was asked, so very, very important. So let's talk about Hodgkin's lymphoma. So when we talk about lymphoma, it is cancer, leukocytic cancer in the lymph nodes, right? Lymphoma can become leukemia, leukemia can become lymphoma. Hodgkin's lymphoma, the age is bimodal, very young, very old. Non-Hodgkin's usually happens in elderly. Lymph node involvement is usually cervical, axillary, inguinal, while when we talk about lymph node involvement here, it is mesenteric or Walde's ring. Here it is continuous, while when we talk about non-Hodgkin's, it can happen anywhere, okay? Extranodal involvement is rare, while here there is extranodal involvement, like there is stomach, okay, most commonly stomach. So this was asked in INESET 2024. Look at this. Which of the following statement is not true about Hodgkin's lymphoma? So RS cell are immunopositive for CD30 plus PAX5. Yes, this is true. Okay, Hodgkin's is a B cell tumor. What about, yes, they have a B cell origin. This was your previous year question as well. Your RS cells, which origin do they have? They come from B cells. Nodular sclerosis is the most common subtype. Yes, it presents with a mediastinal mass. What about Walde's ring? Walde's rings, I just told you, it is involved mainly in non-Hodgkin's. Okay, this was asked in INESET 2024. Now these are the different types of Hodgkin's lymphoma. Okay, and for Hodgkin's lymphoma, you can go through them. I always remember it as a dance, okay? Nodular sclerosis, mixed cellularity, lymphocyte rich, lymphocyte depleted. So all of them are CD15, CD30 positive. Non-classical nodular lymphocytic predominant Hodgkin's lymphoma is the one that has the best prognosis and has popcorn cells, okay? Go through this, many times this was asked. Popcorn cells in the background. This is the one that is not associated with EBV and has the best prognosis overall. So you can see classical RS is usually seen in mixed cellularity, okay, where you have this two owl eyes, okay, with eosinophilic eyes. What about mononuclear? This is seen in lymphocytic rich, okay. What about this? Lymphohistiocytic variant, this is popcorn cell. Where do you see it? NL-PHL. What about your lacunar cell? It is seen in nodular Hodgkin's lymphoma, nodular HL. And mummified is seen in lymphocyte depleted. Okay. And we follow the ABDVD regime, okay. Look at this. A 45-year-old woman presents with fever, night sweats, generalized itching, and unintentional weight loss of 10% over 3 months. Okay. On examination, enlarged cervical and axillary lymph nodes are noted. Lymph node biopsy shows Reed-Sternberg cell. You can see them. What is the likely diagnosis? So Reed-Sternberg cell, where do we see? Definitely we see it in Hodgkin's lymphoma. And which regime? ABVD. What is ABVD? Adriamycin, bleomycin, vinblastine or vinblastine, and dacarbazine. Vinblastine was asked in NEET PG. Okay, good job. Now, Reed-Sternberg is derived from which type of cell? I just told you this was your previous year question. It arrives from what is the origin? B cells. Okay, it arrives from B cells. Is that clear? Okay, so this is about your Hodgkin's lymphoma. Remember, nodular sclerosis, mixed cellularity, lymphocyte rich, and lymphocyte depleted. Nodular sclerosis presents with a mediastinal mass. Remember, all 4 of them are CD15 and CD30 positive. Okay, your classical Reed-Sternberg cell is seen in mixed cellularity. Lacunar cell is seen in nodular sclerosis. Mononuclear cell is seen in lymphocytic rich, and mummified cell is seen in lymphocytic depleted. Popcorn cell is seen in NL-PHL. Okay, Is that clear? Non-classical Hodgkin's lymphoma. Now, these are the different types of non-Hodgkin's lymphoma, okay? Non-Hodgkin's lymphoma. Out of them, the most important for your exam, please do not, it is a stupidity if you don't do Burkitt's lymphoma, okay? Remember Burkitt's lymphoma, you have translocation 814, which is the most common, 28 or 822, leading to CMYC, okay? There is a gain of function in CMYC. Now, it is EBV associated and you see the starry sky, right? Starry sky. It is also usually endemic to Africa, okay? Can you see the starry sky? You have lymphocytes, okay? You see lymphocytes and macrophages that have eaten the dead lymphocytes, okay? These stars are nothing but macrophages. Sheets of lymphocytes with macrophages who have eaten the dead lymphocytes. Usually jaw involvement is present, this child, and on FNEC, you can see vacuolations in the lymphocytes, okay? Vacuolations are present, which are nothing but fat deposits, so they are oil red O positive. Is that clear? Go through them, very important. Hairy cell, do you remember? I have always told you about Anil Kapoor. Have you remembered? Do you remember Anil Kapoor? Okay. Look at this now. This was asked recently in NEET PG. Can anybody solve this question for me? Can anybody solve this question for me? A 12-year-old child presents with cervical lymphadenopathy. Lymph node biopsy shows CD10, CD19, CD20. These are all B cell. These are pointing towards B cell origin, right? Another thing, CD5, CD23 negative rules out CLL. You can rule out CLL, okay? CLL, it cannot be CLL. Also, TDT negative. So this rules out any lymphoblastic leukemia. If it is TDT negative, that means it rules out lymphoblastic leukemia. Okay, it rules out lymphoblastic leukemia. Is that clear? What is the most likely diagnosis? This must be 12-year-old. जब भी बच्चे देते हैं, we always remember Burke 8. Okay, firstly, it occurs in children. Okay, it occurs in children. कैसे बच्चे? काले बच्चे. ठीक है, African child. And what is the translocation? 8, 14. Okay, and बच्चे क्या करते हैं? Twinkle, twinkle, little star. So starry sky is seen. All right, you can see this vacuolation. This is Burkitt lymphoma. Burkitt lymphoma. Is that clear? Good job. Now, multiple myeloma, it's a tumor, again, B cell tumor, post-germinal center B cell, and there is an increase in plasma cell, especially IgG, okay? X-ray findings, what do you see? See, you have a lot of increase in light chains, okay? What happens? Plasma cells that make a lot of light chains, misfolded immunoglobulins. So these keep on accumulating in the plasma cells first, and then they will go into the kidney. They affect the kidney will fail, leading to these plasma cells going into the urine. Okay, so you see Benz-Jones proteinuria, and you see what does that do? You remember the CRAP criteria. There is hypercalcemia because there is bony lytic lesions. Okay, bony lytic lesions because of increase in osteoclastic activity. Okay, there's increase in osteoclastic activity. And anemia because of renal failure, because of Benz-Jones proteinuria. Once these light chains go to the kidney, they fail the kidney, and this decreases erythropoietin, causing anemia. Okay, definitely renal failure and hypercalcemia is seen. Hypercalcemia because of lysis of bones. Okay, is that clear? Which kind of calcification? Metastatic calcification. So ultimately, because of bony lysis, there is raindrop skull. You can see rouleau formation. What are these bodies known as? They're very famous, what do you say, inclusions in the cytoplasm. This is your Russell bodies. What about inclusions in the nucleus? Intranuclear inclusions, these are Dutcher bodies. Okay, Dutcher bodies. What about these? These are Mott cells. Okay, a lot of inclusion in the cytoplasm. This is known as Mott cell. And on electrophoresis, okay, on protein gel electrophoresis, you can see that there is a M spike, monoclonal spike in the gamma region. N spike in the gamma region, all right, monoclonal spike in the gamma region. This looks like a flame, right? This is your flame cell. Is that clear? This is your flame cell. All right. Yes, your protein and plasma electrophoresis. Good job. All right. Langerhans histiocytosis, remember about mutation, BRAF mutation. Also, you see this is very important. Burbeck या tennis racket granules. Okay. Platelet disorders. Let's do some questions first. Which diagnostic methods are more effective than clotting factor measurement? See, when we talk about, firstly, when we talk about platelet disorders, please remember, whenever there is a problem with the platelet, your bleeding time will increase. Whenever there is a defect with clotting factors or there is a problem with clotting factors, PT and APTT are affected. Okay. So, platelet count, the normal count is 1.5 to 4.5 lakh. Bleeding time assesses platelet function. Okay. And platelet, remember, when we talk about our primary hemostasis, your platelet has two receptors on it. Which one? GP1B9 and GP2B3A. Now, primary hemostasis is what? When you have platelet adhesion, where your von Willebrand factor binds with GP1B9. Okay, binds to GP1B9. Then you have platelet degranulation. Okay, release of alpha and dense granules. And the third thing is you have platelet aggregation. Platelet binds to itself. Other platelet keep binding to itself, right? To make the primary hemostatic plug. This is done with GP2B3A plus fibrin. Okay, plus fibrinogen. Is that clear? This is how your primary hemostatic plug is formed. First, there is platelet adhesion to the endothelium. How is it adhered to the endothelium? With the help of von Willebrand factor. Then what is happening? This platelet is degranulating. Okay. And it will call more platelets which will bind to each other with the help of the second glycoprotein receptor GP2B3A. Is that clear? So, please remember, bleeding time assesses either these two glycoproteins or there must be some problem with the number of platelet itself. Prothrombin time, PT. We have table tennis and tennis, right? Where do you play tennis? Outside. So, it assesses extrinsic factors, okay, clotting factors like 3 and 7, right? Factors 3 and 7. What about APTT? Your factors, intrinsic factors, which are factors 12, 11, 10 and 9, okay? 8 and 9. What about clotting time? It is how much time is taken for clot formation. So now look at this. Which diagnostic method is more effective than clotting factor measurement for assessing the intrinsic pathway? Intrinsic, table tennis, just a little bit more. Eshan, I know it's a marathon, right? We have been going on and on. Tell me. It is APTT. Very good. A patient presents with recurrent nose bleeds. Workup confirms the diagnosis of von Willebrand factor disease. Primarily binds to which of the following? I just told you, platelet adhesion. How do you do platelet adhesion? Von Willebrand factor binds to what? GP1B9. Okay, GP1B9. Okay, 2B3A. You need a platelet aggregation is done by 2B3A. Is that clear? Is that clear? Now this table, please go through this table. This is what is important for the exam. This one table will save you. See, whatever happens here. See, Bernard-Collier syndrome is a qualitative defect in platelet, Bernard-Sollier and Glanzmann thrombasthenia. What happens here? Your platelet count is normal. Nothing happens to the number of platelet. What is happening? There's a problem with the receptors. Either there is a problem with platelet adhesion because GP1B9 is affected, or there is a problem with aggregation because GP2B3 is affected. Is that clear? So Bernard comes first alphabetically. B, big suckers. Please remember big suckers. Why? You see big platelets. Okay, big suckers. GP1B9. Remember, big platelets are seen in Bernard-Sollier syndrome, and the alphabet, it is the defect of GP1B. While when we talk about Glanzmann's, okay, Glanzmann's is the defect of GP2B3A. Okay. So what is defective? Aggregation is defective. Is that clear? ITP, you have acute and chronic. What happens here? Sudden drop in platelet is seen. Now, why does ITP is type 2 hypersensitivity? So there are abnormal antibodies made against which glycoproteins? GP2B3A or GP1B9. Again, you see large platelets here due to megakaryocytic hyperplasia. Acute is seen in children after viral infection, while chronic is seen usually in females, like females who get, who are in their age to get pregnant. Hemophilia A and B, both are X-linked recessive. Okay, so they are seen mainly in boys. Hemophilia A is a factor 8 defect, while hemophilia B is a factor 9 defect. Okay. Now, please remember what happens in hemophilia. What do you say? A and B. Platelet is not affected. Okay, platelet is not affected. Please correct this. Platelet is not affected. So BT is not affected at all. What is increased? APTT is increased because both factor 9 and 8 are intrinsic factors, right? What about your, what do you say, HUS, hemolytic uremic syndrome? There is consumption of, this is nothing, hemolytic uremic syndrome is microangiopathic hemolytic anemia, right? And even TTP is, what do you say, microangiopathic hemolytic anemia. So ultimately there is consumption of platelets, due to which the platelet count is low in both of them. Okay, but what is affected? Because the platelet function is affected, your bleeding time is increased. Okay, bleeding time is increased. Do you get it? Bleeding time is increased. In HUS and TTP, both bleeding time is increased. But what is normal? Because the clotting factors are not affected, your PT and APTT are normal. Triad of your HUS is firstly kidney failure. Okay, kidney is affected, plus you have hemolytic anemia and thrombocytopenia. While when you talk about TTP is a pentad, okay, Adam TS13 defect, where you also have neurological symptoms plus fever. Okay, what about DIC? DIC is disseminated intravascular coagulation, where everything gets consumed. The clotting factors, the platelets. Okay, so platelet count is low, BT will be increased, APTT will be increased, everything will be increased because everything gets consumed. Okay, is that clear? Von Willebrand factor disease. See, remember, von Willebrand factor disease, firstly, it's like that guy with two girlfriends, right? I always tell you that because it affects clotting factor 8. Okay, it binds to clotting factor 8 and increases its half-life. It also is involved with platelet adhesion, right? So BT will also increase, and because clotting factor 8 is intrinsic, APTT will also be increased. Is that clear? MPO positive. Alphia, MPO positive. Okay, is that clear? Now, look at this case. Hemophilia B presents with pain. Which of the following is used in management? A known case of hemophilia B presence. Okay, known case of hemophilia B. So hemophilia B, see, for hemophilia A, you give cryoprecipitate. Hemophilia B, you give fresh frozen plasma. Okay, so what should you give? Fresh frozen plasma, and what else? Fresh frozen plasma and cryo poor plasma, right? So 2 and 4. What is the answer? B, which is 2 and 4. Okay, fresh frozen plasma is given for hemophilia B. Okay, so hemophilia A and B both are X-linked recessive, both happen in boys, right? A is a factor 8 deficiency, while 9 is factor 9 deficiency. Intrinsic pathway is affected, so both will affect APTT. Okay? Clinical features, there's a male patient with hematolosis. Deep tissue bleeding will be seen. While when you talk about primary hemostatic disorders, like there is superficial bleed. Okay? Now, these are your color coding of vacutaneous, important. Okay? Blue. See, we add anticoagulants, right? In blue, please remember, light blue is used for coagulation studies, like to check PT, APTT, bleeding time, right? What anticoagulant do we add? Trisodium citrate. What about red? Put a star mark. Again, previous year question. This is also a previous year question. Clot activators. There is no anticoagulant added. Okay, no anticoagulant. So it is also known as clot activator. Okay, clot activator. What about green? Green, what is the anticoagulant? Green is heparin. Okay, and it is done to check electrolytes. What about lavender? CBC, we check CBC. And what is the anticoagulant? EDTA. Gray, again previous year question. What is the anticoagulant? Potassium oxalate. We also add NaF, sodium fluoride, because it blocks enolase. Okay, it blocks enolase, inhibits enolase, and that's how it stops glycolysis. And this can be used to check glucose. Okay, so when we talk about light blue, always remember this is for coagulation studies. And what is the anticoagulant in this? Sodium citrate. What about red? It doesn't have any anticoagulant. It is a clot activator. Your green checks electrolytes, has heparin in it, EDTA, lavender. Okay, routine CBCs. Okay. What about gray? Gray is for potassium oxalate, and we do glucose estimation because it has sodium fluoride that blocks enolase. Okay. Now this is regarding whole blood. You can check this question, which was asked recently. Match the following blood products with their respective shelf lives. So packed RBCs you can use for 42 days, while cryoprecipitate you can use for 1 year. Okay, the packed RBCs, 1D, it's easy to match. 2C, okay, 2 for 24 hours. Then 3B, okay, 3B, and platelets you can keep for 5 days, and cryoprecipitate because they are kept at a very negative temperature, right? So you can keep it for 1 year. With this, we are done with hematology and we are done with general patho. Okay, what are we done with? Guys, are you with me? We are done with hematology and general patho. Now with respect to systemic, we'll only focus on the questions, and this is easy because it integrates with medicine. So the main 2 topics are done. Okay, systemic will take hardly 1 hour. Okay, is that clear? Can we continue and finish it off? Are you with me? Are you with me? Okay. Now with respect to vasculitis, please remember, look at this question. A young woman presents with feeble upper limb pulses, low blood pressure, okay, and retinal hemorrhages and papilledema, all right, and papilledema. On physical examination, there is a different blood pressure between arms and weak radial pulses. So pulseless disease, young woman. Okay, what is this pointing towards? It is pointing towards Takayasu arthritis. Okay, Takayasu arthritis. So when we talk about vasculitis, remember there are 3 types of vasculitis. Okay, there are 3 types of vasculitis. What large vessel vasculitis? Chapel Hill has classified them into 3 types. Which are the 3 types? You have large vessel vasculitis, medium vessel vasculitis, and small vessel vasculitis. When we talk about large vessel, there are 2 types. Both of them are granulomatous. So how do you differentiate between both? The age becomes the big factor to differentiate. Okay, giant cell arthritis usually affects the temporal artery. Okay, the granulomas are formed in the temporal artery, leading to unilateral headache, or they can involve the maxillary artery, leading to jaw claudication, which is the most specific symptom of large cell arthritis. Okay, or they can also involve the ophthalmic artery, leading to sudden onset blindness. That's why you treat the patient right away with immunosuppressants. Okay. What about Takayasu? Takayasu is known as pulseless disease. It usually involves the aorta and its branches like subclavian artery, and since it involves subclavian gives blood to the upper extremities, the pulse is lost in the upper extremities. But when you check the femoral pulse, that appears normal. Okay. So you don't need to remember the histopath, just remember the age. The age matters a lot. It's granulomatous, we don't know the cause. Okay. When we talk about medium vessel vasculitis, the two medium vessel vasculitis is polyarteritis nodosa as well as Kawasaki. Okay. When we talk about PAN, please remember PAN is a type 3 hypersensitivity and it spares pulmonary. Your PAN spares pulmonary vessels. It's a medium vasculitis, right? So it will not involve the capillaries of the lung because capillaries are very small. What about glomerulonephritis? That also doesn't happen in PAN. But remember, PAN is associated with fibrinoid necrosis as well as hepatitis B. Okay, 30% of PAN cases are associated with hepatitis B. Kawasaki. Kawasaki, do you remember I always told you about this child? Okay, that the child, remember there's a child that has anti-endothelial antibodies. There's cream criteria, right? Fever is the most specific sign of Kawasaki disease. Plus you have adenopathy, unilateral adenopathy, okay, unilateral cervical lymphadenopathy, plus this child will have strawberry tongue, right? Strawberry tongue. What else will this child have? Erythema in palms and sole. And conjunctivitis. Okay, conjunctivitis. Is that clear? So these are features of your Kawasaki disease. While when we talk about Buerger's, see, Buerger's is both medium as well as small vessel vasculitis, and this can not be categorized into medium vessel. Okay, so this is actually a hypersensitivity to smoking itself. Okay, so what happens, there is a thrombus formed along with microabscesses inside it, and ultimately it starts affecting the arteries, veins and even nerves, and because it affects the nerves, there is pain while walking. So these patients don't walk a lot, leading to intermittent whenever they rest, pain goes away. So intermittent claudication. Okay, remember, it doesn't involve lymphatics. You also see secondary Raynaud's phenomena and what do you say, dry gangrene. Why? Because there is ischemia to extremities, right? Ischemia to. So how do you treat Buerger's disease? Stop smoking. This is a hypersensitivity to smoking. So you cannot do anything. There is no treatment without stopping smoking. Okay, there is no treatment without stopping smoking. All right. Look at this question. A 3-year-old child was brought to the hospital with complaints of fever, rash, and swelling of hands and feet. There is edema of hands and feet, palms and soles, cervical lymphadenopathy. What is the likely diagnosis? So you need fever, a consistent fever for more than 5 days. Very good, very good. Ahmad, Dream Kishore, Utharodayan. Okay, good job. So this is Kawasaki disease. What about measles? Measles, you already know complex spot, cough, coryza, and conjunctivitis, right? Hinox-Schollen purpura, we'll talk about it now. Hinox-Schollen purpura, again, type 3 hypersensitivity, and type 3 hypersensitivity usually involves the joints and your joints and yes, very good. So I always tell you, joint and kidney. Type 3 hypersensitivity will always involve your joints and kidney. So you remember it as a Papa ki pari. Why Papa ki pari? Because there's a girl, okay, there's this girl, okay, and she's in a lot of pain. So she starts calling her Papa. What is Papa? there is palpable purpura. Now this purpura is not because there is any thrombocytopenia, okay? This is a non-thrombocytopenic condition. Palpable purpura. This patient has IgA deposits. There is pain abdomen. Pain abdomen. Involvement of joints leading to arthralgia. And hematuria, okay? So this is your Hinox-Schollen purpura. Remember, it happens in kids, okay? It happens in kids. Post-immune is like you have one immune, when we talk about small vessel, it is either immune complex mediated or post-immune. Now with respect to post-immune, it is ANCA mediated. We have C ANCA and P ANCA, right? Now, three kind of post-immune disorders are there. You have microscopic polyangiitis, Wegener's granulomatosis, and Church-Strauss. Remember, microscopic polyangiitis have no granuloma formation. This is very important. Only vasculitis is there, no granuloma formation. While when we talk about Wegener's granulomatous, yeah, Church-Strauss, what is the difference? Eosinophils, okay, are involved with Church-Strauss syndrome. This is very, very important, okay? So no granuloma. Granuloma is seen in both, but where are eosinophils? Church-Strauss syndrome. Okay, so these are the key findings. Go through them. I always tell you C, okay, Wegener's, always think of C. Why? It involves the upper respiratory tract, lower respiratory tract, and the kidneys. RPGN is seen in Wegener's granulomatosis. So cavitations are seen, lung cavitation, crescentric glomerulonephritis. Wegener's is also C ANCA. Everything else is P ANCA positive. Okay, look at this. That was asked recently. A 5-year-old child with colicky abdominal pain, purpuric rash on the extensor surface, urine analysis shows hematuria. What is the most probable diagnosis? Hinox-Schollen purpura. The same question was repeated in 2024. Okay, is that clear? Important. All right, now with respect to CVS, I'll tell you the questions that are asked. Firstly, heart failure, left-sided heart failure shows you heart failure cell, left-sided heart failure shows you heart failure cells in the lung, okay? Hemosiderin-laden macrophages. This you already know. Myocardial infarction, put a big star mark. Questions are asked, especially, what is the earliest, look at this, what is the earliest marker of myocardial infarction? What is it? Now we have a non-specific marker, which is IMA. What is IMA? Ischemic modified albumin. This is the earliest marker. Okay. So troponin T and I know it is IMA, then heart fatty acid binding protein, then myoglobin. Okay. So this was the question. Please remember, all of them are non-specific. Early to rise, especially myoglobin, early to rise, early to fall. Okay, it's like, and it's non-specific. Okay, it's fake, it's non-specific. What about CKMB? It comes early, again 2-3 days, it goes away. Troponin T and I are the best. Okay, out of that, troponin I am the best. Okay, most sensitive, most specific, as well as now it is the best marker for reinfarction. Before, CKMB was the best marker. Now LDH, flip, you must have heard. LDH1 is present in your heart. Whenever the myocyte rupture, LDH1 will leak into the serum and the levels of LDH1 will increase in the serum, known as LDH flip. So in LDH flip, in myocardial infarction, LDH1 is more than LDH2. Is that clear? This is, go through the changes that are seen. I will focus on the questions. Look at this. A 65-year-old man dies due to myocardial infarction. Which of the following stain can be used to see the infarct in the heart during an autopsy? So within 0 to 4 hours, no gross changes are visible. But still, if you want to see gross changes, remember guys, if you want to see, you can take a cross section of the heart and put it in a dye. Which dye? triphenyl tetrazolium di. It binds with lactate dehydrogenase and gives a brick red color. Which color? It's given here. Normal heart, brick red color. It binds with LDH and gives a brick red color. Now, infarcted area. What happens? The LDH is gone from that area, so it remains pale yellow or unstained. It doesn't stain there. Okay, unstained. Is that clear? It remains pale yellow or unstained. Okay, pale yellow or unstained. Is that clear? Now look at this question. A 28-year-old man with exertional dyspnea for 1 month. Echocardiography shows mitral stenosis, mitral valve release, fibrinoid necrosis around lymphocyte and NHL cells. Okay, what is the most likely diagnosis? What are they pointing towards? See guys, what is this? This is your Aschoff nodule. This is pathognomic for rheumatic heart disease. Okay, Aschoff nodule, which is pathognomic for rheumatic heart disease. All right, yeah, good job, good job. So when we talk about endocarditis, we have rheumatic heart disease, right, which presents with pancarditis, okay, and Aschoff nodules, which are mainly present in the myocardium. Okay, so they are present in all 3 layers, but if I have to ask you, where are they mainly present? In the myocardium. So what is it? You have a central fibrinoid necrosis. Around that you have NHL cells. What are these? These are activated macrophages. Okay, they can be either caterpillar-like or owl eye appearance. Okay, acute RHD presents with mitral regurgitation, while when we talk about chronic RHD, mitral valve stenosis is seen, as well as endocardial thickening in the posterior walls. Is that clear? So mitral valve stenosis result in fish mouth or buttonhole appearance. Where do you see, just now you remember, we have done fish mouth vertebrae somewhere. Can anybody tell me where have we done it? Now with respect to your endocarditis, we have vegetations, right? Large friable vegetations. Where are they seen? They are seen in infective endocarditis. Okay, infective, and very good, Udayan. Yes, sickle cell anemia as well as fish mouth vertebrae is seen in osteoporosis, right? Good job. So infective endocarditis, see vegetations. We have 4 types of vegetation. One we have learned already, lemon sac vegetation, SLE. You see vegetations on both sides of the leaflet. Okay, sterile vegetation. While infective endocarditis, you have large, bulky, friable, destructive, vegetations. Okay, they are non-steriles. What are vegetations? They are nothing but masses made up of fibrin and platelets and bacteria if they are non-sterile, or immune complexes if they involve SLE or rheumatic heart diseases. Okay, what about your NBT? They are seen in pancreatic cancers, and you see bland vegetations made up of only platelet and fibrin. Okay, so these are the different types of vegetation. Very important. Okay, very important. What about this question? A 27-year-old athlete suddenly collapses during a football match and dies on the field. Autopsy reveals left ventricular hypertrophy on cardiac histology. Left ventricular hypertrophy is there. What is the most common diagnosis? And you can see myocyte disarray. You can see the arrangement of myocytes. Some myocytes arranged this way, that way. So myocyte disarray is there. What is this? Okay, myocyte disarray. Is that clear? Myocyte disarray is there. So what do you see in this? Yes, this is a part of hypertrophic cardiomyopathy. Okay, hypertrophic cardiomyopathy. You have rheumatic heart disease in cardiomyopathy. The cardiomyopathy, the types of cardiomyopathy that we have: dilated, Takotsubo, hypertrophic, and restrictive. With respect to dilated cardiomyopathy, the ventricle is so dilated that there is a systolic dysfunction. Okay, pumping is affected, systolic dysfunction. Okay, so dilated most commonly happens due to daru. Okay, alcoholism. Most common cause is idiopathic, we don't know, but the most common known cause is daru. Okay, one gene mutation is Titin gene mutation, where you see these ninja star-shaped nuclei. Okay, very famous ninja star-shaped nuclei. Okay, ninja star-shaped nuclei. What about your Takotsubo? This is due to emotional or physical stress, where a large surge of catecholamines are released, and you have a catecholamine receptors in the left ventricle. So there is isolated left ventricular hypertrophy. Hypertrophy, dilation and hypertrophy due to sudden emotional stress. Okay, Takotsubo, please remember, it mimics myocardial infarction, but when you do angiography, the blood vessels are cleared. There is no cholesterol deposition. What about HOCM? There's a beta-myosin heavy chain defect. Remember, this is autosomal dominant, and there is myocyte disarray. Banana-shaped ventricle is seen, okay, due to interventricular septal hypertrophy. Restrictive cardiomyopathy, again, diastolic dysfunction. Filling is not proper. Why? Because something is filling inside the ventricle. Okay, most common cause is extracellular deposits like amyloidosis, ATTR. Okay, you can also have hemochromatosis, but most commonly associated with dilated. You can see this. We did a question in the starting as well. Banana sign is also seen in other places like gamete of falciparum, ultrasound of spina bifida. You see lemon and banana appearance, as well as NCCT, subdural hematoma on NCCT. Okay, do this question now. Can anybody tell me the answer for this question? Can you see the screen? Yeah, very good. 78-year-old man, pedal edema was noted. ECG shows no. Echo reveals restrictive cardiomyopathy. Apple green birefringes under polarizing. What is the cause? Cardiac amyloidosis. Very good. Good job. Okay. Now look at this question. This was asked. Let's go to respiratory system. A 30-year-old woman with a long history of dyspnea, cough with sputum and wheezing died of respiratory failure. Remember, she's a woman, and she had the lung autopsy is shown below, and you see continuous, like there are, a lot of dilatations, permanent dilatations in the acini. Now, when we talk about a 30-year-old woman, remember, women usually don't smoke. So we're taking a case of a non-smoker. Cystic fibrosis, we can rule out here. Cystic fibrosis, they would have usually given you a young patient. Why? This is autosomal recessive disorder. Okay, there is thick greenish sputum, right? Mutation in dynein arm, they should have given you a history of Carter-Jenner syndrome. What is Carter-Jenner syndrome? It's a triad of bronchiectasis and sinusitis, and can anybody tell me dextrocardia, right? So this doesn't point towards that. And type 4 antibodies against type 4 collagen is seen in Goodpasture's syndrome. Okay, Goodpasture's syndrome. Type 2 hypersensitivity, Goodpasture's syndrome, right? Goodpasture's syndrome. So what can I point towards? This must be pan-acinar emphysema, which is seen in lower lobe of the lung, usually in a non-smoker. Okay, usually in the non-smoker. So when we talk about obstructive lung diseases, you remember FEV1 by FVC is less than 0.7, okay, less than 0.7. What are obstructive lung diseases? So there's an obstruction with breathing out, right? You have your emphysema, chronic bronchitis, asthma, and bronchiectasis. Now, when we talk about chronic COPD, this includes your emphysema and chronic bronchitis. Remember, emphysema is a dilatation and destruction of the acini. What is acini? When you look at the respiratory, the functional unit of the lung, it is nothing but an acinus, which is respiratory bronchiole plus alveolar ducts and alveoli, right? So that is destructed. So what happens in emphysema? Please remember, emphysema usually happens due to smoking. Or it can be due to smoking presence with centri-acinar emphysema. Okay, there are different variants of emphysema, right? Most common cause is smoking. What is another cause? What is another kind of emphysema that you have? Pan-acinar. And what is the problem with pan-acinar emphysema? It is a deficiency of alpha-1. So I will write it like this, alpha-1 antitrypsin. Why did I write the whole word? Because I want you to remember, alpha-1 antitrypsin is autosomal recessive and it affects two organs, lung and liver. In the liver, it causes cirrhosis, okay? While in the lung, it causes pan-acinar emphysema. Which lobe involvement? Lower lobe involvement, okay? And the word, where does it occur? On chromosome 14. So you can remember it from here itself, from the word emphysema itself. P also stands for pink puffers. Please remember, these people who have emphysema, what happens to them? They are not able to breathe out, okay, because of obstruction, because they lose their elastic recoil, okay, because of losing their elastic recoil, okay, because there's a balance between alpha-1 antitrypsin as well as proteases, right? When you smoke, a lot of proteases are produced. Or if you lose your alpha-1 antitrypsin, again, proteases will increase and they will break down elastic fibers. So elastic recoil is lost, right? Elastic recoil is lost. So breathing out becomes tough, and that is why these patients have pursed lip breathing. They breathe like this, okay? Pursed lip breathing. Is that clear? Pursed lip breathing. Okay, pursed lip breathing. Is that clear? All right, pursed lip breathing. Now, another thing, because there's so much air inside the lung, the air is not able to go out, right? Because there is so much air, it's oxygenated. That's why you call them pink puffers. And they are, please remember, they are very thin because breathing out consumes a lot of energy. So they are very thin. Is that clear? They are very thin. So these are the things that you need to remember about emphysema. From the word emphysema itself, E stands for elastic recoil. Whenever you look at P, think of pan-acinar emphysema, happens due to deficiency of alpha-1 antitrypsin. Pan-acinar, remember, alpha, chromosome 14, there is a mutation. This is autosomal recessive, affects lung and liver. In the lung, pan-acinar, in the liver, there is cirrhosis. Okay? Which lung involvement? Lower lobe. Okay? Please remember centri-acinar. Sir, when you SEMA, smoking, it is associated with smoking. Centri-acinar emphysema is most common overall. Okay? Now, when we talk about chronic bronchitis, again, this also happens due to smoking. But what happens is there is mucus. Okay? There is mucus plugging the airways. So, gaseous exchange doesn't happen properly. And that is why, because the gaseous exchange doesn't happen, there is cyanosis. Okay? There is cyanosis. What is the definition of chronic bronchitis? You need a productive cough for more than 3 months in the last 2 years. Okay? And please remember, this can lead to, these patients are usually, when you look at C, you can just make it O, right? These patients are usually obese because the minute they start walking, okay, what happens is they will not be able to breathe properly. Already they have cyanosis. The minute they do some physical activity, their breathing reduces, okay? So they don't do much physical activity. That's why they're usually obese, okay? Please remember the definition. The most important thing in chronic bronchitis is what? Reid index. What is Reid index? It is, see, when you look at the histology, you have MS, MC, you have mucosa, submucosa, muscularis propria, and your cartilage, right? So what happens when you take the submucosa, the gland, compare the gland with the submucosal glands with the entire wall of the epithelium, entire wall of the bronchus, what happens? It increases to more than 0.5, more than or equal to 0.5. Normal is 0.4, okay? So this is very important in chronic bronchitis. What about asthma? Remember, chronic bronchitis and emphysema are irreversible. Bronchiectasis is irreversible. But when we talk about asthma, this is reversible bronchoconstriction and inflammation. Type 1 hypersensitivity, right? So airway, you see 3 C's in asthma, okay? So asthma, A stands for type 1 hypersensitivity, okay? Type 1 hypersensitivity. Second, you see 3 C's. What are the 3 C's? On sputum analysis, you see 3 C's. What are the 3 C's? Creola bodies, then you have Kirschmann spirals and Charcot-Leyden crystals. Very good. I'm so happy you said it, Udayan. Happy that you're still with me. See, we are towards the end and I know you're all tired. I am too, but don't worry, we'll do it. Yay, Patho, come on, let's do it, okay? So, bronchiectasis, what is bronchiectasis? Chronic inflammation and infection leading to permanent dilation. See, emphysema was affecting the sinus, but here it affects the bronchi and bronchioles. So there is a chronic cough, purulent sputum, and there is a toxic cycle of recurrent infection, inflammation, destruction. Recurrent infection, inflammation, destruction. Many causes are there. One of the causes is carcinogenesis syndrome, okay? Bronchiectasis can be caused due to your CFTR gene mutation or carcinogenesis syndrome. Remember, infections like TB as well. Remember, carcinogenesis syndrome is a defect in dynein arm. This was your NEET PG question. And presence with the triad, bronchiectasis, sinusitis, and situs inversus. Okay? Is that clear? These are the images. Go through them. Very, very important. Bronchiectasis, you can see signet ring appearance. HRCT is the investigation of choice. Signet ring appearance can be seen. Okay? Ring appearance can be seen. Look at this question. Solve this question for me. Can anybody solve this question for me? Can anybody solve this question for me? Can anybody solve this question for me? Kishore, good job. Yes. Now, a middle-aged man, what do you see here? There is diffuse interstitial lung fibrosis. So we are going towards restrictive lung diseases. Okay. So what is the problem here? The lung itself has less volume. It cannot take in much air inside itself. You cannot breathe in enough air. Okay. So let's go to restrictive lung diseases. Please remember this question. You can see asbestos bodies or ferruginous bodies. This is seen, this appearance. I'll talk about it. Restrictive lung diseases, most important is pneumoconiosis. Even this time there was a question from silicosis and asbestosis. Both of them are important. Okay. So what are these? The pneumoconiosis are occupational lung diseases. Okay. Out of the three, the most common occupational lung disease is silicosis. Remember, silicosis is associated with sand mining or glass industry, okay? And it involves upper lobes. On X-ray, you can see eggshell calcification, okay? Eggshell calcification. Is that clear? On X-ray, you can see eggshell calcification. What about anthracosis? This anthracosis always reminds me of Delhi. Anybody from Delhi here? You might have seen in Delhi, मतलब up feel हो रहा है वो air का pollution, right? So anthracosis is when you keep on taking in carbon. It can be due to smoking or due to coal worker industry, right? What is the pigment known as that accumulates in the lung due to anthracosis? It's your anthracotic pigment. It is nothing but carbon. Anthracotic pigment, exogenous pigment. Okay? What is Kaplan syndrome? Pneumoconiosis plus rheumatoid arthritis is Kaplan syndrome. It was seen for the first time in anthracosis. Asbestosis, what is it? Which industry? It is associated with? Can anybody tell me? Which industry? Bhavashyat, okay. Yeah, Delhi always will remind me of anthracosis because you get a chronic cough, okay? Asbestosis, which industry? Can anybody tell me? Cement, okay, very good. Shipyard industry, yeah, difficult even, difficult without air purifier. Asbestosis, you have bronchogenic carcinoma, which is the most common, also known as adenocarcinoma, and mesothelioma, which is most specific. Asbestosis is associated with cancer, while TB is associated with your silicosis, okay? TB is associated with silicosis. Here, asbestosis, lower lobes are involved. Everything involves upper lobes, but asbestosis, I always think of it as it involves lower lobes, okay? Now, these are your ferruginous body, which are nothing but hemocentrin-laden bodies, iron-laden bodies, stained with Pearl's Prussian blue. Okay, look at this now. Tell me the answer for this. A 35-year-old male presents with low-grade fever, night sweats and a dry cough for past 2 weeks. See, whenever you think of a cough for more than 2 weeks, what comes in your mind? TB. But now they are telling there is bilateral hyaline lymphadenopathy and there is non-caseating granuloma. See, whenever you talk about TB, there is caseating granuloma, which is the most common presentation. So what must this be? This must be sarcoidosis. Very good. This must be sarcoidosis. Okay? This must be sarcoidosis. Now, sarcoidosis, remember, two bodies are seen. I always write sarcoidosis like this. I remember it like this. Usually common in female. So you imagine a naked female. Okay? Naked female, why? Firstly, it happens in a stree and she's naked. Okay? Because you see naked granuloma. Okay? And she's wearing a star. Okay? Star made up of calcium. Okay? Star. There is a star-shaped and calcium body, right? Known as Shaman body. So you just imagine her wearing a crown of like a star, okay, made up of calcium. All right. Thodi your time. I'll finish it by 8:30. Just a few more slides and we are done. Okay. These are the two bodies that you see in sarcoidosis. Okay. There is increase in vitamin D. Increase in vitamin D, which causes which kind of calcification? Metastatic calcification. Metastatic calcification. Is that clear? Increase in serum calcium. D, also remember, or you can remember it as C. With C, what should you remember? CD4 to CD8 ratio. Because vitamin D, the granulomas, okay, this granulomas synthesize vitamin D, okay. So there is increase in serum calcium. CD4 to, and you know granulomas are formed because of T helper 1 cells. So CD8 to CD4 to CD8 ratio is already high, 2:1 it is. But now it becomes 5:1, Okay, so this increases in sarcoidosis because of the multiple granulomas. Okay, also there is an increase in ACE levels. ACE levels. So this is enough keywords for sarcoidosis. Remember, you have naked granuloma, you are non-cacheating. Remember a woman who's naked wearing a star made up of calcium. Okay, so you can remember this. And what should you also remember? She has a rash, okay, mala rash, but now this involves your nasolabial folds, okay, lupus pernio. It involves your nasolabial fold. Now look at this question that was asked in NEET PG 2024. Can anybody tell me the answer for this? A 55-year-old chronic smoker presents with weight loss, hemoptosis, shows TTF1 positivities. TTF1 is an immunohistochemistry marker for adenocarcinoma of lung. Okay, adenocarcinoma of lung. Please remember, for lung tumors, we have squamous cell carcinoma, adenocarcinoma, small cell carcinoma. Squamous cell and small cell, sir. Why sir? They are central and they are associated with smoking. Okay. Pathogenesis, you have to remember small cell MYC amplification, while when we talk about your squamous, there is loss of P53. Adenocarcinoma, there can be, when you go and learn your oncogenic mutations, EGFR1, KRAS, ALK gene, all these mutations lead to adenocarcinoma of the lung, usually seen in non-smoker, usually peripheral. Okay, while your squamous and small are sir. Central, mostly associated with smokers. Okay, now when we talk about paraneoplastic syndrome, very important, your hypercalcemia, your squamous, right? It shows you calcemia, okay, hypercalcemia. While when we talk about small cell lung carcinoma, it has the maximum number of paraneoplastic syndrome. Keratin pearls and desmosomes are seen in any squamous cell carcinoma. While when we talk about your small cell lung carcinoma, they show small cell, salt and pepper nuclear chromatin, molding, and Azzopardi effect. I'll show you Azzopardi. This is your upper Azzopardi effect, where tumor cells break and fall onto the blood vessels. Okay, so that's why you have this bluish outline on the blood vessels. Is that clear? What are these? These are keratin pearls. Any squamous cell carcinoma will show you keratin pearls. What is the most common lung tumor overall? Adenocarcinoma. Most common associated with smoking, or second most common, it is your squamous cell lung carcinoma. Okay, is that clear? And adenocarcinoma, do you remember? Asbestosis is a risk factor. Okay, now with this we are done with lung. What are we left with? GIT and what do you say? Kidney CVS. Okay, please remember, with respect to GIT, Mallory Weiss tear is there, Bohr-Harvey, you must have done it in your surgery. Mallory Weiss tear, it's a mucosal tear, superficial only, usually happens in young males. While when we talk about Bohr-Harvey, there is a transmural tear. Usually boodo mein hota hai, okay, older generation. And it comes with a triad of chest pain, painful hematemesis, and subcutaneous emphysema. With respect to esophageal cancer, please remember, squamous cell esophagus is the most common cancer overall, is squamous cell carcinoma, affects upper third, middle third, while lower 1/3 has adenocarcinoma. You can see the rat tail, tapering end of the esophagus, rat tail appearance, and filling defects, as well as apple core appearance in esophageal cancer, right? What about Plummer-Vincent syndrome? This is a triad of angular chelosis, esophageal webs, atrophic glossitis, and koilonychia. Okay, IDA. So you can see koilonychia. Again, this was your previous year question, spoon-shaped nails. Okay, spoon-shaped nails. Okay, now with respect to gastritis, pernicious anemia, remember what happens with pernicious anemia? There is your type A gastritis, there is type 2 hypersensitivity, there is antibodies against the parietal cells. So the parietal cells are lost. So there is a decrease in number of parietal cells, leading to atrophic glossitis and immune megaloblastic anemia or pernicious anemia, because vitamin B12 does not get absorbed. Is that clear? Type B is associated to H. pylori, and you can see which stain is this. Can anybody tell me the stain? H. pylori can cause cancer. Which cancer? Most commonly gastric adenocarcinoma, but most specifically maltoma, right? Can anybody tell me which stain is this? Which stain is this? It shows you H. pylori. All these black bacilli are H. pylori, right? Can anybody tell me the stain? This is? All right. Now, when we talk about gastric adenocarcinoma, just remember, you see the most important variant is diffuse variant, okay? And it is associated with, yes, Warden's silvery starry stain. Very good, Kishore Kumar. Yeah. What about, there is loss of E cadherin. We have done this in your neoplasia, right? Leather bottle appearance is seen. This is the leather bottle appearance. And when you take a biopsy, you can see signet ring appearance, where the mucus, okay, the mucus pushes the cells, the mucus pushes the nucleus to the periphery, okay. So nucleus is pushed to the periphery. This is known as signet ring appearance, okay. This is known as signet ring appearance. Is that clear? You can have metastasis of your gastric adenocarcinoma to various places. Virtuous triad is when the metastasis, virtuous node is when the metastasis is to the left supraclavicular lymph node. Sister Mary Joseph is when it is to the periumbilical lymph node, and Krukenberg is any kind of metastasis to the ovary is known as Krukenberg. Okay, all right. Just most common mesenchymal tumor in the stomach is just, okay, origin is cells of Cajal and leads to gastric bleeding. These are the markers, very important. Now, a 12-year-old boy presents with abdominal bloating, foul smell, bulky stool, signs of malabsorption. Serological is positive for HLA-DQ2. What is this? This is your celiac sprue. Okay, this is your celiac sprue. And what should you give in celiac sprue? Low gluten diet, right? Such a simple question, right? So when we talk about yes, all बातें बता दो, पढ़ लो आप, आपको पता है ना, ठीक है? When we talk about malabsorption, we have steatorrhea. What is the presentation? There is steatorrhea, right? And there are 3 types of malabsorption. All of them are very, very important. Okay, all of them are very important. Celiac disease, tropical sprue, and Whipple's disease. Out of that, celiac disease is usually asked. Okay, what happens? There is a polymorphism of HLA-DQ2, DQ8. Because of that, people forget that gluten is normal. What is gluten present in? Gladden, yeah, gluten is present in bro. What is bro? Barley, wheat, rice, oats. So what is formed? Antibodies are formed against this gluten. Which antibodies? Transglutaminase IgA antibody, anti-TTG, anti-gladden, anti-endomycin antibody. Okay, please remember, antibodies are very important. What happens? See, celiac disease usually affects the duodenum. Okay, duodenum. So what happens in the duodenum? You have the villi, right? Because antibodies are formed against this, there is villus atrophy. You can see the villi becomes flattened. Okay, there is villus atrophy. Is that clear? Villus atrophy. And can you see this crypt? How is your body reacting? By increasing crypt. You can see the number of crypt have increased. So crypt hyperplasia. Okay, and because you are stimulating CD4 T cells continuously, there is increase in intraepithelial lymphocytes. There is increased in intraepithelial lymphocytes. Okay, so these are the things that are seen in celiac disease. All right, villus atrophy very, very frequently given. Avoid bro. How do you treat this patient? Avoid bro. give immunosuppressive. What about Whipple's disease? Whipple's and tropical are both infective causes, while celiac is immunological, right? Whipple's present with extraintestinal manifestation because what happens? It is an infection with Trophirema whipplei, and macrophages eat them, but they're not able to destroy them. So they start filling up with these Trophirema whipplei, okay? And they start, congesting the lamina propria, due to which there is a defect in lymphatic transport of fats, okay? Lymphatic transport of fats. So this leads to PAS positive and diastase sensitive macrophages in the lamina propria. Is that clear? Okay. PAS positive. Where are the extraintestinal? Now these macrophages go everywhere, so they can infect they can involve the CNS, or they can involve the heart. Okay, so there are extraintestinal manifestations also. Pseudomembranous colitis, what should you just remember? The cause, Clostridium difficile. Okay, so due to cephalosporin use, all right, antibiotic therapy. Amoebic ulcer, what kind of ulcer is there? Flask-shaped ulcer. Okay, flask-shaped ulcer. Diastase resistant, sorry, this is diastase resistant. PAS positive and diastase sensitive is glycogen. Diastase resistant is your macrophages here, okay? All right, now when we talk about inflammatory bowel disease, you have Crohn's disease and ulcerative colitis. What should you remember? Ulcerative affects the terminal ileum. We have just discussed this, right? What about ulcerative colitis? It starts retrograde. Okay, it starts retrograde. Ulcerative colitis only affects the mucosa and submucosa, while your Crohn's disease affects the mucosa, submucosa, all the layers. It's transmural, okay? It affects all the layer. MC, MS, MC, right? MS-MC, mucosa, submucosa, MS, sorry. Your muscularis and your serosa, it affects all the layers. Now, it goes through all the layers, okay? And that is why it can form fistulas. It can form deep fissures, Crohn's disease, because it is transmural. Also remember, it can appear anywhere. So skip lesions are seen. It's not continuous. While when we talk about ulcerative, it is continuous. Okay? It is associated with P-ANCA antibody. No granulomas are formed here, while granulomas are a hallmark of Crohn's disease, non-caseating granulomas. Okay? So very, very important. Calprotectin is seen in both ulcerative as well as Crohn's disease. So you can see a lot of polyps. These are nothing but pseudopolyps. Pseudopolyps that are, why do you call it pseudopolyps? Because ulcerative colitis involves only the mucosa and submucosa, right? While a true polyp involves all layers. So here you can see crypt abscesses, neutrophilic crypt abscesses, which is present in both. And lead pipe appearance because of continuous inflammation. So lead pipe appearance, this is seen in ulcerative colitis. While when we talk about, this must be a granuloma, okay? Granuloma is present in Crohn's disease along with creeping fat. And all these lesions, please remember, they heal with fibrosis. So that's why strictures are formed, okay? You have skip lesions, then strictures. This is known as the string of Cantor. This is known as string of Cantor. Smoking is protective for ulcerative colitis. क्या करोगे? Smoking से बहुत कुछ खराब भी होता है, ठीक है? So what is the point of smoking being protective, right? Okay. Child with painless rectal bleeding, prolapsing mass, cystically dilated gland. What is the most likely diagnosis? So this is actually juvenile polyp. Okay, juvenile polyp. It's a hematomatous polyp. Let's go to polyps. Remember, your juvenile polyp is when the age is less than 5 years and painless bleeding is there, and there is presence of hematomatous polyps. Which mutation? MAD4 and 2 mutation. What about Cowden? It is P10 on chromosome 10. Okay. Peutz-Jeghers is STK11 mutation, most commonly seen in jejunum and perioral melanosis. Perioral hyperpigmentation. Okay. Hyperpigmentation. This is very famous, I think. Very famous. And Christmas tree appearance is seen, right? Familial adenomatous polyps, very important. More than 100 polyps, 100% risk of colon cancer, okay? Associated with APC mutation on chromosome 5, right? This image has come for the exam. HNPCC, we have already done. This is autosomal dominant due to DNA mismatch repair genes. MSH2, MLH1, okay? High risk of colon cancer. This is colon cancer without polyps, right? Because of DNA mismatch repair genes. Colon cancer, now adenocarcinoma of colon cancer, what is the risk? Definitely it involves HNPC, FAP, smoking, tumor marker, very important, CEA plus gene mutation in a sequence, KRAS, your APC and P53, okay? Look at these questions now. We are done with GIT. Let's continue. This is enough. Okay. All right. Look at this now. Liver. Let's go to liver, kidney and CNS. We are just ending. Okay. Thank you. Okay. So when you look at this, see a 55-year-old man with hepatomegaly, dark skin. Okay, despite no sun exposure, liver histology shows brown pigment. What is this? This must be hemochromatosis. So dark skin without, so bronze skin along with diabetes plus cirrhosis. What is this? A triad of hemochromatosis, right? It is a triad of hemochromatosis. Is that clear? Then second, a patient presents with jaundice shows elevated unconjugated bilirubin, normal liver enzymes and normal conjugated bilirubin. Which of the following best explains the following? See, there is elevation of unconjugated bilirubin. You can go see doctor. Always remember this mnemonic. Unconjugated bilirubin increases in Crigler, Najjar and Gilbert syndrome, while your conjugated bilirubin increases in Dubin and Rotor syndrome. So what is the answer? You have shows isolated elevation of unconjugated bilirubin. Which of the following best explains? See, if the patient is Crigler Najjar, you have, what is it? Is it A ya Gilbert? Is it A ya Gilbert? So it can be both A or Gilbert, right? Because what is it? What are they? They are both unconjugated. What about this question? What about this question? So if you have to choose isolated, Crigler Najjar, the type 1 is fatal, while Gilbert can present. Okay, I will choose Gilbert. What about this? A patient with suspected viral hepatitis undergoes serological testing. Which marker is positive? Strongly indicates high infectivity and active viral replication. This was a previous year question asked just now in FMGE 2024. What is the replication marker? HBE. So which is S? It is the surface antigen. First one to arrive, right? IgM, this is core antibody. This is core antibody, right? Antibody. The one that arrives in acute hepatitis. Okay. Now you have a patient that presents with fatigue and jaundice. Serology reveals HBsAg positive, IgM and anti-HBC positive. Which of the following is most accurate interpretation? So see, surface antigen means there is an infection ongoing and they are telling you IgM is present. IgM is for acute hepatitis, right? So which is this? Acute hepatitis B. Okay, chronic IgG will be present. Resolved, there will be no surface antigen present. Okay, and immunization, there will be no exposure to surface antigen. Is that clear? So with respect to liver, Mallory dengue we have done. Acute hepatitis, this is ground glass appearance seen in ground glass appearance of hepatocytes seen in hepatitis B. Okay, hepatitis B infections, right? So go through this table, very, very important. I just want you to remember, when we talk about hep B, always remember your surface antigen is the first one to arrive, which is the antibody against it, anti-HBs. When will anti-HBs be present? Whenever you have vaccination and recovery. What about HBC antigen? It never arrives in the blood. So how do we know this antigen is there? Because you have antibodies against it. Which antibodies? HBC, anti-core antibodies, okay? Anti-HBC antibodies. Which two? IgM, yeah, IgG. IgM points toward acute hepatitis, while IgG points to chronic, okay? Remember, acute is present in the window period. Okay, window period where there is no surface antigen or surface, anti-HBs or HBs AG. What about HBEG? This is the marker for replication या infectivity. Remember, the antibody against it is anti-HBE. So anti-HBE tells you that this patient is fine, has low infectivity or good immunity. Either one can be present, both cannot be present together. Is that clear? Is that clear? Go through this. Very, very important for the exam. You must have done it in micro as well. Okay. Now, what are the causes of hyperbilirubinemia? Like I told you, there can be conjugated or unconjugated. When we talk about conjugated, with genetic defects, you have type 1 and type 2. Crigler-Najjar syndrome. Absence of 100% UGT leads to Crigler-Najjar type 1. Okay, type 2 is reduced activity and type 3 is a mild deficiency, which is nothing but Gilbert. Gilbert syndrome is what? Mild deficiency of UGT. Only during stress there will be jaundice, okay? While type 1, it is 100% fatal. This patient will die. That's why I choose the answer to be Gilbert, because usually Crigler-Najjar syndrome, patients die, okay? Now, conjugated hyperbilirubinemia includes Dubin-Johnson and Rotor. What about Dubin-Johnson? There is an accumulation of, this is a defect in MRP2 and you see dark pigmented liver. While when we talk about Rotor, there is ATP transport protein defect and you see non-pigmented liver. Go through this, important, okay? Now, biliary diseases that can lead to, conjugation, hyperbilirubinemia. One is primary sclerosing cholangitis and primary biliary cholangitis. Please remember, primary, I always used to remember it as sir. Why? Primary sclerosing means hard, okay, hard. And I used to remember this as mard ko dard. Okay, hardening of the tissue, right? कौन hard होता है? मर्द. और मर्द को क्या नहीं होता? दर्द. Okay. So why is this important? Because this is present, primary sclerosing is present in males, okay, young males, and it is strictures that are present in both intrahepatic and extrahepatic ducts, okay. Age of presentation is 30 years. It is associated with ulcerative colitis, okay, ulcerative colitis, and P-ANCA antibody positive. We have already done that in ulcerative colitis, I think, okay, most commonly. So whenever you think of PSC, always think of a hatta-katta man coming towards you and very hot, very handsome, okay? But the minute he opens his mouth, he says, sir. Why sir? Sclerosing presents with onion skinning, okay? Another appearance that you see is onion skinning. Onion skinning. और मर्द कहाँ होता है? अंदर भी बाहर भी, okay? So it affects both intrahepatic as well as extrahepatic ducts, okay, bile ducts. Is that clear? So there is bile duct, around that there is fibrosis that presents with onion skinning. Okay, fibrosis is present around the bile duct. Okay, is that clear? Now metabolic diseases of liver we have already done. Okay, renal system, go through the notes. These are your what do you say, stones as well as your cast. Nephritic and nephrotic, see, when we talk about nephritic, look at this, a middle-aged man with hematuria, pedal edema, high creatinine and crescent on biopsy. Which condition? This was asked in NEET PG. Okay, so when we talk about a middle-aged man, please remember there is hematuria, there is high creatinine and crescent on biopsy. Where did you see it? Remember good pastures syndrome, good pastures syndrome has hematuria. Good pastures is nothing but type 1 RPGN. What is it? Type 1 RPGN. So it presents with crescents and it affects lung, leading to hemoptysis and hematuria. Why? It is a type 2 hypersensitivity. Type 2 hypersensitivity. So antibody against alpha 3 chains of type 4 collagen, right? So anti-GBM antibodies. Now with respect to nephritic, nephritic, remember hematuria is most important because there is inflammation of your glomerulus, while nephrotic affects the podocytes. Okay, so protein goes out more than 3.5 gram per day. Okay, more than 3.5 gram per day. Very, very important. The urine is frothy, while nephritic you see cola colored urine. Okay, so nephritic syndrome. What are the different nephritic syndromes? You have PSGN, IgA, Alport syndrome. All right. PSGN most common in children, and this is a type, yes, most common in children, and group A beta hemolytic streptococcus affects it, right? Now please remember, starry sky appearance is seen. PSGN I can show you. You can see subepithelial humps. Subepithelial humps. Okay, subepithelial humps are seen. The immune complex deposit under the podocytes. Okay, under the podocytes. Is that clear? Subepithelial humps are seen. So your what makes your, can anybody tell me what is your filtration slit formed by? You have endothelial cells and then basement membrane and visceral epithelial cells. Okay, visceral epithelial cells. Okay, which is nothing but your podocytes, right? This is forming your filtration slit, right? So in PSGN we have hypercellular glomeruli as well as subepithelial humps and starry sky on immunofluorescence. It's all given here. Okay, IgA nephropathy. See, it is the most common nephritic syndrome in adults. Okay, it is also known as Berger's disease, and immune complex deposit in the mesangium here. Recurrent hematuria happens 3 to 4 days after some infection. Okay, what about RPGN? There are 3 types of RPGN, and the first type is good pasture syndrome. Immune complex we have already done. So out of this, what is what do you say? Water image. This is crescent. More the crescents, bad prognosis. Okay, more crescents, poor prognosis. Okay, with respect to nephrotic syndrome, please remember there are 3 kinds of nephrotic syndrome: minimal change disease, then you have your FSGS and your membranous nephropathy. These 3 are dependent on age. When we talk about minimal change disease, this is seen in 2 to 6 years old children, while focal segmental glomerulosclerosis is most common in adults, while in elderly you have membranous nephropathy. Okay, yes, okay, membranous nephropathy. Now when we talk about minimal change disease, when you look at histology, it's normal, but on electron microscopy, you'll be able to see effacement of podocytes, okay? While when we talk about focal segmental glom, go through the causes, okay? Go through the causes. With membranous proliferative glomerulonephropathy, remember you see tram track appearance. I'll show it to you. See, this is minimal change disease where you see effacement of podocytes here. This is your FSGS where there is sclerosis, okay, focal segmental glomerulosclerosis, and here MPGN type 1, you see tram track appearance. You can see tram track appearance. The basement membrane is split, okay, tram track appearance. All keywords are given, okay. What about this? This is in membranous nephropathy, you see spike and dome pattern, spike and dome pattern. While when you look at this, you can see nodular glomerulosclerosis, right? This is your Kimmelstein-Wilson lesion where you have nodular glomerulosclerosis. Okay? Okay. With respect to renal tumors, the most important are Wilms and your RCC. Remember, one question that was asked in NEET PG was VHL gene deletion. Okay, VHL von Hippel-Lindau syndrome. It is associated with 3P gene deletion, and it presents with hemangioblastomas, right? Retinal hemangioblastomas, cerebral hemangioblastomas. You have an increase in vessels, right? Along with clear cell renal carcinoma. What about Wilms tumor? It is nothing but a triphasic tumor, nephroblastoma, and it presents with abdominal mass, hematuria, and fever. Remember, it is 2 to 6 years. Less than 2 years will be nephroblastoma. Okay? Less than 2 years will be neuroblastoma. With respect to CNS, go through the notes. These are the notes. And one question that was asked recently was amyotrophic lateral sclerosis. Alzheimer's, you have an increase of A beta amyloid. We've just discussed it. It is associated with Down syndrome, right? And what do you see in Alzheimer's? You see this neurotic plaque, on BL-Schosky stain, neurofibrillary tangles, and Hirano bodies. Okay. What about this? This is nothing but your Lewy body, which is seen in Parkinson's. Okay, this is seen in Parkinson's. Right? Parkinson's. So what is the triad of Parkinson's? You have bradykinesia, Cogwheel rigidity, and tremors. Okay. What do you have? Increase in alpha-synuclein. Okay, overexpression of alpha-synuclein. This is your Lewy body. This one is your Lewy body. That is the pink deposition of alpha-synuclein. With respect to CNS tumors, see glioblastomas, go through them. You have your grade astrocytoma, oligodendroglioma, ependymoma. We have already discussed ependymoma. It is associated with NF2, and you see perivascular pseudorosets. I've told you, astrocytoma, always think of a child that is very happy and holding a rose and very, very good. Okay, so you see it in a child, a good child with good prognosis. You can just remove it. It's a slow growing tumor. Okay, with a cerebral mass, cystic mass, okay? And on histology, you see Rosenthal fibers, okay? You see Rosenthal, okay, Rosenthal fibers. Grade 4 astrocytoma, this is very bad prognosis, glioblastoma multiforme. It's the most common malignant tumor in adults, and this has very bad prognosis. So it's like you can see serpentine necrosis, okay? Pseudopelliciding cells along with serpentine necrosis, okay? Serpentine necrosis. While with meningioma, what should you remember? You should remember Samoma bodies. I've already discussed it with you. And miss me, multiple inherited schwannomas, meningiomas, and yours, ependymomas. They are associated with NF2, okay? Schwannomas, they are peripheral nerve sheath tumors. You have Antony A, Verrucke, and Antony B areas, very, very important. Medulloblastoma, grade 4, it is a malignant tumor in cerebellum. But you should remember what is seen homerite pseudorosets that we have already discussed is present in Ewing's neuroblastoma and medulloblastoma. With respect to endocrine, see, the only thing you should remember is that thyroid gland, like with respect to pathology, the most important is the cancers. So you have papillary thyroid carcinoma, follicular thyroid carcinoma, and medullary thyroid carcinoma, which was asked recently. Papillary thyroid, very, very, very important. Follicular, also, what was the question? Please remember, with respect to follicular, see, what happens? You can see capsular invasion. Okay, you can see tumor cells invading the capsule. Okay, tumor cells invading capsules. So how can you differentiate? FNEC is not useful. That is why FNEC is not useful in follicular. Okay. Why? Because FNEC sees the cell's cytology, the nuclear changes, but I cannot tell whether invasion has happened or not. So biopsy is important, right? Invasion will only differentiate between follicular adenoma and follicular carcinoma. So FNEC is not useful. This was a question that was asked. Second, the spread is hematogenous and KRAS mutation is seen. What about papillary thyroid carcinoma? Remember, it is mostly associated with exposure, radiation exposure. Okay, history of radiation exposure during childhood. And what do you see? Two very, very solid appearances, which is 2 minutes, which is your orphan Annie eye appearance. Okay, orphan Annie eye, where you see the glassy nuclei. Okay, these glassy nuclei, and okay, orphan Annie nuclei and coffee bean appearance. Can you see this coffee bean appearance like this? Okay, coffee bean appearance. Coffee bean appearance. Now, how is this spread? Lymphatic and genetic. This was asked recently in NEET PG 2024. What mutation is seen? BRAF mutation. Okay, papillary thyroid carcinoma. Also, which other body do you see? Papillary thyroid carcinoma. Can anybody tell me? We are just towards the end. Okay, which body? Can you tell me? Which body? Samoma bodies. Okay, Samoma bodies. Very good. Samoma body. Good, good. Samoma bodies are also seen, right? What about medullary thyroid carcinoma? So there is extracellular accumulation of calcitonin, right? So you will see pink amorphous. What was the question that was asked in the exam? Pink amorphous extracellular deposition. Extracellular deposition. Okay, of what? Of amyloid. Okay, so which kind of amyloid? ACAL. Okay, because you have this is a tumor of parafollicular C cells, so calcitonin will increase and it can misfold into ACAL. Is that clear? So amyloid, please remember this was a question asked. What is the mutation? RET. And what is the tumor marker? Calcitonin. Okay, calcitonin. Is that clear? Now, with respect to male and female genital tracts, you have granulosa cell tumor. What do you see? You see Kohl-Exner bodies. This is seen in postmenopausal or precocious puberty. Okay, FOX L2 mutation is seen and increase in estrogen. And what marker is there? Inhibin B. Kohl-Exner bodies. Okay, coffee bean nuclei is there. I'm sorry, there is something pink in the center, and coffee bean nuclei is around them. Okay, this is your coffee bean nuclei. You can see coffee bean. All these cells have coffee bean nuclei, just like your papillary thyroid. Yolk sac tumor, you have an increase of AFP. We have already discussed it. Okay, and which bodies do you see? Schiller-Duval bodies. Okay, so you have a blood vessel, surrounding that are tumor cells, surrounding that are cystic spaces. Seminoma, the marker, what is the marker? You can have beta-hCG, increase in beta-hCG. Remember, AFP is always normal, and seminoma is seen. Where is it seen? In, what do you say? young adults or middle-aged adults. And this was the question that was asked. It looks like a potato appearance, right? Yes, PLAP also. Yes, very good. With this, we are done with our rapid revision. Okay, with this, we are done with our rapid revision. Seminoma, please remember the appearance, please remember the tumor marker. And remember, this is a radiosensitive tumor. It happens in males, okay? With this, we are done with the rapid revision. Thank you, guys. Please remember, every slide tells a story, just like your efforts today are shaping the narrative of your success. Best of luck for the exam, and I really, really hope you can, you can clear the exam with flying colors, okay? I really hope for that. Best of luck. If you have any doubts, you can always reach me with on Instagram, which is Dr. Sara K27, okay? So you can, this is my Instagram ID, you can always reach me there, all right? Take care, guys. I'll send you the annotated notes. Bye. Yes, this is enough. This is enough. Bye. Take care. Thank you.